Morning, everyone. Can we please have your attention? I request all our guests to kindly please be seated. Good morning, everyone, and a warm welcome to all at the 4th edition of Cancer Summit, an initiative by Integrated Health and Wellbeing Council and Rapid Global Cancer Alliance. Integrated Health and Wellbeing Council is India's premier institution for holistic health awareness, advocacy, and behavior change. The council works through a series of initiatives to open new platforms and forums where healthcare leaders, experts, policymakers, community leaders, and common citizens come together for fruitful engagements and collaborations for facilitating holistic health and well-being to all. It works towards creating awareness and advocacy for a healthier, happier world with the core belief that health is everyone's responsibility. Rapid Global Cancer Alliance is an initiative hinged on the principles of realize, act now, practice, inform, and defeat, to respond to the country's holistic fight against cancer by improving cancer outcomes for all patients. Cancer exerts enormous pressure on healthcare infrastructures around the globe and is among the leading causes of death worldwide. A rapid approach that addresses the gap and challenges in cancer care, along with policy regulations, screening opportunities, and accessible and affordable cancer treatment is the need of the hour to ensure that we are able to control the menace of cancer and bring down the numbers considerably and effectively. It is with this line of thought that the IHW Council envisioned the Cancer Summit. The goal is not only to create relevant awareness on the symptoms, screening, diagnosis, and treatment for cancer, but to also provide a platform where all relevant partners can come together to deliberate on the challenges and come up with concrete actions and suggestions to overcome them. Tomorrow is the World Cancer Day, a day that calls for integrated action and awareness on cancer. The theme for this year is Close the Care Gap, considering the unavailability and unequal access to cancer care world over. The theme for 2023 is to ensure that people have access to cancer care irrespective of their race, gender, economic background, and ethnicity. We are hopeful that coming years will witness the shift towards a more patient-centric approach along with capacity and skill building of healthcare resources, accelerating innovation and technology, thus favorably impacting the patient and caregiver outcomes in cancer, while also creating awareness on risk factors and symptoms, thus facilitating early diagnosis and treatment, which is an essential game changer as it substantially brings down the mortality rate and also the cost involved in treatment of the disease. Hence, multifold awareness along with capacity building of medical professionals and caregivers is sure to yield positive results. With this hope and thought process, let's start the proceedings of the 4th edition of the Cancer Summit. I would like to invite Mr. Kamal Narayan, CEO of IHW Council, for his opening remarks. Please put your hands together for Mr. Kamal Narayan, the man behind this. A very, very warm welcome to you, sir.
Thank you so much. Is it working? Am I audible? So thank you so much, and I welcome you all to this 4th edition of Cancer Summit. Since our anchor for the program has already spoken a lot of English around cancer. So I would rather take, the Hindi route now to talk about this problem. कैंसर हमारे देश में एक इतनी बड़ी चुनौती के रूप में सामने आया है और शायद ये चुनौती हम समय के साथ उसकी गंभीरता को समझ भी नहीं पाए। अगर कोविड-19 जैसी चुनौतियों को देखें जो कि पिछले 3 सालों में भारत की और ना कि सिर्फ भारत की, पूरी दुनिया की जो रिसोर्सेज, प्लानिंग, स्ट्रेटजीज और विल पावर जहां पर लगी वो था कोविड को कैसे रोका जाए, कोविड से कैसे लोगों को बचाया जाए और कम से कम जो है जीवन की हानि को होने दिया जाए। लेकिन अगर देखें जो कोविड के पहले भी था, कोविड के समय भी था, कोविड के बाद भी है और कोविड के आगे शायद और बढ़ता जाना है, ऐसी एक समस्या कैंसर जो शायद आज से कुछ सालों पहले या मैं कहूं कि एक आध डिकेड्स पहले एक ऐसी चीज थी जो शायद किसी को होती थी। मैंने शायद अपने स्कूल डेज में या कॉलेज डेज में भी कैंसर की बीमारी को ऐसा नहीं देखा था कि वो आपके आसपास हो रही है। किसी को दूर कभी एक आध केस सुनने में आते थे, लेकिन आज मुझे लगता है जितने लोग यहाँ पर बैठे हुए हैं और बहुत सारे लोग जो सोशल मीडिया के थ्रू या लाइव भी इस प्रोग्राम को देख रहे हैं, और सारे लोग जिस तरीके से कोविड कोई ऐसा नहीं था जो उससे बचा हो। अगर इन्फेक्टेड नहीं हुआ तो इम्पैक्टेड जरूर हुआ। आई थिंक कैंसर भी उसी तरीके, शायद हम सभी किसी ना किसी तरीके से उससे अगर सीधे तौर पे परेशान नहीं है तो कहीं ना कहीं इम्पैक्टेड जरूर हो रहे हैं। और अगर नहीं हो रहे हैं तो जिस तरीके से हमारे चारों ओर का माहौल है या जो एनवायरमेंटल फैक्टर्स हैं या जो सोशल फैक्टर्स हैं, शायद हम सभी उसी रास्ते पे आगे बढ़ रहे हैं। हम लोग ऐसे शहर में रहते हैं, दिल्ली में, जहां पर AQI 300-400 से नीचे तो शायद ही कभी आती हो, और कभी आती है तो बहुत अच्छे दिन होते हैं। ISW काउंसिल की जो फिलॉसफी है, ये जो वर्क है, वो 5 इंपॉर्टेंट पिलर्स पर टिका हुआ है, या वो पिलर्स हम सोचते हैं कि वो एक स्वस्थ और हेल्दी जीवन को बनाने की बहुत इंपॉर्टेंट प्री कंडीशंस हैं। तो गुड एयर, गुड फूड, गुड वाटर, गुड लाइफ एंड देन गुड हेल्थ केयर, ये 4 पहले के फैक्टर्स हैं। वो कहीं ना कहीं से, जब मैं बहुत सारे कैंसर के एक्सपर्ट्स, मैं एक्सपर्ट नहीं हूं और डॉक्टर भी नहीं हूं, हमारे साथ कैंसर के भारत में जो कैंसर केयर को स्ट्रेंथन करने के, कैंसर केयर को लोगों तक पहुंचाने के ऐसे दिग्गज बैठे हुए हैं, और बहुत सारे लोग ड्यूरिंग द डे भी ज्वाइन करेंगे, आएंगे। तो मैं एक्सपर्ट ना होते हुए मुझे ये जरूर लगता है कि जिससे भी मैंने बात की तो उन्होंने कुछ ये बहुत इंपॉर्टेंट बातें बताई कि जो हमारी हवा है जिसमें हम सांस ले रहे हैं, दिल्ली जैसे शहरों, और सिर्फ दिल्ली नहीं, मैं अभी बीच में बहुत बार मुंबई में था और मुंबई में कई सारे कामों में के बीच में, तो वहां की भी AQI 200-250 से कम नहीं थी। पहले मुझे लगता था कि नरीमन पॉइंट में बैठने पर जब ये जो सी ब्रीज आ रही है तो सबसे शुद्ध हवा फेफड़ों में जा रही है, लेकिन मुंबई की भी AQI मोस्ट ऑफ द एरियाज में 200-250 से ज्यादा ही थी, जो कि 4 गुना पॉल्यूटेड है WHO के आई थिंक जो मानक स्टैंडर्ड्स हैं। तो जब हवा, जब जहां आप सांस ले रहे हैं, जिस पे आप सांस ले रहे हैं, जो खाना आप खा रहे हैं, जो पानी आप पी रहे हैं, या जिस तरीके की जीवनचर्या आप जी रहे हैं, जिस तरीके की लाइफ स्टाइल आप जी रहे हैं, जब वो आपको बीमार करने लगे तो हॉस्पिटल और डॉक्टर्स पर ना सिर्फ जो है बहुत ज्यादा बर्डन बढ़ता है, और बल्कि आपके अपने जीवन में भी बहुत सारी जो स्ट्रेस बनते हैं, चाहे वो फिनेंशियल स्ट्रेस हो, चाहे वो इमोशनल स्ट्रेस हो, चाहे वो सोशल स्ट्रेस हो। तो आईएसडब्ल्यू काउंसिल का जो प्रयास और प्रयत्न रहा है कि कैसे इन इंपॉर्टेंट फंडामेंटल्स को सॉल्व करें। लेकिन सिर्फ इंपॉर्टेंट फंडामेंटल्स को सॉल्व करने से ही दुनिया स्वस्थ हो जाएगी या स्वस्थ बनी रहेगी, ऐसा जरूरी नहीं है। तो ये भी जरूरी है कि हेल्थ केयर और हेल्थ सिस्टम को कैसे स्ट्रेंथन करना है, ये कैसे किया जा सकता है। और उसके लिए हमारे देश में हजारों लाखों लोग बहुत अच्छा काम कर रहे हैं, बहुत लेवल पे काम कर रहे हैं और पैशनेटली काम कर रहे हैं कि इसको कैसे ठीक किया जा सकता है। अगर इसका एक बहुत बड़ा एग्जाम्पल है कि कोविड-19 में जो हमने अचीव किया, जिस तरीके का रिस्पांस हमने इस्टेब्लिश किया, जिस तरीके का रिस्पांस हमने दिया उस महामारी को या उस डिजास्टर को या कैलामिटी को, वो अपने आप में एक एग्जाम्पल है कि समस्या कितनी भी बड़ी हो, अगर आपके अंदर इच्छा शक्ति और विल पावर है तो आप उसको अच्छे से हैंडल और उसका समाधान निकाल सकते हैं। मैं अभी ये प्रोग्राम शुरू होने के पहले कुछ एक्सपर्ट्स से बात कर रहा था, उनकी बातें सुन रहा था। तो सबसे बड़ी जो बात मुझे फीलिंग हुई कि वो ये थी कि कैंसर में कुछ भी नहीं हो सकता या हो नहीं रहा, या लोग कर रहे हैं तो बहुत आइसोलेटेड तरीके से कर रहे हैं। कैंसर एज अ केयर का जो पूरा इकोसिस्टम है, उसको बनाने, सुधारने या उसको इम्प्रोवाइज करने के लिए जो काम करने की जरूरत है, उस पर किसी का इंटरेस्ट उतना है ही नहीं। तो मेरा मानना है कि ऐसा हो सकता है कि हमारा इंटरेस्ट या बहुत सारे उन लोगों का इंटरेस्ट जिनको उस पर इंटरेस्ट लेना चाहिए। ये जगह आज हम जहां बैठे हुए हैं, एक बड़ी इंटरेस्टिंग जगह है। यहाँ पर देश के लॉ मेकर्स, पॉलिसी मेकर्स बैठ करके बहुत सारे डिस्कशंस भी करते हैं, चर्चा भी करते हैं, गपशप भी करते हैं, कॉफी भी पीते हैं, जिम भी जाते हैं। कॉन्स्टिट्यूशन क्लब है ये क्लब, एक्सक्लूसिवली मेंट फॉर द मेंबर्स ऑफ पार्लियामेंट, एंड दीज आर द पीपल जो हमारे देश के भाग्य विधाता हैं। सेशन चल रहा है, अभी बजट भी पास हुआ है, यो बजट पेश हुआ है, तो उस पर बहुत सारे डिस्कशन होने, बहुत सारी चीजें करने की कोशिश की है। एक एटलीस्ट एक बहुत इंपॉर्टेंट काम जो इस बार कैंसर के प्रिवेंशन के स्पेस में माना जा सकता है कि सिगरेट्स और महंगी हो गई हैं, शायद स्मोकिंग का लेवल थोड़ा और कम होगा। हालांकि जब महंगी सिगरेट्स होती हैं तो लोगों की आय भी बढ़ रही है उस हिसाब से, तो शायद सिगरेट की अफोर्डेबिलिटी इतना बड़ा प्रॉब्लम है नहीं। तो सिगरेट महंगी करने से सिर्फ काम चलेगा या सिगरेट को बैन करने से काम चलेगा, या जैसे न्यूजीलैंड का एक अभी एग्जाम्पल कि उन्होंने 18 ईयर के बाद सिगरेट एब्सोल्युटली बैन कर दिया है। मींस नेक्स्ट जनरेशन विल नॉट हैव एक्सेस टू द टोबैको मोस्ट लाइकली। तो ऐसे बहुत सारी जो पॉलिसी के काम है या जो डिसीजन मेकिंग के काम है, जिनका काम है ये करना, शायद उनको अभी कैंसर की जो विविधता है या जो कैंसर की जो इंटेंसिटी है जिस प्रॉब्लम की, उसका रियलाइजेशन नहीं हुआ। और कुछ लेवल पे वो रियलाइजेशन देखने को भी मिल रहा है। हम सभी ने देखा है कि अभी प्रधानमंत्री ने बहुत ज्यादा जो है एक अच्छा स्टेप लिया है कि जो एचपीवी वैक्सीन है वो सबको मिलेगी, सब तक पहुंचेगी। एवरी गर्ल विल गेट एचपीवी वैक्सीन। So, and we have got an affordable HPV vaccine now rolled out already by the Serum Institute. तो कुछ ना कुछ कहीं ना कहीं हो रहा है, बहुत कुछ करने की जरूरत है। जब आप वो ये रियलाइजेशन आ जाएगा कि कोविड के 2-2.5 साल के टाइम पे शायद जो जीवन की हानि थी, वो भारत सरकार का जो ऑफिशियल नंबर है करीबन 5.5 लाख लोग भारत में जो है उन्होंने जीवन खोया। लेकिन कैंसर से हर साल 8.5 लाख या 8 लाख लोग मर रहे हैं, और ये वो डेटा है जो कि ऑफिशियल डेटा है। तो जब हर साल इस लेवल का लॉस ऑफ लाइफ, और लॉस ऑफ लाइफ ही नहीं है, ये बहुत बड़ा एक अपने आप में डिजास्टर है। वो एक जीवन जो उससे खो रहा है, वो बहुत सारी और जिंदगियों को भी इम्पैक्ट कर रहा है। परिवार, फैमिलीज पॉवर्टी में जा रहे हैं। बहुत सारे लोग अपने यंग डियर्स और नियर वन को खोते हैं। तो इसका एक पूरा सोशल, इमोशनल बहुत बड़ा बर्डन है। तो इम्पॉर्टेंट ये है कि हम सब साथ मिल करके अपनी आवाज को कैसे इतना बुलंद कर सकते हैं कि जहां हमको लगता है कि आवाज नहीं पहुंच रही, वहां तक वो आवाज पहुंचना शुरू करे। और शायद इसीलिए आज हमने सोचा कि कम से कम अगर उस आवाज को उनके कानों तक उस तरीके नहीं पहुंचा पाए, तो कम से कम फिजिकली इतने नजदीक ले आते हैं कि शायद सुनाई दे जाए। तो इसी के साथ मुझे लगता है कि आज का जो कैंसर समिट का ये 4th एडिशन है, आज जो बहुत सारे कैंसर के डिफरेंट एस्पेक्ट्स, डिफरेंट इस जो स्पेशलिटी के लोग आज हमारे साथ आएंगे। वी विल डिस्कस अबाउट the various strategies, modalities, way forward, how to make a strong and effective response to this not emerging threat. It's a threat, it's a big threat, it's only getting intenser. So with this, I welcome you all again for this 4th edition of Cancer Summit, and looking forward to hear a lot of insights, see the work which various stakeholders have been doing. And we are also, during the evening at the conclusion of this program, are going to recognize some of those work which has been identified by our, esteemed jury for the Cancer, Care Awards, which we have kind of initiated from this 4th edition of Cancer Summit. So I look forward for your cooperation, your participation, and your contribution towards making cancer, India a cancer free, if we can really achieve it, or at least a country which manages cancer well. Thank you so much.
Thank you so much, Mr. Narayan, for your words and also for making this happen. Now, to grace the event with his inspiring presence, I'd like to call upon stage Dr. G.K. Rath, former head, National Cancer Institute, India, one of India's most illustrious oncologists. He pioneered the current governmental cancer care infrastructure revamp in India. Please put your hands together for Dr. G.K. Rath. Good morning. Thank you so much for coming.
मॉर्निंग। कमल जी ने जो बोला मैं उसके साथ पूरी तरह सहमत हूं। और कैंसर की जो स्टोरी है कुछ अच्छी है, कुछ इतनी अच्छी नहीं है, लेकिन मैं तो ऑलवेज बोलता हूं कैंसर इज ए फैंटास्टिक डिजीज। इससे बढ़िया कोई डिजीज नहीं। ट्रीट भी करना, अपने को होना भी। अगर कोई बोले, भगवान बोले कि आपको बीमारी चाहिए, मैं तो डायबिटीज कभी नहीं लूंगा, बीपी कभी नहीं लूंगा। रोज इंजेक्शन लेते रहो, इधर उधर 2 रसगुल्ला एक्स्ट्रा खा लिया तो 4 चक्कर लगाओ। कैंसर इज लाइक ए 1 डे क्रिकेट मैच। या तो कैंसर फिनिशेस यू और यू फिनिश द कैंसर। एंड इफ Upperwala is with you, you can ask for prostate cancer where the stage 1 and 2 may cure it is 100%. Thyroid cure rate is 99%. So there are good cancers also. What I want to address, which Kamalji has already told, is what can be done. Because IHW का जो aim है is to bring together at one place people who are all working in cancer care in some way or the other. And let me tell you, हम सब ने मिलके जो अचीव किया है, it is not small. Diabetes cannot be prevented. कैसे करोगे? प्रिवेंट करोगे? रोज खून निकालोगे तो आदमी पागल नहीं तो पागल हो जाएगा। कैसे कैसे करोगे? ब्लड प्रेशर यू कैनॉट प्रिवेंट, कैसे प्रिवेंट करोगे? डेली देखोगे बीपी तो पागल हो जाएगा, डेली सुबह बीपी देखना है, उसको टेंशन हो जाएगा पुराना रात से। इट कैनॉट बी क्योर्ड ऑल्सो, बट मेंटेन हो सकता है, इट कैन बी कंट्रोल। बट कैंसर 50%, क्या बढ़िया डिजीज, 50% प्रिवेंटेबल, 50% अर्ली डायग्नोसेबल, 50% क्योरेबल। चलो मैं जल्दी बता देता हूँ, आई डोंट नो मेरे पास टाइम कितना है, हम तो मास्टर लोग हैं, बताते तो वही चीज हम 5 मिनट बताते हैं, टाइम है तो 1 घंटा बताते हैं, बट मैं 5 मिनट खत्म करूंगा, मैं बहुत लोग बोला है। ऐसा है कि हमारे एक स्टेट है पंजाब, इतना बढ़िया स्टेट है, वहां लोग तंबाकू नहीं खाते, ओरल कैंसर नहीं होता। मैं लैंडसेट बीएमजी के नहीं बताऊंगा क्योंकि लोग बोलेंगे बकवास ज्यादा कर रहा है। हमारा पंजाब में ओरल कैंसर नहीं होता, तो प्रूफ क्या है? तंबाकू कॉजेस कैंसर। तो हमें यूएस यूके जाने की क्या जरूरत है? और तंबाकू न खाने या न सेवन करना या न पीने के लिए हमें कोई पैसा चाहिए क्या? तो मैंने जो एक स्टेटमेंट बताया कि 50% ऑफ कैंसर्स आर प्रिवेंटेबल, 35% आर टोबैको रिलेटेड। देयर आर 17 कैंसर्स व्हिच आर टोबैको रिलेटेड कैंसर। टोबैको नहीं लो, नहीं होगा, सिंपल। आप अगर जबरदस्ती तंबाकू लोगे तो होगा ही। आंध्र प्रदेश में श्रीकाकुलम में पीपल डू रिवर्स स्मोकिंग, पैलेट कैंसर होता है। तो इफ आई गो टू द 10th फ्लोर एंड जंप, मैं बोलूंगा मैं मर गया, तो मरना ही था, अगर नहीं मरोगे दैट इज आप नंबर। सो टोबैको रिलेटेड कैंसर्स आर बेसिकली प्रिवेंटेबल कैंसर, हम अपने लेवल में कर सकते हैं। मैं क्या करता हूँ बताओ, आई डोंट बॉदर व्हाट अदर्स आर डूइंग। जो दूसरे के बाल बोलता है वो संभव, बट यू नो हेल्प करना चाहिए उनको। आजकल कोई किसी से नहीं समझता, कोई किसी का नहीं सुनते। मेरे कमरे में कोई अगर आता है, उसके और उसके परिवार में कोई बंदा स्मोकिंग करता है, दे आर नॉट अलाउड। सेकेंड इज इन्फेक्शन रिलेटेड कैंसर्स, जो कि प्रिवेंटेबल है। आई डोंट नो, देयर आर सो मेनी गर्ल्स इन दिस रूम, इफ आई आस्क देम, आई वोंट आस्क देम बिकॉज़ दे विल ऑल बी एम्बैरेस्ड। 99% हैव नॉट टेकन द वैक्सीन। हम बोलेंगे, हम दूसरे को बोले, अपने घर से मेरे पास आता है, इसका 26 नहीं लिया, इज नॉट अलाउड। तुम अपने लेवल में तो कर सकते। आज क्या हुआ उससे? आई एम नॉट टेलिंग आउट ऑफ माई हेड। NCDIR, नेशनल सेंटर फॉर डिजीज इन्फॉर्मेटिक्स एंड रिसर्च, जो कि ICMR का ऑर्गेनाइजेशन है, गो टू द वेबसाइट। Tobacco related cancer, 7 of 17 are coming down. It's recorded in our country. Recorded. आज से 45 साल पहले incidence of cervical cancer was 40 per 100,000. Today is 10 per 100,000. दिल्ली, बॉम्बे, कलकत्ता, महाराष्ट्र में, केरला में 7 पर 100,000। कौन बोलता है काम नहीं हुआ? बहुत हुआ। ये नहीं कि कमल जी या जीके रथ ने किया, हम सब ने मिलकर किया। तो ये मैं तो बता रहा हूँ, कैंसर जैसा बीमारी है ही नहीं काम करने के लिए और लेने के लिए भी। अगर मेरे को भगवान बोला कैंसर देना, मैं देना प्रोस्टेट दे दो जिसमें मैं बच जाऊंगा, नहीं देना तो पैनक्रियास दे दो, 2-3 मर जाओ। पैनक्रियास से क्योर रेट पिछले 50 साल में 3% से बढ़ के 6% हुआ, जिसमें स्टीव जॉब्स मर गए। बट कहीं पॉपुलर लोग बोलते हैं पैनक्रियास क्यों नहीं ठीक होता है, प्रोस्टेट क्यों ठीक होता है। मैं बोलता यार सारे ठीक करोगे, विल बी ऑल विदाउट जॉब्स। कर रहे हैं, वी आर ऑल डूइंग दैट। मैंने अभी तक ट्रीटमेंट की बात नहीं किया। ट्रीटमेंट आई विल कीप इट टू द एंड। द रीजन इज ट्रीटमेंट ऑफ कैंसर इज वेरी एक्सपेंसिव। ये जो 50 हमारे कंट्री में, यू कैन नोट डाउन, हमारा जो NCDR का डाटा है, यू कैन सी द डाटा फ्रॉम द यूएस, 14 लाख न्यू कैंसर केसेस, 1.4 मिलियन न्यू कैंसर केसेस। 8 लाख मर जाते, कमल जी ने सही बताया। 7 लाख प्रिवेंटेबल है। डायबिटीज 0% प्रिवेंटेबल। कैसे प्रिवेंट करोगे? अपने पतले सुखड़ा है, उसको भी डायबिटीज है। अब क्यों है? चक्कर काटोगे, क्या करोगे, तब भी होता है। तो ऐसा एक डिजीज है जहां हम बहुत कुछ कर सकते हैं, पैसा वगैरह खर्च करते हैं। हम अपने सोसाइटी में, सपोज आज ए डॉक्टर, आज पब्लिक पर्सन, वी मीट 50 to 100 पीपल एवरी डे, उनका तो स्मोकिंग बंद कर लेते हैं, कर सकते हैं। 100 लोगों को बोलेंगे 30 तो बंद करेंगे ही करेंगे। डिपेंड्स ऑन हाउ डू यू काउंट। सो आई थॉट दिस इज व्हाट इज डूएबल इन कैंसर प्रिवेंशन। जहां तक ट्रीटमेंट है, कैंसर ट्रीटमेंट इज वेरी एक्सपेंसिव। अनफॉर्चुनेटली कैंसर की एक ट्रेजेडी है, मोस्ट कैंसर सेंटर्स आर मेमोरियल सेंटर। मतलब घर में कैंसर किसी को होना जरूरी है तभी जाकर टाटा मेमोरियल, स्लोन केटरिंग मेमोरियल, दिस मेमोरियल, दैट। आपको डायबिटीज मेमोरियल, मेनिंजाइटिस मेमोरियल नहीं मिलेंगे। And I give you a figure today. Most of the students can look down. 3rd September 2019, Lancet Oncology, बच्चे में नोट कर सकते हैं. There is a publication. Death from cancer has already overtaken cardiac. हमें बकवास करने की जरूरत नहीं, ऑलरेडी पब्लिश्ड है. पहले हम कार्डियक बोलते थे, चाहे जो भी हुआ, कार्डियक में इतना एफर्ट हो गया. अब मुरादाबाद, झांसी, इधर उधर आपको टायर 5 सिटीज में पहुंच गई कार्डियक केयर. स्टेंटिंग हो सकती है, बाईपास भी हो. कैंसर, मैं आपको एक चीज बताता हूँ, ये सबके लिए हमारा बड़ा चैलेंज की बात है. वी हैव ट्राइड टू डू समथिंग. अगर हमारे ड्राइवर को या कोक को कैंसर हो, 5 करोड़ पॉपुलेशन है दिल्ली एनसीआर में, कहा जाएगा. अगर हम काम कर रहे हैं एंटिल, दिस इज चैलेंज टू ऑल ऑफ अस. एम्स छोड़ दो, एम्स छोड़ दो. एम्स में भी आएगा 6 महीने का वेटिंग लिस्ट होता है, तो 4 बार मर जाएगा बीच में अगर जिंदा कर दिया उसने किसी ने. तो क्वेश्चन जाएगा कहां? डोंट यू थिंक इट्स आवर रिस्पॉन्सिबिलिटी टू सम वे मिटिगेट दिस? नहीं तो खाली भाषण देकर मेरे पास जो आता है मैं बोलता तुमने अभी तक क्या किया, खाना खा के बच्चा पैदा कर मर गए, ये 3 छोड़ के और क्या किया बता. तुम इतना बड़ा पोजीशन बैठे हो, सरकार को जानते हो, आईएएस जानते हो, मंत्री को जानते हो, करो ना अपने पद. अरे वो तो करो, लेकिन कुछ ना कुछ तो दूसरे के लिए करो ना. एंड कैंसर ऐसे डिजीज है, लेट मी टेल यू, फॉर आवर स्पेशलिस्ट ऑल्सो, मेडिकल, सर्जिकल, रेडिएशन, प्रिवेंटिव, पैलेटिव, 50 साल तक नौकरी है. कार्डियोलॉजिस्ट धक्के खा रहे, थ्रो स्टोन फॉल्स ऑन अ कार्डियोलॉजिस्ट. सो व्हाट आई एम ट्राइंग इज, देयर आर चैलेंजिंग थिंग्स कि हमारे पास फैसिलिटी नहीं है. हम सब बोले हाँ जी मेरे को कहा जाएगा, मेरे पास जी कर को टेलीफोन कर लेते हैं. मैं बोले यार चाय में चीनी डाल सकते हैं, चीनी में थोड़ी चाय लाएंगे, इतना भीड़ है, मैं क्या करूं? है नहीं. कैन वी नॉट डू समथिंग अबाउट? यू गो टू प्राइवेट सेंटर, एटलीस्ट 10 लाख से शुरू हो रहा है. वो अपने पूरी लाइफ को बेच दे तभी नहीं मिलेगा. मर रहे हैं, पीपल आर डाइंग ऑफ कैंसर एवरी डे. मैं एक चीज बता के, आई थिंक माई टाइम इज ऑफ, सॉरी. ऐसा है, मैं एक यार्ड स्टिक देता हूं जिसमें आप कहां है, हम इट विल टेल अस. वही चीज है सर्जिकल ऑन्कोलॉजी, मेडिकल ऑन्कोलॉजी, रेडिएशन ऑन्कोलॉजी. नंबर ऑफ लीनियर एक्सेलरेटर, मैं घड़ी देख लिया आपके. नंबर ऑफ लीनियर एक्सेलरेटर में एक्चुअली उतना ही बोलता जो चाहिए, ज्यादा सुनना नहीं चाहते, क्यों बोल रहे हो, समझ गए ना. नंबर ऑफ लीनियर एक्सेलरेटर पर मिलियन पॉपुलेशन, कनाडा और ऑस्ट्रेलिया में 10 पर मिलियन है. यूके, यूएस में 4 पर मिलियन है. इंडिया में इट इज लेस देन 0.5 पर मिलियन. आप इस स्टेट में देखा. बट कुछ चीज हम कर रहे हैं अपने लेवल में भी. हम थोड़ी बैठे, हम घास थोड़ी काट रहे हैं, हम कुछ ना कुछ कर रहे हैं. यू विल बी हैप्पी दैट हमारे कंट्री में देयर इज ए प्लेस कॉल्ड बैंगलोर, उसके पास एक जगह है मल्लूर. 120 कोबाल्ट मशीन ऑलरेडी बन चुकी है आरसी के हेल्प से. बाहर का कोबाल्ट 8 करोड़ है, यहाँ 3 करोड़ में 120 बन चुके हैं. हमारा पीएम साहब ने उसको जाके मंगोलिया और अमेरिका में थोड़ी डोनेट करेंगे. ये मंगोलिया इधर उधर जाके डोनेट कर चुके हैं, वियतनाम वगैरह. 6 लेनाक बन चुकी है, 45 सिमुलेटर बन चुकी है. तो आई एम जस्ट टेकिंग स्मॉल बेबी स्टेप बीइंग टेकन इन द डायरेक्शन ऑफ कैंसर ट्रीटमेंट ऑल्सो. बट अब लोग बोलते हैं हम, मैं क्या करूं, ये तो नहीं कर रहा. तुम नहीं करोगे फिर बात क्या करो, चुपचाप बैठो घर में रोटी खाओ. आई थिंक इट इज पॉसिबल. एंड क्योर की बात कर रहा हूं. जेएससीओ 2010 जो पढ़ना चाहते हैं, जेएससीओ 2010, आई थिंक मार्क क्रिक का आर्टिकल है, लेफ्ट पेंडर मार्क क्रिक है ना, जेएससीओ 2010. आप जरा पढ़ लीजिए उस आर्टिकल. कैंसर इज द ओनली डिजीज जिसका क्योर रेट कंटिन्यूसली बढ़ रहा है. ब्रेस्ट कैंसर का क्योर रेट आज से 40 साल पहले था 70%, अब हो गया 95%. प्रोस्टेट कैंसर 100%. तो कौन बोले खराब बीमारी, बहुत बढ़िया बीमारी है. अब पैनक्रियाज क्यों नहीं हो रहा है, वो हमें काम करना है उसके लिए, ठीक है ना. अच्छा, जहां तक व्हाट वी शुड डू डिपेंडिंग ऑन आवर कैपेबिलिटीज एंड आवर कंबाइंड कैपेबिलिटी, लॉट कैन बी डन एंड लॉट इज बीइंग डन एंड वी आर गेटिंग रिजल्ट्स आल्सो. थैंक यू वेरी मच.
Thank you so much, Dr. Rath. That was a very interesting talk. Okay. Now I would like to invite Dr. Survesha Khanna. founder and president of Dharamshila Cancer Foundation and Research Center. Dr. Khanna is the visionary founder and brain behind Dharmashila Rahat Supportive Palliative Care Center, playing an instrumental role in its growth, while providing a wide range of palliative care services to patients in need. Please put your hands together for Dr. Survesha Khanna. Survarsha. ओके मैं आपको मैम आपको हाँ, मैं गलत बोला हूँ अगेन एंड अगेन नहीं मैं अपनी गलती हूँ ओ यस अच्छी बारिश चलिए
नमस्कार डॉक्टर रथ को सुना कमल जी को सुना मैं जो बोलने वाली थी सब बदल दिया मैं वो जो बोलने वाली थी वो नहीं बोलूंगी अब मैं इनकी रिस्पांस में आती हूँ चैलेंजेस हैं लेकिन ये जो नेगेटिव वो है ना माइंडसेट सबसे पहले तो उसको बदलने की जरूरत है कैंसर के लिए सबसे पहले अपना हमें माइंडसेट बदलना है कुछ नहीं हो रहा कुछ नहीं हो रहा कुछ नहीं कौन कहता कुछ नहीं हो रहा बहुत कुछ हो रहा है मैं आपसे 1981 की बात करती हूँ अपना पर्सनल एक्सपीरियंस मेरे फादर को स्टेज 4 कैंसर इंस्टीट्यूट रोटरी कैंसर हॉस्पिटल कुछ नहीं हो सकता दिनों की हफ्तों की महीनों की बात है सुन लिया he lived for 7.5 years after that how drug trials supportive care palliative care हम उस वक्त पैलिएटिव केयर का नाम जानते ही नहीं थे लेकिन जो हमने करा वो थी पैलिएटिव केयर मगर नाम नहीं पता था हमें पैलिएटिव केयर है तो थैंक्स टू the cancer research, new technologies, new molecules, targeted therapies, immunotherapies, सर्जरी जिस तरीके से हम पहले करते थे और जब अब हम कर रहे हैं वो रेडिएशन जो हम पहले देते थे जिस तरीके से अब कर रहे हैं वो the cancer incidence is increasing, no doubt about it. वो कसूर हमारा है लेकिन कैंसर क्योर रेट जैसे डॉक्टर साहब ने बोला कैंसर क्योर रेट्स बढ़ रहे हैं एब्सोल्युटली बढ़ रहे हैं डेथ रेट्स जो कॉम्प्रिहेंसिव कैंसर केयर सेंटर्स हैं उसमें डेथ रेट भी कम हो रहे हैं कभी सुना था आपने 20-25 साल कैंसर सर्वाइवर बहुत से लोग हैं 25 साल से 30 साल से जो लिविंग नॉर्मल लाइफ अभी हमने पीछे 25वीं अपनी वो करी थी सिल्वर जुबली करी थी तो वी कॉल्ड 10 people on the stage and we facilitated them. They were about 25 year survivors. तो बहुत काम हो रहा है कोई कम काम नहीं हो रहा बहुत काम हो रहा है लेकिन हाँ काम इतना ज्यादा है कि लगता है सिर्फ इतना सा हुआ लेकिन जैसे डॉक्टर रथ ने बोला ये तो बेबी स्टेप्स हैं होंगे करेंगे कमिंग टू कैंसर प्रिवेंशन लोग बहरे हो गए हैं उन्हें सुनाई देना बंद हो गया उनको पता है कि प्रिवेंट हो सकता है लेकिन वो नहीं करते कि कौन से कैंसर होता है किसको नहीं पता है कि गंदे जो लाइफस्टाइल है हमारा जो खान पान है उससे कैंसर होता है किसको नहीं पता पोल्यूशन से कैंसर होता है किसको नहीं पता फंगिसाइड पेस्टिसाइड से कैंसर होता है लेकिन बहरे फिर भी जो कर रहे हैं वो कर रहे हैं बस भेड़ चाल और जो हमारी आज की जनरेशन है उसने तो अपना बेड़ा गर्क खुद कर ही लिया पैरों पे कुल्हाड़ी मार ही लिया उनके पास टाइम ही नहीं है जो भी प्रेसिपिटेटिंग फैक्टर्स हैं जिससे हमें कैंसर होता है वो सबको पता है डॉक्टर साहब कह रहे थे कि HPV वैक्सीन जो है वो गवर्नमेंट अवेलेबल करने वाली है 4000 की वैक्सीन है जनाब वाली कितने लोग लगवा सकते हैं 2 डोजेस देनी है आपको 8000 की जो छोटे बच्चे हैं और जो बड़ों को देनी है 3 डोज 12000 की कितने लोग लगवा सकते हैं तो कीमोथेरेपी इम्यूनोथेरेपी टारगेटेड थेरेपी हाउ मेनी कैन अफोर्ड इट तो अफोर्डेबिलिटी इज द बिगेस्ट प्रॉब्लम तो अफोर्डेबिलिटी को हम तो बढ़ा नहीं सकते लगे हुए हैं हमारे मोदी जी लगे हुए हैं कि कैसे करता है अभी कल मैंने 3 लोगों को बोला कि ये HPV वैक्सीन लगा लो कितने की है जब मैंने 4000 की खरीदी है तो मैं 4000 में ही तो लगाऊंगी उससे ज्यादा तो मैं कम नहीं लगा सकती भाग गए कोई लगाने को तैयार नहीं है 12000 रुपए कोई मतलब छोटा रकम तो नहीं है ना जो मीडियम क्लास लोगों के लिए उनके रकम तो नहीं है सो दैट इज द बिगेस्ट प्रॉब्लम Coming to early detection, we have been doing free cancer detection for 4 cancers: breast, cervix, prostate, oral, 4. चीख के चिल्ला के अवेयरनेस लेक्चर्स कर करके we've gone mad. असर लोगों का माइंडसेट, पता नहीं उनको लगता है कि वो टेस्ट करवाने आएंगे तो कैंसर निकल ही आएगा। तो रोज के अगर आप पूछो कि जो हॉस्पिटल के अंदर क्लिनिक है, फ्री कैंसर क्लिनिक 2, 4, 5, 6, हाँ हमने एम्बुलेंस जो है हमारे पास फ्री कैंसर की, उसके अंदर मेमोग्राफी मशीन भी है, एक्सरे मशीन भी है, उसमें ओरल कैंसर को भी देखते हैं, प्रोस्टेट, वहां पे बहुत से लोग आ जाते हैं अपना चेकअप करवाने के लिए। सो यू हैव टू गो टू देयर होम्स, दे विल नॉट कम टू यू, यू हैव टू गो टू देयर होम टू डिटेक्ट कैंसर। सो ठीक है, आज एक वैन खरीदी है, कल कुछ और खरीदना पड़ेगा, परसों खरीदना पड़ेगा, लेकिन रास्ते हैं, उस रास्ते पे चलने के लिए हमें तैयार होना पड़ेगा। जो तैयार हो सकता है वो होएगा, जो नहीं हो सकता नहीं हो सकता। अब कैंसर के लिए, प्रिवेंशन के लिए रास्ते हैं, अर्ली डिटेक्शन के लिए हैं, ट्रीटमेंट के लिए है, अवेलेबिलिटी बढ़ गई है। वो 1981 वाला दौर नहीं रहा जो मेरे को सहन करना पड़ा था, वो चीजें हट गई हैं, लेकिन अभी भी बहुत से गैप है, अभी भी बहुत से गैप है। 50% to 60% of the cancer patients reporting to our hospital even today are stage 4, stage 3. You can't cure them. क्या करोगे? उसके लिए किसी ने अभी तक, नॉर्थ में हमारी कैपिटल है, नॉर्थ में हमारे प्रधानमंत्री जी बैठे हैं, बड़ी बड़ी योजनाएं बनती हैं, सब कुछ बनता है, पैलिएटिव केयर के क्या हुआ? कुछ भी नहीं। साउथ वाले तो फिर भी बहुत काम करा उन्होंने, नॉर्थ वालों ने क्या किया? बहुत मेहरबानी करी तो पैलिएटिव केयर की एमडी 2012 में शुरू हो गई, बहुत एडवोकेसी हुई तो पिछले साल डीएनबी पैलिएटिव केयर शुरू हो गई। बट वेयर आर द सेंटर्स? वेयर आर द सेंटर्स? You go to a mainstream hospital, including ours, the oncologists, you can't blame them. You can't blame them. They have been trained to cure the disease. नहीं क्योर हो सकती तो कंट्रोल कर लो। अब कंट्रोल भी करते करते जो पेशेंट के दिमाग में चल रहा है, you can, oncologist can take care of the physical symptoms. What about the other symptoms? The emotional, the psychological, the spiritual, the social, the financial, the cultural. बहुत प्रॉब्लम्स हैं। आप पेन किलर की डोज जो है वो डर के मारे कम देते हो, पेन जाता नहीं है, और अगर डोज बढ़ा भी देते हो तो जब तक आप इसके साइकोलॉजिकल और बाकी चीजें हैं उसको एड्रेस नहीं करोगे तो पेन जाएगा नहीं। अब जो पैलिएटिव एक गैप है, तो पिछले साल WHO ने कहा कि भाई हाँ, स्टॉप द गैप, वो कैंपेन उन्होंने चलाया, लेट्स स्टॉप द गैप बिटवीन व्हाट इज अवेलेबल एंड व्हाट इज रिक्वायर्ड। तो हमने सोचा चलो हम भी छोटी सी एक शुरुआत करते हैं। सो व्हाट वी डिड वाज कि ठीक है, पैलिएटिव केयर के लिए कुछ नहीं हो रहा, चलो हम पैलिएटिव केयर के लिए 60% people require, 60 lakh people require palliative care, available to 2% of the people, available to 2% इंडिया, और मैक्सिमम अगर है कोई तो वो साउथ में है। 23 सेंटर हैं कंट्री में, उसमें से 109 के 110 जो है वो साउथ में है, और हम बड़े नॉर्थ वाले अपने आप को बहुत बड़ा हीरो समझते हैं, और हमारे पास कुछ नहीं, हमारे पास कुछ नहीं। सो हमने सोचा चलो इस गैप को हम कम करने की कोशिश करते हैं। तो 6 महीने पहले वी कमीशन दिस पैलिएटिव केयर सेंटर। नो, कुछ लोगों को शायद पता नहीं होगा कि पैलिएटिव केयर होगी, जिनको नहीं पता जरा हाथ खड़ा कर दे तो मैं एक्सप्लेन कर दूंगी, अगर सबको पता है तो कोई जरूरत नहीं मुझे बताने की। सो यू रिक्वायर ए मल्टीडिसिप्लिनरी टीम टू एड्रेस देयर फिजिकल प्रॉब्लम्स, पेन, ब्रेथलेसनेस, इनएबिलिटी टू स्लीप, इंसोम्निया, 50,000 की उनकी प्रॉब्लम है। तो उसके लिए आपको पेन एंड पैलिएटिव केयर स्पेशलिस्ट तो चाहिए, आपको फुल टाइम साइकोलॉजिस्ट चाहिए टू एड्रेस देयर एंजाइटी, देयर डिप्रेशन, देयर फियर, देयर इनएबिलिटी टू काइंड ऑफ कम टू टर्म्स विद द डिजीज। और कितनी उनकी साइकोलॉजिकल प्रॉब्लम है, स्पिरिचुअल प्रॉब्लम्स हैं, सोशल प्रॉब्लम्स हैं। दर्द का कंपोनेंट जो फिजिकल है वो 50% है, और 50% कंपोनेंट है ये जो बाकी चीजों का है। अब मेन स्ट्रीम हॉस्पिटल में उनके पास टाइम कहाँ है कि इन चीजों को एड्रेस करें। तो 50% कंपोनेंट को तो एड्रेस कर पाते हैं, बाकी 50% 10 मिलीग्राम से शुरू करी आपने दवाई, 15, 20, 25, 30, 40 तक पहुंच गए। अब हमारे पैलिएटिव केयर सेंटर में वो जो 40 वाला आता है उसको हम 10 पे वापस ले आते हैं, बिकॉज वी उनकी एयरिंग, उनके अंदर क्या चल रहा है उसको खोद खोद के निकालना पड़ता है। दे शट देमसेल्फ अप, वो बोलते नहीं, विड्रॉल में चले जाते हैं, लेकिन उनको खोद खोद के उनके अंदर से निकालना पड़ता है कि उनके अंदर को क्या चल रहा है। जब हम खोद के निकालते हैं, उनका गुबार निकालते हैं, उससे डिस्कस करते हैं, फिजियोथेरेपी, म्यूजिक थेरेपी, योगा, meditation, you name it, it is not one thing which is going to take care of. So the team has to be involved, the entire team has to be involved. And this is helping a lot of people, they are feeling a lot better. और डोज उससे हमारी कम हो रही है, दवाइयों की डोज कम हो जाती है। तो क्या पैलिएटिव केयर घर में ही होनी, सिर्फ हॉस्पिटल में होनी? नहीं, पैलिएटिव केयर घर में भी हो सकती है। सो वी ट्रेन दीज पीपल हाउ टू क्रिएट इंफ्रास्ट्रक्चर एट होम। फॉर माई फादर दोज फैसिलिटीज वर नॉट अवेलेबल। 7.5 साल के अंदर 10 days of hospitalization for palliative radiotherapy and 10 days of hospitalization for intertrochanteric fracture। 20 दिन, बाकी तो घर में हुई। तो पैलिएटिव केयर घर में हो सकती है, सिखाने वाले भी तो चाहिए। So we train the people, we train the volunteers, we train the nurses, we train the nursing assistant so that they can go home and train these people how to do the palliative care and how the infrastructure has to be set up। Now poor relatives, अभी तक उनका तो किसी ने सोचा ही नहीं कि फैमिली का क्या होता है। कैंसर के अंदर पेशेंट पेशेंट पेशेंट, फोकस हैव बीन पेशेंट। अब पेशेंट भी नहीं, डिजीज वाज द फोकस। अभी तक कैंसर के अंदर फोकस डिजीज के ऊपर रहा। अब फोकस हमें डिजीज पे तो हम कुछ कर नहीं सकते, तो फोकस हैज टू गो टू द पेशेंट एंड द फैमिली। जब तक हम ना पेशेंट और फैमिली पे नहीं जाएंगे तो क्या होंगे? जो केयर टेकर हैं, घर वाले हैं, उनका क्या हाल होता है वो मुझसे पूछिए। 7.5 साल मैंने जिंदा कैसे रही हूँ, कैसे जी हूँ, मुझसे पूछिए कि मैं कैसे रही हूँ। सो जो उनका हाल होता है, डैडी को पूछने वाले तो हम सब थे, मुझे पूछने वाला कोई नहीं था। मुझे पूछने वाला कोई नहीं था कि तेरे साथ क्या हो रहा है। सो पैलिएटिव केयर मीन दैट वी आर गोइंग टू एड्रेस द प्रॉब्लम्स ऑफ द केयर टेकर्स ऑल्सो, द फैमिली मेंबर्स ऑल्सो। उनकी ट्रेनिंग क्लासेस होती है, उनकी साइकोलॉजिकल काउंसलिंग होती है, उनकी रिस्पाइट केयर होती है। तो उनके लिए क्या 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 करना हो सकता है। बेरीवमेंट काउंसलिंग, पता है कि बाप, बहन, भाई, माँ कल मरने वाले हैं, परसों मरने वाले हैं, तो आधे पाल तो तुम उस बात से हो जाते हो। तो उनकी पहले से उनको प्रिपेयर करना है। चलो ठीक है। सो बेसिकली आई हैव नो टाइम, बट ऑल आई एम सेइंग इज दैट जो ये गैप है हमने भरा है, इसी तरह आप सब भी मिलके तेरे गैप से भरने वाले, कोई कमी नहीं है। इंश्योरेंस कंपनी वाले जो है उन्होंने पैलिएटिव केयर को उसमें रखा ही नहीं है, जिसके लिए डिजीजेस जो है लिस्ट ऑफ डिजीजेस में पैलिएटिव केयर है ही नहीं है। सो विच मीन यू हैव टू स्पेंड मनी फ्रॉम योर पॉकेट। दैट इज अनदर चैलेंज। थैंक यू वेरी मच।
Thank you so much, Dr. Suvarsha. I hope I got this correct this time. Let us now proceed to our first panel discussion titled Addressing the Growing Burden, Investing in Capacity and Skill Building of Healthcare Resources. This session will focus on the grave need to invest in healthcare resources and the various strategies to provide quality care cancer at various levels of healthcare. This session would be moderated by Dr. Nalini Kaushik, Lead of Policy and Government Affairs of RAPID, Global Cancer Alliance at IHW Council. Please put your hands together for Dr. Nalini Kaushik. Joining us for this discussion, Dr. G. Rath, former Head National Cancer Institute India, former Head National Cancer Institute India, one of India's most illustrious oncologists. He pioneered the current governmental cancer care infrastructure revamp in India. Please put your hands together for Dr. G.K. Rath. We invite Dr. Vineet Talwar, Director of the Department of Medical Oncology at the Rajiv Gandhi Cancer Institute and Research Center. Dr. Talwar is a specialist in genitourinary medical oncology, gastroenterology oncology, pancreatobiliary oncology, and breast oncology. Please put your hands together for Dr. Vidit Talwar. Next, we have Dr. Dinesh Pedharkar. I hope I got that. If I didn't, please apologize. Forgive me. Medical oncologist and director of Sarvodaya Cancer Care with more than 35 years of experience in the field of oncology. Dr. Dinesh is known for his impeccable expertise in pediatric oncology and medical oncology. We invite Dr. Ratna Devi, Director of Patient Academy for Innovation and Research and Chairwoman of ISPOR Patient Council. Dr. Ratna Devi brings more than 3 decades of experience in cancer care. She's the CEO and co-founder of Dakshama. As a patient safety advocate, she works with government as well as patient organizations to advocate for better quality and safety of patients. Welcome, Doctor. Now, I would like to invite Dr. Anil De Cruz, Director of Oncology at Apollo Hospitals and Consultant Surgeon at Bombay Hospital. Dr. De Cruz is well recognized as a global leader, clinician, researcher, and teacher in head and neck oncology. He has been the director of Tata Memorial Hospital and chief of head neck services with over 33 years of experience in the field of cancer. Please put your hands together for Dr. Anil De Cruz. With this, I would like to hand over to our moderator for this panel, Dr. Nalini Kaushik. Warm welcome to all of you. Yes, okay. Yeah.
Thank you. So Dr. De Cruz might be joining online sometime. Yeah. So thank you for the introduction, and thank you so much for all of you for being here on a very crucial day. And a big thank you to all our panelists. I am really glad that I'm sitting here with all of you. Over the last few years, I've learned quite a bit in the policy space from many of you, especially in the cancer space. And today it's a privilege that I'm moderating this particular discussion with all of you. So the topic of discussion, the topic that we're going to be breaking down with our experts today is addressing the growing cancer burden and talking about how and why is there a need to invest in capacity and skill building for cancer care. So just to put a bit of kind of text before we start, I have a bit of data with me, and I'm sure many of you are going to add on to what I'm going to say now. And this is from a report which was published by the Government of India in 2021, which said that India currently has only 2,700 mammograms installed, which is less than 5% of the mammograms available in the US. So if you want to make that comparison today, India has only 120 PET CT scanners, with most of them concentrated in the metropolitan cities. And we have only 30% of cancer centers that have advanced imaging technologies. So this is the numbers that we have. And what we can say is that, the way numbers in the cancer space, in terms of incidence and mortality, the way they are rising, they're astonishing. And clearly, there is a supply and demand and supply gap with what the data also suggests right now. So with this, I'm going to begin the discussion. And my first question is, we have 3 oncologists here on our panel today. And my question to all our oncologists, and we're going to start with Dr. Rath, with you right now, that what really when we look at these numbers, there's certainly a demand and supply gap. So what really is, capacity building? Where do we stand in terms of capacity building at different levels of cancer care? And how, these shortages, they impact the delivery of cancer care in our country?
The figures which you told are absolutely correct. And we all know it. So, but the question is, we are sitting here in a hall, we are already biased people. Why I told this loaded sentence is, all of us are biased towards the fact that this is fact. We all know these facts. The question is, so this is a group of already biased people who are convinced that there is a huge demand and supply gap, and this has to increase. How do you do that? That's the question. How do we take it forward? I think what is needed, again, I'll repeat the same thing. How do we increase the number of mammography CT scan machines? Or how do you increase the number of specialists like radiologists? So these are all policy decisions to be taken by government, and not that we are not doing it. All of us are doing lobbying at the level of government, and establishing more cancer centers, establishing more medical colleges, so to fill up this gap. Plus, important thing is, fortunately, mammography machines and CT scans already have started getting produced in the country, and that has reduced the price also. So things are big now, but it's not enough. Thank you.
Thank you, sir. Yes, sir. I'm actually coming to you. So, like sir said that, we are, doing in capacity. So at least the manufacturing has started. But to take that, part, the services that are available to the last mile, and it needs capacity. So what is your take, and how does, this inadequacy right now, it is affecting the service in the patient delivery, patient care?
Fortunately, I disagree.
Yeah.
So I would like to bring to your notice that every district in Himachal Pradesh, every government district hospital in Himachal Pradesh has a 24/7 operational CT scan. Every 90% of districts in Madhya Pradesh either already have operational CT scans, or they would be there maybe within next 3 months. Odisha, every district, 90% of them, not 100%, already either have a CT scan, or there is an approved CT scan near a district hospital which is doing CT scans. So the gap is really coming very down. All districts of Madhya Pradesh, all districts of Himachal, all districts of Odisha offer 24/7 biochemistry investigational services. So things are improving at a phenomenal pace in the country. This is already available. Do I really need a mammography? Yes, I need it. But believe it, it's available, and in private hospitals which is available, it is absolutely underutilized. So we have to raise a question where I need it and where is it available. So probably this discrepancy needs to be solved. So the availability is increasing, and it's really good. I can tell you, I was shocked when I went to a town called Mandi, and I was doing a cancer camp, and I said, I would like to do an X-ray of this patient. So the local doctor said, I would give you a CT scan within 15 minutes. And he actually delivered a CT scan. So it's really a good thing happening in the country. We are really empowering government district hospitals. So the question is, we have to decide first, whom do you want to empower?
Yeah.
We cannot empower the country. We cannot empower the village. So we have to decide a unit which would be empowered first and then slowly expand. So in my opinion, government district hospital is the key healthcare unit of the country. If at all we want to really thinking of improving healthcare in the country, we have to focus on a government district hospitals at every level.
Thank you, sir. Dr. Vineet, your take on the same thing, and like sir said that if you want to add a bit on that, also like sir said that there's a discrepancy of services where they're available versus where they're really needed. How do we sort of bridge that gap as well?
So I have two divergent thoughts on both sides. So I'll follow the middle of the road path. So when you go deep diving as to how the budget is allocated, how the strategies are made, that is made basically on the population-based cancer registries which are there in the country. Now, if you see the population-based registries, there are in only 17 states. The other states don't have the registries. And all your decisions, all your projects are based on the cancer registries, out of which you try to summarize how much is the need, how much is going to be the allocation, and how much is the finances which are actually available at hand. So having said that, we can keep on criticizing till heaven's end. But having said that, there is a lot of work which is going on. As Sir said about the cancer of the cervix, there is a decrease in the trend. And last week only, I just happened to see the American statistics, the American Cancer Society. They released that from the inception of the cervical vaccine program till now, there has been about 65% decrease in the death in the patients of cervical cancer. And India has the majority of patients of cervical cancers. About 40 to 50% of them are having cervical cancer in the females in the rural sector. In the urban, it is the breast which is slightly more. So, as sir said, that it is not that the progress has not been made, but then, a lot of it still requires in the long run.
Thank you, sir. Just to sort of recapitulate here, it's just that, when we talk of capacity building, there are different levels at which capacity building is sort of, required in the space of cancer care in our country. And with that, Dr. Ratna, I'm going to come to you. And let's talk a bit about, capacity building at the community level and in a more patient-centric approach. So what is your take on, first of all, that what sort of kind of a role does community-based resources, they play, in providing that quality of healthcare and all the pros and cons of it. Because let us just not talk negative here, that, let's not take on to the negative tonality, but what is, what are the good practices and what are the gaps?
Before I come to the community, I'd just like to respond to the previous question.
Sure.
We do a very big program on stroke, and under stroke, CT scans is compulsory. So it's not just the 4 or 5 states, but many more, including Karnataka, Kerala, Haryana, Punjab. All district hospitals have CT scans. It's just knowing where the resources are and sharing it between the different specialties. I think that's where the gap is. The second thing that I would like to say is from my experience of working in a very large family planning program, in one of the states that we worked, we procured hundreds of laparoscopes, but they sat within those hospitals for 2 years because there were no trained people to use those laparoscopes. There were no surgeons who could use those laparoscopes. So when we do the procurement, we also have to plan for the training. If that is not done, then those instruments sit within those hospitals and are not used. I think the planning needs to be more specific. Now, coming back to the human resources gap that you talked about, before we go to the...
Just interview. So what you just said that, so I have a follow-up question there that, like you said that, from your personal experience, and there was a huge gap there. What would you suggest that, how can we, sort of bring more structure to that? More structured reforms, we can say, or more structured planning?
I think it's a question of all stakeholders sitting together and working. When planning happens, it's one person or one department or one silo that is planning it, and it doesn't happen together. So the state, training centers or the national training centers don't come together in that. And therefore, the procurement happens in silo. And after the procurement happens, people start to think, okay, who's going to use this now? And then they start looking for surgeons who are trained, and they find that there are very few, or those trained have given up because of lack of the instruments within district hospitals. Even people who have trained have forgotten how to use it. Retrain them, and this doesn't happen as a plan, and that is the reason the problem in this. Also, to add it to that, I find that nurses and pharmacists are missing in the conversation.
Right.
And in cancer care, nurses play a very, very big role. And I think they should be part of the conversation as far as capacity building is concerned.
Right.
Only when this infrastructure is strengthened can we go down to the community. And I won't say that community is not important, but training the community is a very big challenge. And considering the vastness of our country, it is very hard to reach all parts of the world, of the country. In terms of training, I think what we can do is to give some basic information, and Madam Suvarsha mentioned about this, that, the patient is not 24/7 in a hospital. They go back to the home between the chemotherapy cycles or the treatment cycles, and the family doesn't know what to do with the patient because the patient is unable to eat. They have got problems like vomiting, loss of hair, etc., which they are not able to manage, and nobody tells them what to do when the patient is back home. So some caregiver training needs to be given. I also wanted to raise one more question from personal experience. We lost our sister 2 years back to breast cancer at age 52, and she was unmarried. And this happened during lockdown when no family member could travel to her. It was a nightmare taking her to hospitals for her chemotherapy. There is no transport system, no emergency system that can manage single patients. How do we build that? That is a very big gap that needs to be addressed. And I can go on and on, but we know that there is a lot of.
That's absolutely right what you're saying, because those are actually the kind of capacities also, that we sort of need in our country, when we talk of connecting end to end in terms of cancer care. So I'm glad you made that point.
Thank you.
Yeah. Moving on to another aspect of cancer care, delayed diagnosis. And I think that's one of the key challenge also, that we have in our country. What are, certain, areas, like, for example, investment, increased capacity skilling, how can, these aspects come together? And what are the ways in which, different actors plays in different levels, in such levels come together to, support that, delayed diagnosis can be bridged. The challenge of delayed diagnosis can be bridged in our country. Dr. Dinesh, you will start.
So I'll continue from what Dr. Ratna said. So the issue is capacity building.
Yeah.
The only way of capacity building again is we have to choose a level where you want to build the capacity. If we are talking of care, early diagnosis, the capacity building can only happen if we keep physician as a point, as a pivot. I cannot make a ASHA worker as a pivot and run my pap smear program. We have failed. So physician has to be in charge of a program, because a patient looks at the physician as a guide and no one else. So the first point is physician to be the pivot of any program. Number two, go back to the lowest level, which is most accessed, which is, as she said, not difficult to travel. Again, a district hospital. Point number two, use alternate oncology workforce. That's what I specialize in. So do not use an expert. An expert is busy doing expertise. Use an alternate oncology workforce. So alternate oncology workforce in this country is known as a medical officer of a government hospital. Use him. We have evolved a district cancer care program functioning in 6 states of India, all across. So like all districts of government of Madhya Pradesh, Odisha, Rajasthan, Himachal, Chhattisgarh and Gujarat provide cancer care. I mean my words. District hospital level. This includes right assistance from diagnostics unto death palliative care, including chemotherapy is also done there. Again, under the government umbrella, free of cost. So that we are saving money of the family, we are saving travel of the family, and patient is allowed to connect to a higher center as well.
Yeah.
So it's a bridge. So probably this kind of a bridge using alternate oncology workforce is the solution which will solve the question you raised about early diagnostics. At least if I do, like we do a lot of cancer activities. So you diagnose a cancer in a camp in a village where the poor patient would go. Do you tell him now you go to AIMS for treatment? Not feasible. So you need a system there and there to offer this issue. Otherwise, please, for God's sake, do not do the camp unless you have this logistics set in where a patient actually gets the care. Diagnosing an early cancer, I'm sorry, not advisable unless I offer that patient a biopsy report, a cancer care, a surgery, chemo, radiation. So let us please think of the whole cancer as a journey and a totality if really we want to resolve the problem of cancer care.
Absolutely. And I think one point that you've correctly made towards the end is, tracking the entire patient journey. And that actually tells us what are the intervention points and where, capacity building and skilling at the end of the day is required. But ma'am, you were nodding your head at one point on, making physicians the pivot, because I have a follow-up question with both of you on that, because I think training the health workers, at the ground level has been one of the factors with which we have been able to actually, identify a lot of not just cancers, but many other disease areas. Skilling and capacitating the local workforce, local healthcare workers, and also women at the rural level and many other, tier 3 level, training them, like, for instance, collection of, self-swabs in cervical cancer cases, etc. Those has been, one of the pivotal sort of changes as well. So while you were nodding your head, like, do you have a divergent opinion on that? Or do you think that these two aspects of training the local healthcare workforce and making them the physicians, where one, of course, we have a dearth of physicians as well, at that level, but Does that go hand in hand, or we need to capacitate our allied healthcare workers more?
So if you look at the patient journey and the touch points, the only touch point where the patient journey, sort of aligns with the oncologist is when the person is in the hospital. For the rest of their journeys, they are within their communities, within their families, or, living their lives. And that ecosystem is not still strengthened in the context of our country. And there are robust examples where we have seen, for example, from the HIV movement or from the tuberculosis movement, where the community and peer counselors have changed the narrative. So I think there are lessons already there in our country which we can pick up. And that peer counselors or survivors or champions who are sitting with newly diagnosed patients and helping them to navigate the journey is missing in cancer care. I think that needs to be strengthened. We have Jyotsna ma'am here. Their organization does wonderful work in this area, and there's a lot of scope to expand even more. Their strength is in a few cities, but I wish they were there in every district of the country. That would be wonderful, because the kind of work that they do actually elevates the person and gives them the hope and the strength to be able to manage their condition. We don't have that institutionalized right now. I think that needs to be institutionalized. Every cancer hospital needs to have a peer counselor, or at least more than one peer counselor who is able to help the newly diagnosed navigate the journey. And why I said the doctor should not be leading such a program, I think our healthcare system is too medicalized. We need to demedicalize it, because care is moving more and more out of the brick and mortar structures. It is more home-based, community-based, where there is psychosocial support given to the patient. And that aspect of it is not strengthened at all. I think there has to be a lot of work that needs to be done in moving care out of the brick and mortar structure. Yes, the critical part of it needs the specialists and the technical support, but beyond that, I mean, the survivor lives 20, 30 years. Who's going to support those persons? And again, a personal experience. I lost a sister-in-law to a re-emergent cancer. She was diagnosed the first time. The second time it was missed, because even though she was going for her visits, the screening was not, there was complacence. So the screening was not done in a proper way until she was in the third stage, and we lost her in 3 years. So there has to be work that is strengthening the community so that that screening, that monitoring, everything else is done on time.
Thank you, ma'am. And Dr. Vineet, we would like to hear your thoughts on the same aspect, that how about strengthening, the community level healthcare workers and the allied healthcare workforce in a country like India, when it comes to cancer care? How important that aspect is?
As usual, I take a different tangent altogether. You have to go to the grassroots. You have to, go to the villages. You have to go to the district centers. But okay, let me give you an example. COVID has been a nightmare for all of us, but everything has a silver lining. What it taught us in the last 2 years was to digitalize everything forcefully.
Yeah.
India was, about 27% less digitalized as what it is now. People have started using digital accounts. People have started opening accounts. People have started chatting digitally. It was much less than what it was after COVID. So take you from that. Whenever we talk of comparisons, we talk of India versus England, we talk of India versus Switzerland. What is their population? It's not even half of Haryana or half of Delhi. You talk apples with apples, oranges with oranges. Now, why I want to say this is, when we talk of large sums, we have to have some mechanisms or some processes which can digest all these volumes very quickly. And that is the reason you have to have a digital, foray into all these mechanisms. And as Sir said, we have the national digital, this thing under the ICMR, which, collates all the data from all the states, and then you start projecting. So why can't that digitalized, maneuvers be brought into practice where you have such large volumes and quickly it can be processed? And now we have the apparatus in place after COVID. So why not exploit that? And the kind of work which we are doing at the grassroots level, at the state, at the primary health level, if we bring slight amount of digitalization into that, the work will be done 10 times faster.
Correct.
That is my take.
Thank you, sir. And with what you've said, it brings me to my next question of, something regarding, the seamless interaction of technology in healthcare. You cited COVID example, but, and I think that has sort of opened the door for us to integrate technology more closely with the healthcare systems in our country. And while, there was a lot of work that the government of India has also, previously been doing, to take technology, and penetrate it further within the healthcare system. So, Dr. that's my question first to you. And actually, this is a question to all of you that where do we stand in terms of, technology and adoption of technology by the different actors placed in the, cancer care continuum, and where are we right now, and where do we need to, where are we headed in that direction?
I'll start from the discussion regarding the previous question. We add one Australia every year to this country, 22 million. That's not going to be solved very soon. Till that time, I agree with the model what Dr. Dinesh Pendharkar told. It has all been done as individual levels through the state governments. I think we have to approach the state governments because there are medical officers at the level of PHCs. We have to take them because unless the question is you, me, people, as I told you, we are all biased people. We know what is to be done, but do we have the power to do that? It has to be implemented through the state government and central government. We have to take them into confidence. We are doing at individual level. Let it be done.
Thank you, sir. Dr. Ratna, the same question to you, that where does technology and healthcare interact in our country in oncology? And where are we and where are we headed?
Well, digital has been a boon and a bane. But before that, just let me respond to Professor Rath. I worked as a medical officer in a PHC, and trust me, I was filling up 56 reports every month. Where is the time to do anything else? And an equal number of vertical programs and all kinds of campaigns for family planning, tuberculosis, malaria, etc., etc. So there's absolutely no time for a primary healthcare physician. So yes, technology is a boon and a bane. We know that telemedicine has brought care closer to the remotest people who are there. But again, that brings a challenge in itself because language sometimes is a problem. Even though people have smart devices, they may not be very well versed with it, especially the vulnerable populations and the aged or the very young. And they might need support. We do not have a system where people can sort of explain to them issues of privacy, etc. are there because you are explaining your personal medical condition. Physician is also at a disadvantage because they don't know who they are speaking to, whether it's one person or 5 persons in the room. And it is impossible to decipher over a telemedicine screen what you can see in person. At least that's been my experience. What you can see in when a person walks into your chamber is completely different when you're talking on a screen. However, prescription can be done on digital, diagnostics can be shared on digital for expert opinion. So there are a lot of advantages, but still a lot more work needs to be done.
Yes, sir. Dr. Vinny, over to you.
No, by technology integration, I didn't mean that it should happen overnight. You have to take small steps. Nothing, Rome wasn't made in a day. So if you make one change, let it get integrated into the system, then get another one, then get another one. What I'm saying is, if you go by, book and pen, vis-a-vis you go by the digital route, definitely you will gain more, access into the hinterland than just by this book.
I just want to stress on this, Dr. Rath said, what we mean by training medical officer. We are not talking to you a project report. This is a work which was initiated in 2014 in Madhya Pradesh, later on taken by other states after individual checkups, audits, reviews by their cancer experts. So it's a project which is running for 8 years, medical officer based in government district hospitals. More than 150 districts are doing this. I have physically trained more than 225 doctors from 200 districts of India and 450 nurses from these 200 districts of India. So we are training 2 nurses, 1 doctor is a medical officer who belongs to the government, who belongs to the state. If he's transferred, we train the other one. So this is a model which is happening. We are not talking of theories. Let's do practical things and let's not discuss what can be done, what cannot be done.
Thank you, sir. So, yes, ma'am. Ma'am, we'll give you the mic, so.
How much time does a medical student, a student who's not yet an MBBS, how much time does he spend learning oncology?
Well, you are absolutely right there. We have been talking. See, question is, we were under the British for 250 years. मैं पूरा सेंटेंस कहा कि आप बीच में See, अभी हम बोलते हैं sir. Do you know what is the full form of salah? Sir, slave I remain. Yes sir, yes sir. हाँ, उसका full form यही है. Slave I remain. तो ये SAR की कल्चर हमारे यहाँ था. We have been discussing with the Medical Council of India that ये एक सिलेबस तब बनी थी जब हमें इंडिपेंडेंस मिला था. उस टाइम cancer was not among the top 10. We have been trying to pressurize them, take them. They say we are already over, but you are right. But the question is, the good aspect is, cancer is becoming #1 cause of death. तो और ऐसी कल रात तो मरता नहीं कोई. प्लेग खत्म हो गया, स्मॉल पॉक्स खत्म हो गया, पोलियो खत्म हो गया. तो हम ये जो हाल में बैठे कैसे मरेंगे? कैंसर, हार्ट अटैक, एक्सीडेंट. तो even though there is no, program teaching for most of the medical colleges, but घूम फिर को देख ही लेते. But our NMC has said there is no time. So हमें को जो करना है, हमें यही 22 लोग करना है. कर रहे हैं ना, कर रहे हैं. हम यहाँ बैठे क्यों हैं? कर रहे हैं ना, हमको करना है. यस मैडम. आपका सवाल क्या है? व्हाट इज योर क्वेश्चन? कैंसर का मैडम, कैंसर का 257 कॉजेस है, बट मैं 2 बताता हूं. जो मेजर कॉज है, पोल्यूशन, ये सब है, वो 37th कॉज है. बच्चों को एग्जाम में पूछने के लिए, ठीक है. तंबाकू बंद कर दीजिए, बच्चों को वैक्सीनेशन दे दीजिए, आपका 50% कैंसर खत्म. अंग्रेज पान नहीं खाता, अंग्रेजों को ओरल कैंसर नहीं होता. सरदार जी सिगरेट नहीं पीते, नहीं होता. आप दूर क्यों जा रहे हैं BMG लैंडसेट पढ़ने के लिए? हमारा कंट्री में प्रूव है. सो द क्वेश्चन इज व्हाट वी कैन डू. हम बोलेंगे यार पेस्टिसाइड, बाबा रामदेव बोलते पेस्टिसाइड के पीछे लगो. यार कहाँ प्रूफ है? जो प्रूव कर सकते वो करिए. नंबर 1. आप बोलोगे गवर्नमेंट करना चाहिए. गवर्नमेंट हमारा चाचा थोड़ी है, हम जाकर बताने तभी करें. कर रहे हैं, हम जा रहे हैं. जैसे डॉक्टर दिनेश भंडारा को जो मॉडल बनाया, इट इज डन एट पर्सनल लेवल. आगे चलेगा. एक बात सुन ली मैडम, इंडिया अमेरिका नहीं हो सकता, अमेरिका इंडिया नहीं हो सकता अगले 100 साल के लिए. हमारा लाइफ टाइम है. यहाँ पर्सनल लाइफ सर स्ट्रीमलाइन, इंडिया में, अमेरिका में पब्लिक लाइफ सर स्ट्रीमलाइन. दोनों बराबर, दोनों मिलेगा हेवन में.
Thank you, and thank you for your question. While we have positive time, so we would be closing the session now, but one thing is for sure that, for different stakeholders here, capacity building means different when we look at the different levels of, cancer care, which is a beautiful aspect as well, that, that also gives us different solutions that we need within capacity building. There are different definitions, are different solutions. So I would request last concluding remarks from all of you in terms of capacity building at whatever level that you think, we need capacity building in cancer care in our country. Ma'am, we'll start with you.
As all the panelists have been mentioned, a lot of good work has already been done, but I think it's been in silos and patches. What needs to be done is all of us getting together and to design a plan that integrates everything that's been done so that the effects and the good things that are being done are more visible. Also, the work that's been done is not, available to the common man because they don't know that this has been done. It's sitting somewhere in the ministry. So a little more awareness on what's already been done and how we can amplify that more to more states and more districts so that more states become involved in it and take those plans. As far as palliative care, home health care, and community-based care is concerned, there's very little that's been done. I think that that's an aspect that needs to be looked at with a fresh eye and design programs and, ways in which community can be trained, especially peer counselors. I'm a great advocate of that.
Absolutely. Dr. Dinesh, we'll start with you.
Capacity building remains the key.
Correct.
So here came the question of palliative care. I would just like to add that at least 5 states in India have launched a statewide district level palliative care program as well. But the problem is people like us have to know about this program, have to speak about this program, and have to appreciate the government that what they are doing. And we should be after the government to tell them, okay, this is good what you are doing. Please continue, we'll support you. We are not doing this. So we need to pat the government. We have to pat the government saying that this is a good job being done. We are willing to participate in it. What is not happening?
Right. Dr. Vineet, your concluding remarks.
Health education. That is the mantra.
Yeah.
Cheapest, best. You screen the mother and vaccinate the daughter.
Yeah.
Just get this around and cancer of cervix will be a misnomer.
Yeah.
You tell people stop smoking, 42% of the cancers is because of tobacco and tobacco related products.
Yeah.
You've done the job.
Right. Dr. Raj.
Again, I talk with the model which Dr. Dinesh Bhandari is talking. Either all of us, whoever have contact, we all have contact. हम सब VIP देखते हैं, तो जब तक उनको क्यों नहीं समझाते हैं? मैं तो I build this entire national cancer institute, Jajjar Haryana, ₹1 में 300 अगर ले लिया, ठीक है ना? And the question is, you must try to make them understand when they are in power. And that place has 300 extension for another 100 years. We must explain the government that today the budget or the focus cannot be same what was in 47 में कलर मैं जब पढ़ रहा था कलर आके 40 पैसे एक दिन मर गए क्यों उन्हें बहन नहीं मिल रहे थे अरे कलर अब आजकल नहीं मिल रहे कैंसर हार्ट अटैक तो उसमें स्पेंड कर रहे ना बट हम सब कर रहे हैं इंडिविजुअल लेवल में कर रहे हैं ऑल ऑफ अस हैव टू डू टुगेदर नहीं कर सकते तो बस भगवान भरोसे इस कंट्री में तो लेवल 1 एविडेंस है भगवान है.
Thank you. With this, we come to the close of our first panel, the opening session here. A big thank you to our panelists. Lastly, I mean, what that we can say is that capacity building and skilling is really crucial. It's the need of the hour for cancer care in our country, and now we are exactly so. Yeah, I think. Yeah. So. I think there are multiple actors, yeah. There are multiple actors within the cancer care continuum, and I think it's all of us who need to sort of add on to that, but definitely, right. Thank you, sir. Thank you to all our panelists for the session, and we move on to our next session. Thank you.
Thank you so much. I request all our panelists to please kindly join us in front of the stage. And I would request Mr. Kamal Narayan to please, give a token of appreciation to all our panelists for giving their very prestigious time to us here today. Thank you so much. Now moving to our next panel discussion. Accelerating innovation and technology, a push for prevention, early screening, and vaccination. This session will explore how innovations and newer technologies can aid in cancer prevention and early detection outcome, particularly among the hard-to-reach marginalized groups. The session will also elaborate on learnings from current and emerging screenings and early detection efforts, programs that can help reduce the burden of cancer in the country. The moderator for this panel discussion is Dr. Ravi Mehrotra, Adjunct Professor of Epidemiology at the Rollins Institute of Public Health of Emory University at Atlanta, and is the founder of the CHIP Foundation. Dr. Mehrotra is a public health specialist par excellence and is known for creating awareness on promoting a healthy and preventive lifestyle. Joining us for this discussion, we have Dr. Raj Shankar Ghosh, public health consultant and physician with more than 30 years of experience in public health focusing on primary healthcare. His areas of interest are health systems, immunization, and infectious diseases. Please put your hands together for Dr. Raj Shankar Ghosh. Next, we have Ms. Nirja Reddy, Vice President of Genetic Counseling at Map My Genome. Ms. Reddy specializes in the telegenetics and cancer counseling. Her contribution to the field of genetic counseling is in India as a board-certified genetic counselor is immense, and she strives to increase awareness of genetic counseling among professionals and the public. Please put your hands together for Ms. Nirja Reddy. Next, we invite Dr. Anshuman Yadava, Director and Business Head of Endoscopy and Oncology at Stryker India. Dr. Anshuman comes with over 16 years in the capital equipment and medical devices industry and is consistently recognized for mapping large cross-functional teams in the APAC region. Next, we invite on stage Dr. Kishore Singh, Director and CEO of Delhi State Cancer Institute and a member secretary of the Governing Council of DSCI. Dr. Kishore Singh is devoted to the cause of progress of comprehensive cancer care management. Now we invite Dr. Harsh Mahajan, founder and chief radiologist of Mahajan Imaging. He will be joining us virtually.
Yeah, I'm
Dr.
here.
Mahajan is an eminent radiologist and a pioneer in the field of magnetic resonance imaging of India. The national honor of Padma Shri was conferred on him by the Government of India in the year 2002 for his contribution to the field of radiology in India. Dr. Mahajan set up the GMR Institute of Imaging and Research at Pusa Road, New Delhi in 1992, which became a referral center for patients from whole of North, Central, East, and Northeast India for MRI. Ladies and gentlemen, we have all our panelists and a moderator. Over to you. Thank you.
Thank you so much.
So, welcome back for the second panel. It has been an enlightening morning to have this particular event hosted by our friends at ISW, headed by Kamal and his group. We always talk about that all innovations, all new things come from the West and we just follow on, which is partly true as far as some of them, but many things are happening in India. And since morning, we've heard how there is a move to decrease the cost of medication using biosimilars, improve research and innovation starting in India for chemotherapy, radiotherapy machines being available at 20% of the cost what is coming from outside, and similarly using robotics and the latest surgical technologies for treatment. So I always like to be an optimist and hearing good things of what is happening, how cancer cases, at least some of them, are decreasing, at least the preventable ones. And I have a small proxy pride in being part of many of those initiatives over the last couple of decades. So what I plan to do is start asking questions from our panel, which are relevant to the theme of innovation and technology, looking at prevention, early screening, and vaccination. That is the job I've been given for today. So let's be prepared and look forward to the next few minutes of hearing from some of the movers and shakers in this area. And I'm so proud to be coordinating this particular group and to be part of this organization. So thank you once again for giving me this opportunity. Let me start with Dr. Ghosh. Dr. Ghosh, I know you have been involved with vaccinology in a big way, not from today, for the last many decades. And I know your favorite theme at the moment is in line with what we've been talking from the government. And again, we feel very proud of the fact that we were maybe having a very small role to play as far as restarting the HPV vaccination, and now keeping the Made in India, for India theme. Where do you feel we are hoping to start vaccinating from the government, initially maybe in certain districts and then going on to the country? The only cancer where we know the cause, where we can diagnose it, we can treat, and we can cure if treated early. We know about the 90-70-90 rule as far as the WHO's recommendation, not only for India, but for the entire world. I would like you to focus on the first 90, that is, what are the challenges in the government's plan for HPV vaccination for all eligible girls between 9 and 14, and hopefully later ages, and boys as we go along. It is a game changer. I expect it to be the harbinger of cancer control, not only in cervical cancer, but now for the first time, when I go to a layman meet, I go to a dinner, you mean to say there is a vaccine? क्या ऐसा मुमकिन है कि कैंसर के अगेंस्ट वैक्सीन हो सकती है? मैं कहा हाँ मुमकिन है, और हम उसको आपके पास जल्दी ही लाएंगे. Hepatitis vaccine was, of course, everybody knew, but they did not connect it to hepatocellular cancer. And hepatocellular cancer is, of course, relatively uncommon. Cervical cancer, we still have maximum cases in the world. We have 25% of deaths, and which is, I think, now going forward, most of them are preventable. So over to you, Dr. Ghosh.
Thank you. Thank you, Dr. Ravi. First of all, the question is quite a long, we can speak for hours, but I'll be trying to be as brief as possible. So first of all, I think we need to understand that the goal is not just to vaccinate young girls to prevent cervical cancer when they grow adult as women. The goal is to reduce the incidence of cervical cancer in India, eliminate cervical cancer. Therefore, vaccination is only one of the strategies that is being applied. And if we have to really reach the goal of elimination, what we call is the SAFE strategy, which is screening, access to care, vaccination, and education. All the four, S, A, V, and E, are all equally important in order to fight this battle. We must look at vaccination in this larger context of cervical cancer elimination. Now, there are, for any vaccination program, forget cervical cancer. If it would have been COVID, when we worked on polio in 1995, the challenges were the same. The first is around the uninterrupted supply of the vaccine. HPV vaccine was not introduced globally at a larger scale because there were supply issues. If we don't have the vaccine, we cannot vaccinate. The second issue is around the access issue. We must ensure that whoever is eligible, for whoever the program is being targeted, must have access to the vaccine, the last mile, the last house, the last family in the country, if eligible for the vaccine, must have equal opportunity. To do that, we need to have a very strong micro-planning, lessons we have learned from the polio and also from the COVID vaccination program. The third thing that is very important is to educate our population, particularly the young girls who are going to be eligible for the vaccine. There is a lot of new conversation that needs to be happening around their sexual health, around issues of how vaccines do protect individuals. And finally, the most important thing that we need to do is ensure that the impact of the vaccination program, not only in terms of the disease burden, but also in terms of what it contributes to the systems in the society, need to be measured well. Because if we do not show the impact well, the investment will die down. If the investment dies down, the program gets lost. Therefore, all of these, that is the issue of access, the issue of awareness, the issue of impact assessment, need to be done well in order to ensure a successful cervical vaccination, cancer vaccination program.
Thank you, Dr. Ghosh. In addition, I might like to talk about affordability. The good news is that our friends from Serum Institute, having now successfully completed the COVID vaccine, hopefully it is behind us, are saying that they'll be costing roughly about 200 rupees per vial. So, Dr. Khanna, hopefully your problem as far as costing will be sorted.
For the government, it's going to be free of cost. It is in the universal immunization program. It's going to be free of cost, beginning with probably 7 states and then moving on.
Yes.
But definitely in the universal immunization program, everything is free.
Absolutely.
And it has been, sorry, it's just, excuse me. I'm saying that it has been budgeted very well with the support of the Global Alliance Gavi, and also in terms of the domestic budget that has been budgeted for this. All of that part is currently taken care of.
Most likely in the month of April or May, they're going to have a universal tender, a worldwide tender. We are expecting that the company will not be charging more than 200 to 400 rupees, depending on the government or the private. And the NTAGI has clearly said that the moment we have a national, the Indian-made vaccine, it is part of our universal. So, for example, I remember very well getting the hepatitis vaccine. I bought it for, I think, 1,500 or 2,000 rupees per vial. Now it is not even 10 rupees, and for the government it is free.
Yeah, but because you are bringing up this issue again and again, I'm just wanting to say one thing, that we are very proud that there is a domestic manufacturer, but when the tendering process will happen, it is a global tender process in which there will be a bid and everything. So let us understand that the government is prepared to introduce this vaccine, irrespective of whatever the kind of affordability issues come, because it is a sustainable program.
So tomorrow, if Merck wants to apply or GST want to apply, that's fine. We have no reason to stop something good. And the other good thing, positive news, is that we are also going to export this vaccine. And tomorrow, I will not be too surprised, it is sold in Germany and the US. If it is good, I mean, no country, see, at the end of the day, we are all looking at the maximum bang for the buck. We want to pay minimum and get the maximum, and that is the right thing, not only for India, for every country in the world. We are the pharmacy for the world. Why can't we be the vaccine sort of factory of the world, which we probably already are, and hopefully will become even better. So that is the good.
70% of low and middle income country vaccines.
Excellent. So we are hoping to make it 100% as we go along. Thank you so much. That is the first thing we wanted to start. That given, I think 2023 has started with a bang as far as vaccine for cancer is concerned. And I'm sure we'll have other vaccines coming on as and when required as we go further. I'm going to jump from a physical panel to our friend Harsh. Harsh Mahajan, sir, thank you for joining. I know you have been traveling and you are joining virtually, but it's good to have you here. Dr. Mahajan, I would like to know what is the role of various screening methods for cancer, specifically breast cancer, of course, from the area of radiology and mammography. What has been your experience? You were one of the pioneers, and you still continue, at least in this region, to have the maximum number of cases. And we have interacted together in so many different fora. What do you think is the future? Do you think the prices are going to come down? Do you think cancer prevention and cancer early diagnosis, of course, is going to become easier because of the advances in radiology, especially looking at artificial intelligence, looking at mitigating the need for expert radiologists for interpretation? How are you going to get the radiographers? How are you getting the radio technicians to sort this issue out as far as supply and demand is concerned?
Thank you very much, sir, and thank you to the organizers for inviting me. We have our National Radiology Conference in Amritsar, and that's why I'm being forced to join online. Now, let me address your question at two levels. One is what is available today, and second, what is the innovation that is happening both within our country and globally, which may try to, bring screening to the masses. As things stand currently, it is X-ray mammography that is the screening tool of choice globally, as well as in our country, recognized by the government of India through a screening program that is in existence. But however, if we say, is it a successful program? Despite the best of efforts that are being put in both by the public and the private sector, there is a huge hesitancy that we've seen in ladies coming in for screening. And that exists even in those, as you know, there are ladies at average risk and there are those at higher risk. Even in those at higher risk, despite the fact that they may know that they have a higher chance of getting the malignancy, still there is a hesitancy. We also know that in our country, there is a rural-urban divide as far as breast cancer goes, which is stark. It's nearly twice more prevalent in urban areas as compared to the rural areas. So what I would say that if on an X-ray mammography machine, I have the capability of doing 30 or 35 or maybe even 50 scans if done, logistically well, it would be surprising if any time it crosses 10. And this is in the city of Delhi, where we believe, ladies are aware, they are educated about screening. So what is the way that mass screening can be done? And really towards this end, there is innovation that's happened in this country. And that is, technology known as thermomammography. We do know that cancers actually tend to produce more heat. And that has been made use of for the last many years, trying to develop a thermography system where you could actually pick up the disease early as a part of screening. And this is where CMET out of Thrissur, and they make these thermal sensors. They have, and I was part of this, group, they have made a bra which has thermal sensors within. And this is a simple device. A lady needs to wear it for about 10 minutes. And the data is collected through very exquisitely sensitive thermal sensors and fed to a computer. And there is an AI algorithm which is now being used where the initial results actually appear to be very, very exciting. And we are hopeful that this program has now reached a tech transfer level. So there are companies which have shown interest in taking this technology and building these bras, which actually in our country as well as in any other part of the world can be taken from home to home or from a PHC to PHC, even a sub-center to sub-center, and mass screening can be done. This is not to say that this is better or even equivalent to X-ray mammography, but out of the 1,000 screened, we may be able to pick up those select few who then need to undergo X-ray mammography or whatever further is necessary. Now, number two, innovation, even for X-ray mammography, and there are multiple startups as well as academic institutions around the world, including in India, who have developed AI tools with which the mammograms can actually be studied using these AI algorithms. Because remember, there is also lack of skilled radiologists who can read these scans. And there are countries in the world, I know Malaysia, for example, at one point of time, they had 1 million unread X-ray mammograms. Mammograms done, but there was no one to read them. And this is where probably in the context of breast cancer, these AI algorithms are going to be very, very useful, at least even if they are robustly able to differentiate normal from abnormal, and abnormal maybe 5%, 7%, then those 5-7% can actually be studied by radiologists, determined whether there is some evidence of malignancy, and then FNAC, biopsy, ultrasound, whatever needed may be done. So in this specific field, there is a lot that is being done both within our country as well as globally. Thank you very much.
Thank you, Harsh. It was so good to hear about innovations. Talked about thermomammography. You talked about the use of AI. You talked about how digital methods are going to be changing. We wish you all the best in your endeavors as far as bringing radiology to the masses, especially in the area of cancer early diagnosis. So thanks once again. And thanks for the internet to have you sitting in Amritsar talking to us. You're practically, you could be very well in one of the chairs next to me. So that's really good to know. Next, we move on to Ayushman Yadav. Dr. Yadav, please tell us a little bit. I know you are involved with endoscopy, you're involved with robotics, you're involved with a lot of innovations. So please tell us that where do you feel is the role of Made in India, Made for India, again and again I'm using the same words, robotics as far as minimally invasive or non-invasive surgery is concerned? Do you think robotics is going to be changing the field in a country where we do not even have enough trained surgeons? Yeah. Can we use them to make things more precise, more inexpensive rather than more expensive, as well as more applicable to the early diagnosis of cancers?
Sure. Thank you, Dr. Mehrotra, and thanks to the organizers for inviting me. So this is a very interesting question. You know, when we talk about robotics, definitely, you know, it's, and we all agree here that the innovation is the underlying theme. And as the evolution of surgery has happened, you know, from the open to minimal invasive, it was a radical change because, you know, there was lesser complications, minimal blood loss, and better recovery for the patient. When we talk about robotics, it has actually gone up one step ahead, you know, in terms of the inherent challenge with the minimal invasive surgery was that surgeon was seeing the surgery in reverse image. He could not zoom in, and there were, you know, challenges in terms of maneuverability within the patient's anatomy. So robotics has actually tried to, you know, bring a solution to, you know, overcome all these inherent challenges. Now, you know, surgeon is sitting on a console remotely, you know, he may be away from the patient, and he's zooming in into the lesion. He's able to actually, you know, take a clinical decision in terms of which arteries to cut, which to spare. And also in terms of, you know, for example, robotic prostatectomy is a classical example, you know, for if you were to do it through open, you know, there was a big scar from the, you know, navel to pubic area.
What percentage of surgeries in this country for prostate, for example, are done robotically?
See, it's still a gold standard, but I would, you know, if we talk about the overall India numbers, that would be less than 1%. And that is where I think when you talked about bringing a innovative solution, so there are Indian companies which are entering into robotics. So Make in India is definitely happening in robotics. While I was associated with one of the global companies to launch, so I launched Medtronic robotic systems in India and Southeast Asia markets. But I'm very happy to see that, you know, there are Indian companies also which is giving competition to the global players. And there are, you know, but, you know, the main thing is, as you talked about the skilling, that's where there is a big gap in terms of companies investing in skilling. You know, we don't have enough centers of excellence which can train on robotics. So one is that, you know, the companies have to invest in the, you know, and government has to also come up So I don't see too much of penetration of robotic surgery systems within, even if you talk about AIMS or big institutes, there are hardly very few robotic.
Recently, there was this SCG group in Bangalore. Surgeon was actually in Bangalore and the trainee was in Mysore. And they actually showed it on the video and shared it on social media. It sounded more like science fiction, but I'm pretty sure within the next 5 years, you're going to see a huge increase in that. But my question is it going to be affordable for the masses?
So I think
shouldn't that be decreasing the cost of not moving the surgeon from one place to another, rather increasing it?
So there are two costs associated. One is the initial investment cost, which is obviously quite high, and with the advent of more affordable robotic solutions, that is going to come down. The second is the consumables. So consumables again, constitute about a majority of the cost. And if you compare it with the minimal invasive surgery, there is a big delta. So I think we need to have open systems which can allow the usage of low cost instruments.
Correct.
Which will definitely reduce.
India, that will probably come in very shortly.
Yes, absolutely.
So moment these things are mass produced, the costs are going to go down, but we are still on the steep learning curve.
Yes.
Right. Thank you, Dr. Yadav.
Thank you.
Next, I come to Neerja Reddy. Ms. Reddy, you please, I know you are expert in genetics and genetic counseling, working for Map My Genome. And when we talk about genetic cancers, breast cancer, which is the largest number and also the most rapidly rising numbers, comes to mind. We also know that roughly 5% are genetically, both ovarian and breast to be precise, are genetically defined, especially when you look at the BRCA gene. Genetic counseling is relatively few and far between counselors. And I know there is a board which trains people and gives accreditation to those individuals. Where do you see genetic counseling becoming more readily available, not only in the metros like Delhi, but also in smaller places? And what are the basic barriers because those individuals are obviously under a much higher risk of developing malignancy, and if caught early or taken the right precaution, be it mastectomy, be it regular screening, those lives can be saved. So how do you think your area, you will be saving lives going forward?
Thank you, Dr. Ravi, for a very important question, and thank you to IHW Council for having me here. So one of the first things to answer your first question is how do we see genetic counseling being a part of this in prevention as well as in screening and reducing the risk of developing these cancers early? One thing is we are pushing for more training in genetic counseling. So there are, 2013, we had barely 20 odd genetic counselors in India. Now that number has gone up to over 1,000. That is still a minuscule. It's a drop compared to what we require. And correct. So, but it's growing exponentially, given also, I think, to the advent of technology of genetics and genomics in India has been growing, the demand has been growing. Now, we do see more and more genetic counselors coming into this space. One way we are breaking the barrier to access is to actually use telemedicine. So in my own practice, I actually see a lot of, family members, patients coming in from second and third tier cities where we see them via phone, via video conferences. And the second thing that we are trying to do is to educate clinicians. So, of course, we're sitting in Delhi, we're sitting in hospitals like AIMS or Gangaram, clinicians are very well trained in genetics. They're aware that you want to identify red flags. What we are trying to do as genetic counselors is train your basic, gynecologists. You train your clinicians who are seeing family physicians.
How are they training?
They are actually.
Excellent.
Yeah, because they are saying, parents are coming and asking, or patients are coming and asking, is they are scared about the cancer. They are worried about the risk of cancers in the family. So we are at least helping them identify what are the red flags. When do you need to help these people understand that there could be a possible inherited genetic disease in the family? Although only 5 to 10% of cancers are, genetic, predisposed because of these genetic mutations, it's extremely, extremely underdiagnosed in India. Part of it is the stigma.
Do you see the change happening soon?
The change is already happening. And I think thanks to a lot of celebrities who have come out, spoken about their cancer journey, spoken about the diagnosis, spoken about the genetic testing. And the second part of it is the accessibility and affordability of genetic testing. 5 years back, the cost of genetic testing was extremely high. It was 45,000-50,000, which has come down to 13,000-14,000 now. So it's getting
not
cheaper.
affordable for the
Of course.
masses.
Of course.
But if we have the money and we
Correct.
have the access, you will beg, borrow, and steal.
Yes.
Because that money is well worth it.
Correct. And the other change that has happened is the fact that we are getting more precise treatments, right? So with olaparib
That
coming
was my
into
next
picture,
question.
yes.
The newer genetic tests that are, and so many companies are there. Where do you feel precision oncology and focused and kind of laser beamed therapy, which is individually determined, what is the role of genetics there?
So now, if I just speak about our practice that's happening, almost every woman who's diagnosed with ovarian cancer, regardless of her age, has been sent for BRCA testing, right? BRCA 1 and 2. Although that is not enough. Okay, we know that BRCA 1 and 2 are the two most common genes. It accounts for about 18 to 20% of your ovarian cancers. There are many genes, RAT50, CND. I can list out 20 other genes that are, a part of this predisposition syndrome. And we are not testing for those. And this is where I call the clinicians and I help them understand that we cannot stop with BRCA 1 and 2. The data in Indian communities are limited. That is one of the reasons why when we do a genetic testing, we keep finding uncertain variants where we cannot confirm to the patient whether this is something that causes the cancer or not. The only way we can change that is when we start doing more testing. And this is something that is becoming more and more useful in the treatment purpose right now, because now we have olaparib, we have other treatments, other therapies that are coming into picture.
Those treatments are also pretty expensive.
It is expensive, but the only way we can work around this is the more we test, the more we can utilize this. The cost will start coming down when the demand increases.
Thank you so much, Nirja.
May I just come in, sir? This is Harsh. Just a point, going further, because we are very, very cost conscious, and rightly so, because affordability in our country is very limited. But I think we should be looking at cost versus benefit ratio. In the ultimate analysis, this test may seem more expensive, though, as has been very rightly pointed out, it has come down dramatically. But if you get the right treatment, you get precision medicine, overall, not only will you get cured quicker, not only will you get back to work quicker, but so many unnecessary treatments that or treatments, it's why not go to treatment X if that is going to be actually the right treatment rather than trying ABC before that. So I think this cost benefit ratio has to be kept in mind, not just the absolute cost of a test or a therapy.
Absolutely. I couldn't agree with you more, Harsh. The other aspect, which I'm sure you know very well, is the toxicity. Most of these medicines are extreme. They may be effective, but they are very toxic. So, I mean, as it is, so बेचारा मर रहा है उसको तुम और उसको poison देके मार रहे हो. In addition to emptying the person's pocket, I mean, how do you ethically justify that?
Absolutely.
So I fully agree that at the end of the day, all decisions that we make, well, most decisions, and this is a life-changing decision, you have to look at this is the cost, this is the possible benefit. I mean, this not only applies for genetic, applies for everything. I mean, when we choose medicines for tuberculosis, I'm not talking about multi-drug resistant tuberculosis, I'm just talking about standard. Why have we given up really toxic medicines which you lost your hearing?
Absolutely.
There is a specific reason for that, right? So if we can fine tune it, if we can tailor make it to that individual without going bankrupt, obviously that could be a sensible idea. It's a no-brainer, really.
If I can add a last closing comment to this, the theme was closing the gap. If you're talking about cost effectiveness here, even just a BRCA test or a genetic test, if you can identify that there is an underlying genetic mutation, if that costs a patient or a family $15,000, a follow-up test for their adult children or siblings will cost us another $3,000. But if you know somebody is at risk, then if you're screening them and you can prevent a cancer diagnosis, how much money and how much lives are we able to save? And what quality of life can we give them?
For the benefit of the audience here, Rusa, everybody may not be, where are these tests available in Delhi, for example, aside from some of the government setups I know, but privately, where are they done? Are they done in all or major pathology laboratories? Do they have specific areas where you go for? What is the real
Right.
scenario?
So the real scenario is there are about 7 to 8 genomics lab in India. These are all labs that are set up in India in various states. So Bangalore has MyGenome, MapMyGenome is in Hyderabad, there's Strands that is in Bangalore. So a couple of labs, there's one in Gujarat. All of these labs are doing. Delhi right now, I think it's Gangaram that really majorly does, but essentially all of these labs do take up samples pan India.
So you can't go to a standard path lab and ask them to get a genetic.
They will have a tie-up in most cases. That's what happens.
Right.
What happens?
We do have a genomics lab since the last 4 years, sir, and we don't have to send samples anywhere else. But very rightly said, these are limited. These are limited, and frankly, even for COVID, everyone came to know that there's something called mutation. There is genome sequencing that is done. And the government of India actually recognized 6 genomics labs across the country to do genome sequencing for COVID. And they were all capable of doing genome sequencing for cancer, naturally. And these were 4 in Bangalore, 1 in Ahmedabad, and our lab in New Delhi. So there are, about 10 labs all across the country.
Thank you so much for reminding me that why we should not learn. Our country or the entire world has been in a state of shock and a trauma and has so many lives lost, so much money wasted, so much productivity lost. At least we should have some advantage. And I think cancer is one of the areas where, and we started off with Dr. Ghosh talking about vaccine. Not everybody talks about vaccine. Yesterday it was a problem. But on the other hand, we have an anti-vaxxer group is also pretty loud. And you might realize that when we talk about SPV, that is why I think it is better to go a little slow, to take people in confidence, get the thought leaders that vaccines by and large are safe, but there is nothing as 100% safe vaccine. And that is same thing is going to happen. Similarly, when you talked about, I thank you for reminding me, when you talk about COVID genomics, and here we have cancer genomics, the same facilities are there. Now with COVID showing us the rear view mirror, hopefully, and I still have my fingers crossed, why not use them for tuberculosis genomics? Why not use them for cancer? And the interesting thing is when we talk about digital India, we have an entire, because of the COVID app, we have a digital app which is on everybody's phone. Why not use it for tracing individuals? And I know that the government is very seriously looking at broad basing this app business, because I think the COVID app really changed the whole scenario of being able to follow up. I got my vaccination, and I think within 5 minutes I had a message that this is your number. I don't think any country in the world, and I just come back from the US and many other places, they would love to have the digital platform. And our strength is, in addition to being the pharmacy of the country, is also hopefully robotics of the country sitting right here. And now with the digital backbone that we are able to provide the best of services around the world, what prevents us from doing it in this country? Just like we have digital payments. I don't think, aside from China, there any country where practically every second person, you have a cup of tea for 10 rupees, the person will give you a QR code. On a lighter way, and people are even taking bakshish and bribes through QR code, but I will not get into that. So before we go any further, I would like to get my friend Dr. Kishore Singh, who's heading the Delhi State Cancer Institute at the moment, to talk, first of all, what do you think is the role of innovation in cancer treatment? I know you are a treatment specialist specializing in radiotherapy. What are the innovations in the country? How are they being available to the masses? How is the price being down? And what is the role of innovators and scope for? We have a lot of young people here, and I'm sure the same kind of innovation they would apply in other areas of cancer as they have done, for example, in radiotherapy machines of decreasing the cost.
Before I start on the innovation, among all the non-communicable diseases, cancer is the least common. Like diabetes, there are 100 million diabetics in India, includes pre-diabetic.
Unfortunately, we are nearly the diabetic capital of the world.
Whereas cancer is only 2.5 million. But Cancer is the number one in catastrophic expenditure on health. It accounts for 80% of catastrophic expenditure of health by the cancer. So that brings the question of affordability and innovation. If you look at the international norms of 1 unit per million population, only 8 states are having this units completing this norm. Further, these units are focused in metro cities. So again, reaching for treatment to big cities, staying there is a big problem besides the traveling. So affordability is a big problem for cancer, and we are not surprised that 60% of the patients who require radiotherapy, only 20% are getting it. Even those who are able to reach the center, they find it very difficult to complete the treatment. So to cover this gap, Ayushman Bharat is the one thing which has become a game changer. This has made the treatment affordable both for the patient and to the centers who can successfully run their machines and add other machines with this help of this Ayushman Bharat. Innovation is the India-made machine is going to available, and once it is mass produced, it can be installed most of the places in India. But again, manpower will come into the question. We do not have radiation oncologists who can go to the rural area and run these machines. Even if we have the machine, manpower will become a big question. Further, technology is again on the development, and the latest technology in radiation therapy is the flash radiotherapy. It is very costly at present, but it gives hundreds of thousands of gray in microseconds. And beauty of this thing is normal cell do not recognize these radiation and they remain unaffected virtually.
So the normal is spared.
Normal is totally spared.
Which is again a serious problem, because in addition to the cancer, the normal also goes for a toss.
So in future, it may become competitor to surgery. Patient may not even require surgery, and you can treat a small tumor.
We'll have a team of unemployed surgeons.
We do not know, because it is effective only for a small tumor. So there is a limitation also. So innovation is there, and Ayushman Bharat is here, which is going to help in treatment of cancer. But ultimately the question is prevention. No amount of treatment facilities are going to.
You are talking my language now.
Ultimately, we have to go for the prevention.
Right. So as far as prevention is concerned, I'm just going back to the reverse order. Sir, Dr. Kishore, what are some out-of-the-box ideas for prevention which may work in India?
I want to take out the word cancer detection from the dictionary. This should be Cancer Connect.
Okay.
I am proposing.
What is the difference between connect and detection?
Why do we want to detect the cancer and put the danger in the person's mind who is normal otherwise? We are taking them to a condition which put the world upside down.
Absolutely. The very word that starts with C can put the shivers, not only the topmost functionary of the Indian government to the bottommost person on the street.
So I'm proposing in Delhi State Cancer Lounge. Lounge. So they are normal
you'll
persons.
be serving coffee and tea there?
Ambience should be like that, unlike hospital. Because they are normal person, why should they are exposed to the atmosphere of hospital?
That is very true. Actually, when I was working with the ICMR, when we started the word cancer clinic, we found not a single person coming. When we said there's a wellness clinic, we found the whole place is full. And Dr. Rath's team from AIMS and many of my colleagues, many of the colleagues there actually helped us do that. But that's a story for another day. So when you say cancer lounge, you still have the word cancer, right?
Yeah, but it is for Cancer Connect. We want to connect the psyche of person with the cancer, so they remove the phobia of cancer.
Okay. One quick question before I move on to the next panelist. What do you think is the role for palliation? Dr. Khanna talked about it. Many others talked about it. Is one of the least. Can we connect prevention and palliation? Both are P's and both can have the same manpower.
Actually, cancer care is a continuum of care. It starts from prevention and ends at palliation. There should be upward referral as well as downward referral. Unless we have an integrated care, cancer care is not complete.
That, of course, sounds very good, but is it practicable?
It is practicable because I have just completed the creation of 8-bed peri and palliative care ward. So within the
total of how many beds, sir?
We have around 150 beds.
So 158. Okay, so let's just about 5%.
Ideally, 10% of beds should be for palliation.
Okay. And what do you think are the major barriers to people accessing palliation? Because the numbers are huge and the availability is obviously very, very poor. And unfortunately here, sitting in the national capital region, I don't think it's a word that's really very, very popular, even among oncologists.
One is the awareness. Patient need palliation right from the day one they enter in the hospital. If they have symptom, they need to be palliated. Rest of the treatment can follow.
So you think there's going to be a boom in number of palliative centers in the country?
Definitely, because awareness is getting increased, and AIMS has recently started post-graduation degree in the pain and palliation also. So we will going to have more experts in this.
So there is a rays of hope.
Definitely.
Thank you so much. Nirja, we talked about the role of genomics in cancer screening. What do you think are the stigma of individuals going for cancer screening in this country?
Yes, so very important questions. A lot of stigma. One is just the fear of diagnosis. Second, when you look at genetics, is the burden.
When you say a problem, please give me a solution as well.
So one,
I hope I'm not pinning you down.
No, you're not. And in the fear of diagnosis, see, all of this comes down to education, helping them understand an early intervention can only
Would
happen.
you rather go and see the latest movie in the PVR or listen 5 minutes on palliation?
Well,
on prevention, sorry.
I would prevention, of course, because I come from this area.
So you don't want to see Pathan?
I would, but when I have the time for it.
So awareness.
Awareness is the key. Second is the counseling. That is very important. So I think Dr. Khanna very beautifully put out all of these points earlier, is that you can only address the stigma if you're able to sit down and really speak to the person, understand their.
So do you think the average oncologist in the country has any time to do that, or the wish, or
that's
the
why
training?
we are here to help you. Yes.
But I think they should develop the facility themselves. So
Correct.
capacity is of course important, and awareness, and also this sensitization.
Correct. See, cancer is a multidisciplinary clinic, right? You cannot have, the doctors are playing a huge role in helping them prevent, helping them identify.
What do you think is the role of navigators?
Big. I mean, so one of the things that I experienced when I was in the States is that they have a very huge population of oncology nurses, right? And they have a huge, so that for palliative care, they actually have special counselors who are placed over there. They have psychologists who are placed over there. These people play a huge role in the part of the cancer patient's journey, not just in their diagnosis and their treatment, but also in follow-ups and then their concerns with respect to their family members. So I think that we have to really work on building that multidisciplinary approach. Right?
Okay, thank you, Nirja. Moving on to Anshuman. What, in your opinion, is the role of companies based in India or outside funding innovation and research in the domains? What has been your experience and what are the possible challenges?
So I think,
go ahead.
When we talk about the innovation in this field, it's the funding is never enough, because right now, Dr. Kishore also alluded to this fact that the number of cancer patients are relatively lower than, the other disease, chronic disease.
Thank God for that.
But the mortality is very high. I think unless until we reach the stage where the mortality is near about zero, that's the whole, paradigm shift which has to come.
Okay, let me try to refocus that question. Why don't Indian companies spend on research and innovation?
I think it's the ROI, the
return on investment,
which is probably inhibiting. And we have seen that, when in the cancer care, the technology which is being brought out, the cost is actually passed on to the end user.
I mean, if something, once you can broad base and start mass producing, because the cost can be recovered fairly quickly. So what, can you give me some examples? So real world examples. Well, nowadays, everything is real world data.
So I think when we talked about robotics also, this is one of the example, the precision surgery. When we talked about radiology, radiotherapy, I think that's where new level of new ages of LINAC, I think that's very costly. But obviously when we talk, Dr. Mahajan also alluded to that cost benefit analysis, but the initial cost is very high, which is not affordable. And the second is, I think for India, my personal challenge has been the regulatory approvals, which is probably quite bureaucratic. It takes
So
a lot of time.
the government rules can be still quite a barrier in spite of all the fact
Yes.
of ease of doing business and funding business. The reality hasn't really changed that much.
Yeah, usually it takes about 1 to 2 years.
So what you're saying is they have gone from bad to worse.
Yeah.
So that is again the real world experience.
Even if you have to bring a CE mark technology, it takes anywhere from 6 months to a year.
When it's already gone through a fairly rigorous FDA and CE mark. They are still the world's number 1 and 2, I guess.
Exactly.
Okay, thank you so much, Dr. Ghosh. I'm going to talk about something aside from vaccines for you. And I'm talking about what are the ground realities? You visit many of the districts, the smaller towns of India. What are the ground realities? Is anybody really interested in cancer diagnosis, cancer screening and prevention? I know that is a loaded question and slightly biased also.
Yeah, but the more important thing is, Dr. Ravi, that I'm probably not very aware of it because that has not been a conversation before I had started.
And that's the reason I asked you.
HPV vaccine conversation with a lot of the community. But that is a conversation that I've been having since 2005-06 in terms of that. So there are two things which are very important, I think. One, I think around cancer, obviously we all discuss there's a lot of apprehension. The apprehension comes from, lack of knowledge about, where they can access care, about, the prevention part, the curability. I was very, very excited to hear what Dr. Rath told today morning about cancer. We must demystify the cancer in that way to the community. For that, the most important thing that we need to do is the cancer prevention, treatment, whatever diagnosis, everything needs to start from the primary health care, which means that we need to really empower our frontline workers, ASHAs, health workers with knowledge and with kind of their logistics in order to support all of this. That's very important. The second, just most important thing, that this is not a thing that the government can do alone. The government will have to partner, and the government understands that very well, with the private sector. Excellent. We have always had a public-private partnership, but for such programs, we need to bring the C into it. Public-private community partnership is the way to move forward.
I love that aspect. We are coming to the end of our program. So what I'm going to do is give you 30 seconds for every individual to come up with closing remarks. Over to you, Harsh.
Sir, I think we've had a very fruitful discussion. And really, I think collaboration, as Dr. Ghosh also said, and taking the society, community at large into confidence and assuring them that if something is expensive or a drug or a test is expensive, it is still very necessary. And somewhere, I think as health insurance increases, probably the affordability of these will also increase. And as the numbers using it increase, the costs will also go down. So it's a little chicken and egg situation, but I think we are on the right path.
Thank you so much, Harsh. That's a very positive note. And health insurance is another area which maybe we can talk at some later point. Coming back to this side, Dr. Kishore, closing remarks, not more than 30 seconds, please.
Like Heal India, we can also have a website which can connect the cancer prevention, treatment, diagnosis.
Heal India, you said?
Heal India website launched for NRI.
So something like Cancer Connect?
Cancer Connect or Vanish Cancer, which can
Vanish Cancer or Banish Cancer,
which can include everything at one place.
That is something that is very close to my heart. Maybe ISW Council, Kamal and his group, we can work together on this. Nirja, closing remarks.
So two things I think we need to start focusing more closely on. One is community awareness. Second is patient advocacy, whether it's for the patient itself.
Having the patient on the table, I think, is more important than anything else.
Correct.
After all, he or she is the person concerned.
Correct.
Thank you. Ayushman.
Thank you. So I think, again, focusing on the technology, if government really, kind of supports and encourages the Make in India initiatives in these technology, and I'm very happy to hear that, like, for example, thermal analytics for the breast screening is available, and like that,
and there are many such equipment. Because I interact with many innovators.
Yeah.
So whether it is breast light, whether it is a thermal mammography, thermography, there's so many things that are happening, and they're all made in India by
made in India.
Thank you, Raj.
We have a goal now for the country, which is that no one must be left behind. We must keep that goal above everything. Three things: we must ensure access, we must be inclusive, and the third is that we must join hands and coordinate between all the stakeholders in order to take this forward.
So collaboration, connection, and cooperation will hopefully put, as Kishore said, keep the C away. All start with C and end with C. Thank you so much for your good contributions. It's been a pleasure having all of you here. And thank you once again to ISW for giving us the opportunity. Hopefully you've enjoyed it as much as we have. Dr. Khanna, please give the mic to her. Thank you.
Sorry. You can see it this mic.
We've been talking about collaboration and we've been talking about funding. I have wasted 5 years of my life with Delhi government trying to tell them that I'm willing to fund for the palliative care. Give me 10 beds in 10 areas of Delhi, east, west, north, south.
Well, we have 10 beds here, you can take. I'm sure he is happy to collaborate without and this is Delhi government funded, by the way.
5 years ago, okay. I begged of them to have a policy on palliative care. The policy is still not there. Even with the central government, the policy is not there.
No.
Okay.
It's starting, but it's not really fully there.
Then I went to DGHS to tell them that we have purchased this huge ambulance costing us 1.5 crore. The mammography machine is there, the X-ray machine is there, everything is there.
Utilization of the existing.
And we want to go to all the Delhi government hospital, park over there, send us the people, we will screen them. Zero result, no response at all. So this is.
So when we talk about public-private, this is what we come up with.
Public-private. So
it doesn't happen, unfortunately.
I wasted 5 years of my life doing that, and finally I said, go to hell. I'll do it on my own.
They have gone to hell. Thank you so much. Yes, ma'am.
Yeah. Well, apologies for my squeaky voice at the moment. I just need to ask Dr. Ghosh, since we are talking about the HPV vaccines and the early screening, the HPV vaccine is efficient only into the few strains, whether we are talking bivalent or quadrivalent. And when we are talking about the early screening, why can't we include primary care physicians by doing certain screenings of visual inspection with acetone or legal iodine or any other sort of procedures that could be implemented in a primary care doctors or associates that could be into the remote or the rural areas? Thank you.
Thank you. And that is what I meant by public-private community partnership. We need to hear more from people like you. The thing is that everything has a beginning. We have had a past experience with HPV vaccination and all of that. We are starting a beginning. The government is starting a beginning. The people of India are starting a beginning. That includes all of these, all the safe thing that I talked about. I'm sure that as we progress, technology will help us take this forward, and we will take it forward.
Why can't we have a one colposcopy for 10 physicians and going into the sharing basis and get it to be done according to that?
Sure.
Thank you.
Well, the organizers told me just one more question. Only for you.
It's an open question for the panel. There's a lot of technology today. I should start with preventive oncology and the information system. I just have a question to ask that there's a lot of movement in technology for screening, early screening detection. But how do you convince the healthy population of the country to go for something like that?
You talk about Millennium Technologies, right? You're from Millennium? Right. So that's a $1 million question. So unfortunately, the health-seeking behavior has been the last thing on any individual's mind. And this happens all over the world. I work in the US as well. The same problem is there. Everything is free. You get a pap smear, you get a HPV test, you get a mammography, it is free. But to get the folks to come to the center is the problem. One thing that has changed, especially as far as HPV is concerned, or colonic cancer with their mailing out, when you ask people to come for colonoscopy, nobody is interested. When you mail out those particular mailers with the fecal occult blood test, the success rate was better, but still not 100%, not even 50% return. Then it's no money at all. So, and especially in India, we only go to a dentist when our teeth are falling out or we are practically wreathing in pain. So that is something which organizations like IHW, your organization, so many civil society organizations, so many government organizations, that is a role to play, that for heaven's sake, do not ignore early symptoms. Even if you are healthy, you go to get your car service when it is running fine. You can get a scooter service. You can get a motorcycle service. For heaven's sake, look at your own body, which owns the damn machine. Please go for the service. So it has improved. I'm not saying it is not, because I was just talking to somebody from Apollo yesterday, and they apparently have a very strong, they do 130 something, although that's a very pathetic number. But at least they are doing the health checkups every day. And they have, I think, 20 million pieces of information over the last many years spread all over the country. But when you talk about the government setup, again, for example, smoking cessation setups. Every dental college, every medical college is supposed to have one now under the law. Most of the time it is a room which nobody goes to. It is open only when the inspection happens. Otherwise, it is just one spare room which has to be there. So it is there, it is mandatory. So gradually things are improving. But yes, you have hit the nail on the head. You may provide the best services. If nobody is interested in taking it, what do you do? And I think we talked about, just when you talk about a hotel or talk about this place, why we have all come here. It is location, location, and location. Similarly, as far as cancer is concerned, it is knowledge, knowledge, and knowledge, awareness. And as my pocket becomes slightly heavier, when my basic needs are looked after, then I start looking at insurance, I start looking at health. So as we are going up in the development stage, in the economical, and thankfully so, now we are the 5th largest economy, but is it really equitable? The poorest and the richest person, we've just seen in the press the last 2 days, how there's a huge difference. So once this gap decreases, I'm reasonably sure things are going to change. So with that note of hope, I would like to thank once again, and some very interesting questions, and sort of proof of any good panel or any group meeting is that there is audience participation. People are engaged with what you're doing, and hopefully they will take back the message. We are only here, we may be there tomorrow. It's a group and cooperation and community is what Dr. Ghosh also mentioned. That is what is important. Thank you so much. हम हिंदी से काफी वाकिफ है, कोई दिक्कत नहीं है, बताइए. Can you introduce yourself, please?
But later, before that, I was diagnosed. I was selected for the case. I was really but they misguided. Okay, they put me on a very high dosage of steroids. And because of that, my colon was peppery thin. And I was on deathbed. I have undergone 16 major surgeries because of the negligence of doctors. They misguided me and they were overconfident. And after that, I studied medical. I went for the surgery in 2005 by Dr. Subhash Gupta in Gangaram, Dr. Samira Nandi, Dr. Soin. After that, I studied. So I'm guiding. I have my own NGO, Drishti Medical NGO, which provides information on this aspects like for colorectal cancer, for liver cancer, for cervix cancer. And I'm trying from the government that the cervix cancer prevention is available for the women. And they should make it free for everyone. And the other thing is it should be taken under as a national health program, so that the male persons can also take the advantage of that, because until and unless it will be taken as a health program
So,
under the health program.
if I may take this in, please. First of all, I would like to really apologize for everything that you went through, and whatever that you have went through. This is why everyone is gathered here in this room. They have left everything, and hence the discussion.
Exactly.
I just beg to differ. I mean, with full respect to what
Yes.
I'm a cancer survivor 6 years down the line. I feel fine. I give back today because of my doctors, whom I trust and I'm patient. This is whole private sector. I mean, I know cases are hot.
This is a great discussion, and it will be even more fun when having under the sun while we are filling our bellies. And I'm not stopping this, but just suggesting that but before we do that, I would request all our panelists to please join us in front of the stage. Ma'am, please, 1 minute. And I would request Mr. Vivekanand Mishra, he's our Vice President of IHW Council, to please give a token of appreciation to all our panelists. Sincerest apologies, and I'm really sorry for everything that you have gone through.
That's okay.
हाँ, but हम अब हिंदी में डिस्कशन करेंगे, since आपने बोला हम हिंदी में बात करेंगे.
Can I join?
No, this is for the panelists. We are just giving.
Oh.
I would like to tell all our guests that, like, as I mentioned, we are now going to disperse for lunch. The lunch will last for about 45 minutes. I request all our guests to kindly please come back at around 2:15 so we can stick to the schedule. And once again, thank you, all of you, for taking out your very precious time and joining us here. And we will rejoin post-lunch. Thank you. session will highlight effective treatments that can help enhance the delivery of care and support outcomes, including pain and symptom management, quality of life, and mental health. It will seek to cover the whole care way, from the initial suspicion of cancer through treatment, follow-up care after treatment, survivorship, and palliative and end-of-life care. For this, our first panelist is Dr. Suvarsha Khanna, founder and president of Dharmashila Cancer Foundation Research Center and director of Dharmashila Rahat Supportive and Palliative Care Center. Dr. Suvarsha Khanna is the visionary founder and the brain behind Dharmashila Rahat Supportive Palliative Care Center, playing an instrumental role in its growth while providing a wide range of palliative care services to patients in need. Next, we have Dr. Ishi Khosla, clinical nutritionist, columnist, and author who is actively involved with the Center for Dietary Counseling in Delhi. Dr. Khosla is also involved in community service through the All India Women's Association and Delhi Commonwealth Women's Association. Is the trustee of Food Future Foundation Initiative and a writer par excellence books. Please put your hands together for Dr. Ishi Khosla. And we have Ms. Jyotsna Govil, Chairman of Delhi branch of Indian Cancer Society. Ms. Govil has mentored a whole generation of cancer awareness speakers, hospital volunteers, and the first president of Cancer Sahyog, an emotional support group for cancer survivors. We have Dr. Rakesh Garg, additional professor of anesthesiology, critical care, pain, and palliative medicine at Dr. Brayarch, I hope I got that right, All India Institute of Medical Sciences, New Delhi. Dr. Garg has over 250 national and international publications. He is now involved in pain medicine, management of cancer patients, and has special interest in teaching and research activities. Next, we have Dr. Samara Mahindra, founder and CEO of HERA. Dr. Samara is also the director of Easy Check 360 with 10+ years of experience in the field of integrative oncology. Dr. Samara is well known for the efforts made towards fulfilling the gaps in cancer, leading her to be on multiple platforms, a regular TEDx speaker. Please put your hands together for Dr. Samara. And our moderator for this panel, the moderator for this panel discussion is Dr. Keshav Sharma, lead physio-oncologist and grief therapist and counselor at Fortis Healthcare. So, ladies and gentlemen, that's our panel. Please put your hands together and give them a warm welcome.
Good afternoon, everyone. I hope you had a lovely lunch, and you might be a little sleepy also, because post-lunch we would like to have a small nap. Without wasting much time, we shall proceed with our second panel discussion on improving patient and caregiver outcome in cancer care. When in the last panel, I would like to just continue from there. We've been talking about innovation, investments, how do we make cancer treatment cost effective, and things like that. But I would like to focus more on the resources that we already have. A panel is, we have a very diverse panel. We have Ma'am
who's practicing palliative care. We have a dietitian, clinical nutritionist with us, who is, again, food is a very, very important part of our life. We don't survive a day without food. So we have advocates who are advocating cancer care, better cancer care. We have people from the innovation, how to make use of the technology. Like Samara has, she's the CEO of Carer. I think it's a app-based facility. And we have Dr. Garg, who is practicing pain and palliative care at AIIMS. Cancer, yes, we all know, is a very, is one of the leading cause of preventable deaths. I think this is, in the last session also, we got to know that only 5 to 10% of cancers are genetic. What is the other then? Where is the other percentage coming from? Which is, I believe, mostly lifestyle, behavioral concerns, because if it is only 5 to 10% genetic, rest is something that can be prevented, be it through the smoking cessation, be it through the behavioral changes of the lifestyle, exercising, eating right, and so on and so forth. So I'd like to start asking my first question to Jyotsna ma'am about, because we are talking about, you know, the cancer treatment, the impact, how do we improve the cancer care? So when we talk about improving the cancer care, I think we need to understand the unmet needs of the patients and the caregivers. So my question to Jyotsna ma'am is about share with us about the unmet needs of the cancer patients.
I think the first unmet need is to put the cancer patient at the center of your picture. We don't. Doctors think hospitals are made for them. Hospitals cater to the doctor's needs. Where are the patients? Does anyone listen to them? Do they have a viewpoint that needs to be taken into account? I think that is the first unmet need. The second unmet need is a lack of any kind of awareness. We go into the community, we ask them, we're going to talk about cancer, but do you know what cancer is? And they don't. So we need to talk to them in a language which they understand, not medical jargon, but in a language that they understand, and give them the information that they should have. And the moment they do understand, the questions just come pouring out. So it's not that they're not interested. They are. It's how we address them, whether we deal with them with respect or are we patronizing them. I don't want to be patronized. I'm sure neither do you.
I get that. You mean to say that we need to treat cancer patient like a person, not the disease. We need to treat the whole person.
Even before the patient, talk to the ordinary man in the street with that respect. They ask the questions, they ask the right questions. We have screening camps, we have a screening center. I don't use the word detection, you know this, but I don't call it a clinic either. Okay? They are screening centers. We have a fixed address center and we go out to camps. We screen 10 to 12,000 people every year. During COVID, it dropped to about 7,000, but we're climbing back up again.
Yeah. So I think going back to the unmet needs of the patients, like you rightly said, treat the person as a person, not the disease. Just look at the whole person, but not just the tumor or the disease or the diagnosis. I'll ask my next question to you, ma'am. Share with us the unmet needs of the caregivers. We did speak about the patient, but what about the caregiver in the system?
I think what Jyotsna had just said is She picked up only few needs of the unmet needs of the patient. Can I?
I take over the whole session.
Okay, you have another session for that? Okay. So coming to the caregivers, I've been a caregiver since 1981 myself. First with my father, then with my mother, then with my elder brother, my bhabhi, and endless number of people you see in the family. So nobody is bothered about the caregiver at all. Nobody is bothered. Nobody is bothered. So they also need rest. They also need emotional support. They also need psychological support. They also need social support. They don't get time to eat, bathe, sleep. They're exhausted. They're absolutely exhausted. To share with you my personal example, I was relieved the day my father died. I was relieved. When we went for the cremation, I hadn't slept for 6 months. I hadn't slept. I sat down on the cremation ground and fell off to sleep. I had to be bodily picked up and brought back home. I was that exhausted at that time. Who was bothered about my needs at that time? Nobody. But now the things have changed. So we are looking into you go to a hospital, the attendant bed is a sofa or a very small couch kind of a thing. So when we made our hospital, we made sure बेचारे अटेंडेंट बेड का भी होना उतना ही जरूरी है जितना उसको घर में चाहिए, जैसा चाहिए. कम से कम 3 फुट चौड़ा होना चाहिए, हार्ड बेड होना चाहिए. तुम मर रहे हो, तुम्हें नींद वैसे ही नहीं आ रही है, तो यू हैव टू वरी अबाउट. खाना नहीं खाया जाता. The needs of the patient are so important in your mind that you forget about your own needs. You forget about. So there should be somebody to tell me कि तेरा भी नहाने का टाइम हो गया, तेरा भी खाने का टाइम हो गया, तेरा भी सोने का टाइम हो गया. We have to have relievers. Where are the relievers? So what we have done now is that we sent girls who were qualified graduates, inter science students, children of rediwalas, helewalas, rickshawalas, and we send that batch to the, what do you call it, IGNOU. They have a home care plan, training program for home care. So we financed all that program and we train 11 students every 6 months. Now, these girls, after the 6 months of training, we put them in our ICU as kind of observers, 3 months observer, and 3 months start helping the nurses over there. So they have been so beautifully trained. They have been so beautifully trained. For every patient that gets admitted into the palliative care, आप सो जाइए मैडम, मैं इसका ध्यान रखूंगी. कोई प्रॉब्लम होगी आपको जगा लूंगी. आप नहा लीजिए, आप खा लीजिए. पर हमारा ध्यान रखने वाला कोई नहीं था. कोई नहीं था.
So true. So true.
मैं के बाद
home service. Ma'am is asking if there is a home
we
service.
will send them only for our patients, not for the other people. So we send them because they've been trained in home care. So they have become like they are our pillar of strength. Nurses, of course, had always been a pillar of strength, but palliative care patient, you have to give one nurse, this assistant nurse in every room to assist those people. Mera TV chala do, मेरे को रामायण सुना दो, मेरे को कीर्तन सुना दो, मेरे को वो वाले गुरुजी का पाठ सुना दो. So these are the patient की needs भी है, patient की उसके भी चीजें.
So I think there are multiple needs, like you rightly said.
And then we have a counseling session for these people also.
Wow.
We have the counseling session for these people regular. And to begin with, the patient will not open the mouth at all. पहले 3 दिन 4 दिन patient नहीं बोलेगा, वो अंदर पी के बैठा हुआ बोलेगा नहीं. But these people will come out, वो सताए हुए हैं. They come out with कि मेरे साथ ये हो रहा है. The interpersonal relationship between the family members gets so ruined. They don't want to look at each other. काटने खाने को दौड़ पड़ते हैं. There are people who have come to the hospital and said, तू इनको संभाल, मेरे को 3-4 दिन के लिए सांस ले लेने दे. I'm sick and tired of him. Husband, she's a doctor. She's saying the same thing for the husband. इसकी डिमांड्स खत्म नहीं होती, इसकी जरूरतें खत्म ही नहीं होती, इसने मुझे तंग करके रखा हुआ है. तो palliative care will improve the interpersonal relationships also tremendously. So counseling इन लोगों की चाहिए, patient तो बाद में खुलेगा, पहले इनकी counseling चाहिए, फिर इनके रिश्तेदार इनको तंग करते हैं, to cap it all. अगर बहू है बेचारी घर के अंदर, तो उसके ससुराल वाले उसको जीना उसका हराम कर देते हैं. मैं तो बेटी थी, मुझे तो किसी ने तंग नहीं करा, बट वो कर देते, तू इसका ध्यान नहीं रखती, तू इसका ध्यान नहीं रखती, तू उसका ध्यान नहीं रखती. So these are social problems also. So you have to look at their emotional health, their social health, their medical health also.
Yes, ma'am. So again, going back to the unmet needs, there are a lot of them. We ourselves have been caregivers at some point of time. All of us are caregivers at some point of time. All of us need care also at some point of time. And I think what it needs is the absolute empathy and compassion to understand the needs of the patients and the caregivers. Moving forward to Samara, my question to you is, how do we work toward the need for health information? Because that's also one of the unmet need of patient and the caregivers.
I think that's probably one of the biggest unmet needs. We don't realize the power of information and knowledge. As Mrs. Jyotna said, that when a patient is diagnosed, as well as caregivers, very much a part of the journey of healing a patient, there is lack of information, there is misinformation, there's lack of effective communication. And we don't realize that if we just solve that one problem for that patient and the caregiver, as soon as they hear a diagnosis, a lot of their journey is resolved for them. So things like, what we see constantly is that patients, caregivers, because of the lack of information, are adhering to other forms of retrieving this information, whether it is through Google, whether it is through their neighbors, whether it is through wherever they get this information. And unfortunately, a lot of this information is uncredited. A lot of this information is not from the right sources. And that puts them into a path of even more fear. And actually a lot of it affects the adherence to treatment. A lot of patients stop treatment, they start taking alternative treatment, they come back with a progressed disease. And honestly, just solving the information part of it is very, very important. So even with what we do, while we provide integrative therapies, while we support the patient from a nutritional, physical, psychological standpoint, and very much the caregivers, we've realized that if we really need a patient to recover, then we need to start with expelling the right information to them on ground as soon as they are diagnosed. So this solves a big problem.
So true. I think misinformation is equivalent to a lot of information, because then it's just a lot. Right? It's like there's too much information on your computer and you just don't know the simple thing that you're looking for. So misinformation is also equally bad as too much information, because that induces a lot of fear in our patients. A lot of stigma also, I think, roots up from there. So yes, information, need for health information is very, very important for the patients and the caregivers. But again, we need to guide them on the credible resources. Where are they taking information from? If they have disease related, if they have, the side effects related information that they want, if they get it directly from their physician, their oncologist, I think that would be very, very
just come in. Indian Cancer Society runs a group called Cancer Sahyog. Our members of Cancer Sahyog are not trained counselors. They share an experience. And by and large, we find that they respond to the queries of the patient. If extra counseling is required, we do have a few members who are trained, and they go in and supplement the information given. But the mere fact that here is a person who's a cancer survivor who's coming up there and saying, I had cancer, I have overcome it, I'm coming to you now to tell you that you can overcome it. Dispels fear first, gives information and absolutely correct information. Second, we train those people who go in on cancer awareness as well as on emotional support. So we address these
needs
two
of
major
it.
needs. Yeah.
I think we are back to the same thing where we started, that this need is something which will not consume a lot of funds. These are the resources that we already have, our family members, our caregivers, our survivors, right? So these are very low cost resources that we have, and just the understanding how do we use these resources for the right path. My next question to you, Dr. Garg, is again, Dr. Garg is a pain and palliative physician. Just help us understand, because I get it, a lot of us do understand palliative care, but I think it's for just very simplify the concept of palliative care, because I feel there is a lot of wrong notions about it. So if you could just help us understand that.
I think to begin with, people usually think of, and if you remember, maybe 2 decades back, if you go to a physician and somebody has advanced disease, the last sentence used to be, "Ab aapka kuch nahi ho sakta, aap ghar le jaiye inko." And they used to suffer a lot, right? Because any suffering without attention will lead to more suffering, not only for patient, but as we mentioned, for the caregivers. And they will realize that these are a group of population which suffers. Now, tell me, anybody who's sitting in the audience, have you never felt that you have some concerns, some stress, some tension at any point of time? Or if you have a simple, like let's say somebody has a viral pneumonia, you sometimes feel discomfort and you approach somebody, a medical physician, to get treatment because you are feeling uncomfortable. Now let's talk of a chronic disease. He is suffering from years and years. Don't you think he will be suffering from something? He will be having a lot of issues. Madam mentioned about physical, social, psychological, spiritual. I think one question which we usually get into our clinical practice is, if somebody is diagnosed with a chronic disease, you say, you have a cancer. Oh, obviously, we'll break a bad news in a proper way. The first question is, why me? I have never done anything wrong. I'm a non-smoker. I've not hurted anybody. I've not murdered anybody. Why me? Why God has given to this? This itself is a suffering. And who bothers for it? Who cares for it? Madam shows the example of her own, that who are we giving them care for? You tell me a treatment that will not lead to some amount of suffering. I was just going to a WhatsApp jokes. Now you say, when we prescribe something, patient will ask, is the se koi side effect to nahi hoga na? I say, name a drug which does not have a side effect. Name a disease that does not have a side effect. Name an intervention does not have a side effect, 100% safe. This means a journey of a patient with chronic disease will have turmoils. Who supports it? Who will come forward? A medical oncologist will obviously treat his specialty. A surgical oncologist will treat his specialty. There has to be a person who will take care of the sufferings of these patients. And this has 4 domains I mentioned: physical, social, psychological, spiritual. And our team needs to provide, and this is what is simply the palliative care. This is just not the end of life. That's one of the thing of the palliative care. But a person who suffers from chronic disease needs some support system. And I think palliative care physician team is the best person to do so.
Wow. Well, I think it's also a comprehensive care team involved in the palliative care team. It only doesn't manage the physical symptoms of the patients, but also the psychological, emotional, spiritual needs of the patient and caregivers also met in the palliative care system, if I'm right. My next question to you, Ms. Khosla, is there are a lot of narratives about superfoods that we hear, like, eat this particular fruit and your cancer will be gone. Just tell us more about it. If there are any superfoods, if yes, or if no, and what is that? What is the way forward to it?
Well, all these conversations have been actually so overwhelming and so relatable. All of us have in parts experienced this. And to be honest, as an individual or as a practitioner, I'm seeing a huge spectrum, a huge canvas to deal with, to address, because there are no simple solutions. There are no, I just like to share this one fact, that there is more money spent in cancer research today than has ever been spent in NASA, which means we are all kind of finding solutions, finding reasons, what's happening, how to treat, why I got cancer. And these are really not so simple. And yet, I would say today, as a practitioner, I can say that we do have answers. We have been able to understand things far better than what we had a few years ago. And this one question is across for any patient who gets diagnosed with a big C is why, so where did I go wrong? What did I eat wrong? You know, it's so central, the food aspect of, you know, I ate all the right things and I did my yoga, I did my exercise. So what is wrong? What is right? I'm just going to come to that. But, you know, I just made an interesting observation while Dr. Samara was speaking, that the source of information is important. But modern medicine need not feel arrogant enough to say that that's the end of it and we know everything. We don't. We really don't. Because more than 20 to, I would say, depending on the research you quote, 20 to 50% cancers relapse. So we have reasons to believe that we are still inadequate. So we should never feel that chip on our shoulder that what the doctor is saying is the last word. And I know so many people as patients, and I think this one gentleman who was completely terminally ill, many of you may have heard his name, Amit Vaidya. He came to India just to die. He was 30, all of something in the middle of 30s, and all the treatments that were done on him and he had terrible metastasized cancers, and both the parents were cancer, they're not survivors, they died of cancer. And he did everything by the book, and he was not making it. So he said, I belong to India. He lived in the US. And he said, if I have to die, I might as well come to my country. And here is what happened to him. He read some yoga advertisement of something where they also practiced lifestyle change and cancer treatment. And he said, if I have to die, I might as well die, but let me give this a shot. So he started doing yoga. He flew to that little village in Gujarat, and he was completely cured. And then he wrote a book, The Cow That Saved My Life, The Holy Cow, something like that. And that became his mission, that if my counts can improve and every day get better with the diet and lifestyle I followed in a village, and now I'm cancer free. So what is right, what is wrong, we don't know. He was the failed case by modern medicine. So these are the people, these are the stories, they are not anecdotal evidence. This is real time, real time stuff. And we need to, therefore, not get overwhelmed, but rather understand that it can't be that we are going so horribly wrong in our lifestyles with so much information. We can't be doing everything wrong, right? That we also have cancer, we also have thyroid, we also have obesity, we also have diabetes, we also have joint pains, etc., etc. We couldn't be doing everything wrong, right? And here I'm going to quote Dr. Alicia Fasano, who is the director of the Department of Gastroenterology, Pediatric Gastroenterology in Boston Hospital. And he has said that wheat sensitivity, also called gluten sensitivity, is becoming the underlying cause of a lot of problems that we are experiencing today. And over 300 medical conditions can be linked to the inflammation caused by wheat in the gut. And these 300 medical conditions include cancer, autoimmunity, diabetes, heart disease, high blood pressure, etc., etc., etc. I mean, this is a practitioner of modern medicine in Boston Children's Hospital, and he is a researcher of great repute and respect. It's just telling us that that is where we have to strike. And what is happening in the gut is inflammation. So if we are able to tackle, so everyone asks me, what is the anti-cancer diet? What is the cancer diet which during treatment we should have? What can we do to, and there usually are comorbidities with every patient. So they can't be eating different diets for different things. So the answer is a simple anti-inflammatory diet. And in fact, my latest book has just come out. It's called The 4G Code to Good Health: Gut, Girth, Gluten, and Glucose. And really, the interconnection between both these, the gut and the girth, that is our visceral fat, which is inflammatory, with what grains we consume and the amount of sugars, etc., we consume. And the sugars need not be just from sugars or mithai. It could be just fruit juices. It could just be too much of grains itself. So that's the relationship. And I think what I'm going to really add here is that somehow I think the right authorities, the government, Honorable Prime Minister Modi, have been saying for the last, I would say, the last few months, and declared 2023 as a year of millets, is a silent message. In the budget, the finance minister spoke 10 minutes about the importance of millets. And so did Mr. Modi in the Mann Ki Baat. So these are basically what I would just say. I was thinking of a one-liner that it's the grain change which makes the game change. And really, that's the core. And we not be, confused about which is what is the wrong thing I'm eating. This morning, I had a patient, I'm just taking a little more time, but this, by just coincidence, it was a cancer patient. And she's from Patiala. She was obese, difficulty in losing weight. She just could not drop weight. And she said, finally, I decided to go in for bariatric surgery. At the age of 50, she lost about 45 kgs. And yet I said, did you feel better? Because she was constantly low on energy and exhausted. But nobody really could understand why, and she learned to live with low energy. And then started a back pain. And finally, after rounds of a lot of medication, painkillers, etc., somewhere she was diagnosed with multiple myeloma. This is all post her surgery. So we say obesity is a risk factor. Yes, she lost 50 kgs, but she didn't get fitter because the inflammation, the inflammatory components in her food and her lifestyle continue to remain. And let me also clarify that when I talk about inflammation, diet is a key culprit of increasing inflammation in our bodies. But we also have other aspects, stress, big time. So toxic emotions and all of these things add up to the inflammatory quotient. And so just the point I'm making here is that this lady has been diagnosed with cancer, and she admits that I am a slave of food. I can't stop eating. I eat very bad food. So I said, listen, you have to understand that you have to eat differently. And there are lots of people today who eat very well, and yet they succumb. So we understand these things far more closely, the importance of inflammation in the gut, and the right kind of choices of food. We all know what is a healthy diet, which is vegetables, fruits, antioxidants, now probiotics, enzyme-rich foods. All the nutrients are all so important. We know that, and we are doing it, yet it's not helping. The graph is just going the other way. And I can go on, so please stop me now.
Yeah, thank you.
Yeah.
Thank you, ma'am, for sharing that nutrition is not for the disease, but it's for the person.
बहुत सही कहा आपने. Absolutely, absolutely. Absolutely right. Customized diet approach is important, but we have broad guidelines which we can go by. And that's, of course, something no, that's everybody's different, that one man's food is another man's poison. And, but today there is so much confusion. Is milk good for me?
I think it's the answer would be the body knows
Yeah.
it all.
बिल्कुल.
I think consulting the right
Yes.
person for what they
This
need to
is what we call, sorry, I'm just interrupting, answering a question, the reductionist approach, that carbs kharab hai, proteins kharab hai, fat kharab hai, ye kharab. So this is spoiled the sanctity of nutrition. Nutrition to the public has to be communicated in the form of foods. Ye khana hai, ye nahi khana. And it has to be customized. So
very well said. I think to this, I have one thing that body knows it all. What your body cannot digest, it will reject it first. You'll not feel like eating it. This is one thing my mother used to say. And I think I've started to believe it because one day when you don't feel like eating anything, a particular thing, it means your body is telling you. So which means we need to be best friends with our body, listen to the body. Going back to the body, the nutrition, the stress, again, I'm going back to the pain. Dr. Garg, pain is spoken a lot. The importance is there. WHO has its own guidelines, the pain ladder. But how can we make it a person-centered, but not not just to focus on the disease and for example, the ladder, if we follow, the person has pain on this to this, and then we give the second ladder of it. How do we overcome that, and is this even possible?
Absolutely. I think this is an important aspect. I think behind the ladder, there is a person who is trained for it. So he has to choose it very judiciously. Ladder can be used in multiple ways, but how to use it to climb up or climb down, it depends upon you. I must say that every patient has the right to be pain-free, and AIMS has been declared pain-free because all our patients who comes to pain cancer center, they remains pain-free. I think this is the right we need to understand. And in this technology, we have app, we have softwares, we have so much, and we are working on the individualized medicine, personalized nutrition. The same thing is applicable for pain management also. And we have a couple of good drugs and interventions which we can give to each of our patients. And as Madam said, we have to individualize it. So that's why this cannot be a pain management cannot be an over-the-counter drug or over-the-counter prescription. We run the clinics, we have home care teams available with us, we have OPD clinics with us, and we give them a pain management. But just to add on, it's not pain, it's something called total pain. Majority of us as physicians or patients or the caregivers will go to the doctors for the physical pain. Back mein dard ho raha hai, peet mein dard ho raha hai, ya jahan cancer hai, wahan dard ho raha hai. And when I start treating those patients, on one day they will be crying, ki kuch bhi kar dijiye, bas ye dard theek kar dijiye. We'll admit them in next 2, 3, 4 hours, they'll be pain-free. But then why are you not looking happy now? You have a pain-free? Yes, sir, pain-free, but you're not looking happy. So I think there is something more component of pain, which is psychological, spiritual, physical, social, financial. How many of us, how many of physicians, family members, cancer care teams, palliative care physicians, or medical fraternity are looking for those type of pains? क्या हमने कभी पूछा कि आपका कैंसर का दर्द तो ठीक है, but आप शाम को जाके क्या खाने के लिए सामान खरीद पाएंगे? He is suffering from that pain. A patient who is having a married girl, a daughter in the house, he is waiting for him to be married, but he is admitted in hospital. क्या आपने पूछा उनसे कि उसकी शादी कैसे होगी? A person having kids who is not going to school because fees pay करने को नहीं है. That social psychological component has to be integrated. So we don't talk of pain management. We must talk of total pain management, and we have the options available. I think this is not a rocket science. तो ऐसा मत समझिए उसके लिए 10, 15, 20 साल पढ़ना पड़ेगा pain management के लिए. I think come to us, come to any of us, just learn a person with some empathy, some understanding, and a passion to devote to these patients. I think all our patients can be pain-free.
Very well said, Dr. Garg, because I feel pain, for physical pain, if we talk about, you need opioids, you need to follow the WHO's ladder, but for the psychological, emotional, social, spiritual, financial, other pains, all you need is not the opioids, but the support system.
But I think if with the permission, I can get something about the opiates, because काफी patients ऐसे आते हैं कि sir opiates का मतलब होता है दवाई होती है, morphine, fentanyl ऐसी दवाई होती है. कुछ लोगों को लगता है ये opium है तो नशा चढ़ जाएगा, नहीं देंगे, या हम देते हैं तो बहुत, उसमें से अगर हम बोलेंगे दिन में 6 बार खाइए तो छुप छुप के 3 बार खाते हैं, और फिर आते हैं दर्द तो ठीक नहीं, वहां पूछते हैं क्यों नहीं हुआ, आपने दवाई ठीक से हाँ खाया, बिकॉज उनको लगता है नशे का दवाई है, ये इसमें से गड़बड़ हो जाएगा. आई थिंक जैसे अभी हम न्यूट्रिशन की बात कर रहे थे ना, हर एक पेशेंट की एक अपनी रिक्वायरमेंट होती है. अगर आप उस रिक्वायरमेंट से लेंगे तो वो न्यूट्रिशन हेल्दी करेगा, उस रिक्वायरमेंट की दवाई लेंगे तो आपको कोई साइड इफेक्ट नहीं करेगा. अगर उससे ज्यादा न्यूट्रिशन लेंगे, ज्यादा दवाई देंगे तो साइड इफेक्ट होता ही होता है. तो आई थिंक दैट्स व्हाई एन एक्सपर्ट गाइडेंस इज इंपॉर्टेंट. ओपिएट इज सेफ, but under supervision, take as per your instructions. And we have now many other options. So I think we should declare India as a pain-free. We should take a lead.
We do have, I think we are the #1 exporter of opioids in the world.
Can I just
Yes.
comment here? I mean, Dr. Garg just mentioned that there are many reasons for the pain. Many years ago, when we had first started our work in AIMS as support workers, we had a lady with breast cancer. She needed surgery and the husband was refusing. So we took them aside and I was talking to them and I asked, why? I mean, she can be cured. Why are you not denying her that chance? So what he told me was an eye-opener for me. He said that no doctor has said that for 100% she will get a cure. I have 3 children who are in school. So do I put my money on or for a certainty of a good future for my children? It's a pain that many patients and caregivers carry.
And I think hence they don't, they default from the treatment.
That's
Even the
the
disease
reason
is
why we
curable.
started. Yeah,
Yes,
we
even the
started
disease
that
is
very
curable. There is treatment available. There is help available. There are, I think, from the government side, there are a lot of funds also available for the treatment, but our patients are not taking treatment because they don't see it as 100%. From this, I think, ma'am, I'll ask you about, we were talking about the physical pain and we know how to manage that, and all the drugs and everything is there. But how do we handle the psychological, social, spiritual, and financial pain, and how do we fill the gap there?
It's the most difficult part. Physical, you can give drugs. First of all, the patient has kind of withdrawn himself. He's shut up. He doesn't want to talk. Some of them, not all of them. He doesn't want to talk. So day 1, kuch nahi. Day 2, kuch nahi. Finally, when they open up, then you know there's so much pent up in their own body, you see, that why were they not saying? They don't want to hurt their family members. ना उसको पता चलेगा तो उसको तकलीफ होगी, उसको बचाने के लिए अपना सत्यानाश करते हैं. Finally, so now counseling चाहिए, 100% चाहिए, but एक खाली काउंसलर से कुछ नहीं होगा. ये काउंसलर से कुछ नहीं होगा, because it is a teamwork. The palliative care person, the psychologist, the music therapy, the yogic therapy, there's a, what do you call it, meditation, the spiritual gurus. So the palliative care nurses, the caregivers, the entire team has to come together and plan a comprehensive treatment plan for that patient. कि अभी हम क्या करेंगे, अगले हफ्ते में क्या करेंगे, अगले महीने में क्या करेंगे, अगले ट्राइमेस्टर में क्या करेंगे. एक दिन से कुछ नहीं होने वाला, और साइकोलॉजिकल चीजें तो एक दिन में नहीं निकलने वाली, 100% नहीं निकलने वाली. So you have to kind of make a care plan. While you're making care plan, you have to tell the family member to anticipate कि ये आगे ये भी हो सकता है, ये भी हो सकता है, ये भी हो सकता है, ये भी हो सकता है. अब उसको जो हो सकता है उसकी प्रिवेंशन कैसे करनी है, उसकी अर्ली आइडेंटिफिकेशन कैसी है और उसको मैनेज कैसे करना है. So these three things you have to tell the caregiver. And amongst the team, we have to be on one platform, you see. Yes, this is what we are going to do. The plan is not made by just the psychologist or just by the palliative care. The rehab team also has to be involved. Rehab team को हम समझते थे कि सिर्फ फिजियोथेरेपी करते हैं, नहीं, वो बहुत कुछ करते हैं, बहुत कुछ. साइकोलॉजिस्ट हम समझते थे खाली वो काउंसलिंग करते हैं, तो कॉग्निटिव चीज को भी देखते हैं. So वो सारा का सारा, it is not one person job, it's a teamwork. And the entire and the most important component we always forget is the nurse. She is the biggest coordinator. ये लिखा गया, ये हुआ कि नहीं हुआ, ये लिखा गया, implementation हुई कि नहीं हुई. Unless the implementation is done, you are not going to get any benefit. And I can tell you from personal experience, whether a relative or a caregiver or a doctor, it does wonders. It does wonders. It does wonders.
Thank you, ma'am. And I think I'll just elaborate more on who is a caregiver now. Is this the immediate family member, or is it the friends, or is it the treating team? I think, again, we divide it into the formal and informal family members. Yes, anybody who is associated with a person during the treatment, be it a nurse, because this reminded me because ma'am said nurse is a very, very important component in this entire system, because I think as doctors, you go for rounds, spend 10, 15 minutes, maybe an hour, but the rest 24, 23 hours are being spent with the nurse. She is the one who's taking care of the patient's physical, psychological, emotional needs, because maybe as a psychologist also I'll go for an hour or two, but then who is taking care of their tantrums if in the local language that we say, this patient is very irritating, the patient is getting very angry, and who is taking care of that. And I think when we talk about the caregivers, it's not just the immediate family members, but people who are away, who are physically not there, but emotionally affected, because cancer does not just affect the person, but the entire ecosystem of the person. And who all are part of the ecosystem? Yes, our nurses, yes, our doctors, yes, our treating team. So with that, Samara, I have my next question to you. Like, you're working on integrative oncology, using the technology. How do we use technology as a care path to fill the gaps? Like, what else is that we can do, which is affordable, feasible, convenient for the general mass?
So just as a correction, we're not an app-based platform. We are very much an on-ground company that has a hub and spoke model. So we have integrative. So exactly what was mentioned essentially is integrative oncology, a multidisciplinary approach of managing a patient's condition using nutrition, physical, pain, palliative, psychological, the medical team, the caregivers, so on and so forth. So that's essentially what we do. And the way we do this is by having centers on ground, as well as reaching out to a larger group of patients using technology. So if you have a phone and an internet connection, we can actually extend the support to patients. So a lot of our patients are actually in tier 2 and tier 3 cities. Now, the problem that it solves using technology is, one is that I'm not a big fan of this word scalability, but it extends into the masses. And we are able to reach a larger group of patients beyond just the tier 1 cities. Second, what it does is it gives you access to information. So what we did is that we created an information hub with, again, the right sources and simplified information, again, very important. So whenever patients or caregivers want to understand their condition better, want to understand how they can manage their journey a bit more effectively, the information is right there. They would not need to go beyond what is there, and it's literally a click of a button. Third is it gives us the ability to be in touch with the patient 24/7. So one thing that was spoken about is implementation, and it's all about implementation. I tell my doctors this all the time, that yes, you have a team in the clinic, in the hospital that does all of this. But when the patient leaves the vicinity of that hospital, who's monitoring that? How are we implementing all the changes and the lifestyle support the patient requires on an everyday basis throughout their journey? So technology allows us to do that. Another aspect is adherence. So what happens is when a patient and caregiver feels supported on an everyday basis, even in the hospital and while they go back home, we have seen adherence go up. And according to me, one of the biggest problems we face in cancer care today is the low adherence we face, because that does not support a patient. Obviously, survival goes down, relapse goes up. It does not support the doctor's practice. And of course, it affects all the people involved in that journey. And if we can just improve adherence, and that happens with the right information. As Dr. Garg also said, that people have this wrong perception about opioids, but that would just be solved by educating them correctly of what exactly it does. So when we onboard a patient, the first touch point is educational. The first touch point is to let them understand what is happening in their journey. And all of that can be extended through a digital platform. And then, of course, we are able to collect immense amounts of data in terms of how they are responding to a certain nutritional intervention that we followed, or a certain kind of physical therapy for a specific type of indication, and then prognosis, diagnosis, and the type of treatment they're on. So it gives us immense amount of insight into what's happening with the patient and the caregivers when they go back home, and then so on and so forth.
Thank you, Samara, for sharing this. And I think what we sum up here today is we are using, because in the previous session, what I got is there's a lot of money involved, expensive treatment, robotic, this and that. Yes, that is very, very important to treat the disease, but I think what we are talking right now is treating the person and the entire ecosystem by providing the right care, by taking care of their needs, not only during the treatment, but also after it, during the survivorship. And Samara, you pointed out very well that the biggest problem in India is the non-adherence among the cancer patients. Sometimes the disease is detected in the early stage. For example, the chronic myeloid leukemia, highly manageable kind of cancer. All you need is one medicine every day. It comes up with side effects and everything, but all you need is the adherence. So I remember we did a research, and that's where we found a lot of 80% of people were non-adherent, and that's why they come back into the blast phase, and obviously the disease grows. I want to add
one thing here, and it was actually an eye-opener for us. So when our patients come to us, and of course, there are thousands of patients, we do a mass screening on adherence. So it gives us an indication on the patients who are likely to drop out of treatment. And what we found, we would imagine that most of it is because it's financially, because of finances. And while that plays a big factor, there are many other factors that affect adherence. And what we found was that it was the lack of information, and it was also the negative perception of allopathic medicine that was resulting in a low adherence. I'm talking specifically for oncology on large numbers that we found. We just tweaked that, and we saw adherence going up. So I think presumptions don't work in oncology. I think we have to go out there on the ground.
We have to be in the ground and be, the part of their ecosystem to be able to run it more effectively. Because when we talk about adherence, because there are a lot of reasons, a lot of our patients come from very low socioeconomic status, very difficult for them to manage the funds. But there are organizations. The good news is there are a lot of organizations which are funding their treatment. They're funding the entire lifetime treatment is being funded, and still there is non-adherence. there is something that which we are missing. And I think those are the gaps. I think we were today talking about the pain, the nutrition, survivorship, palliative care, needs of the patients, needs of the caregivers. It's not talked much about because we all forget ourselves as people, ourselves as the first-hand caregivers. We all have been caregivers. I myself have been caregiver. And, directly or indirectly, you may not have to be next to the patient in the hospital, but you might be providing the funds to your parent or somebody sitting in the next city, but you're emotionally involved. So I think before being the practitioner, before the doctors, whoever, whatever role that we are playing, we need to understand that we are people and we also have the roles that we are, working towards helping other people to cater those needs. And I think when we understand that, that helps us being more empathetic, because that makes us, that brings us the human part of us is awakened, and that brings more compassion. And I think when we practice with empathy and compassion, the practice becomes beautiful. So with this, I'll just let you know the last takeaways from Dr. Garg. Yeah.
I think what we need to do is just not to think of good life, but it should culminate into something called good death also. I do not know, people ask what's good about death, but that is what the palliative care is. We should be with the patient throughout the journey and leading to a good death. And it's doable, doesn't require something very great, just requires a little understanding, empathy, and a good environment. That's it.
And I think palliative care is not just about the good quality of life, but also good quality of death. So, Samana.
I think just echoing what everyone has said, and it all goes back to an integrative approach. And this is what we stand for from day one. I have been through it with my mother. I saw the lack of it. I experienced it, and I do till date. And I feel that if we can all come together and actually support a patient as putting the patient in front and then providing an integrative modality of care, we will see immense amount of improvements in patient outcomes as well as caregivers.
Wow. Thank you. Joseph.
For me, it's always the patient at the center of things. Once we have that focus in mind, then everything else falls into place. I think we've spoken about all of it. I don't want to add any more. Thank you.
Thank you, ma'am. Dr. Khosla.
Well, I realize I hadn't specifically answered your question, that there are no superfoods. And all we need to do is to look at what we eat, what we digest, what we don't eat, and the role of micronutrients, vitamins, minerals is very, very important. Today, particularly in the modern lifestyle where we're not getting optimum levels of new micronutrients, it's called hidden hunger. Well, most easy example to give is vitamin D today. With so much sunshine in India, we are almost 80% population deficient of vitamin D. Again, a very powerful anti-inflammatory, beyond many other things, it's an anti-inflammatory agent in our body. And the role, I'm not going to leave this place without talking about magnesium, simply because as I'm practicing, the more I'm practicing, I'm realizing how unrecognized this area is. We are all used to prescribing calcium supplements in the absence of magnesium, and the single most deficiency of, most critical deficiency in our body is magnesium, not to be diagnosed by blood tests. We don't have the ways to determine cellular levels, and it is rampant. And just the other day, I know this session needs to be wrapped up, but it was overwhelming for me. A patient, young boy, 39, came to me with a little extra weight, 5-6 kgs. And he said, my main concern is restless legs. And I have restless legs. So that's something which is associated with magnesium deficiency, among many, many more things, including anxiety and constipation. So we went into the depths of why, the documentation of his problem of magnesium deficiency. And I said, I think it's in your family too. I just asked him, do you have a sister? So he said, no, but my brother is obese and he can't stop eating, and etc., etc. So I said, well, you may have a maternal aunt. So do you have a bua? So if you have a bua, she's at risk of developing breast cancer because of this deficiency in the family. And I had no blood work. This was just basis clinical, clinical questions and interrogation. So he said, my bua died of breast cancer very young. I lost her to breast cancer. So this is how accurate the science today is with respect to nutrition. We are far more clear on what is happening, and going to the gut level is really addressing almost everything about our health, who we are, whether we are healthy, whether we are strong, whether we are resilient, whether we are not. So with that, I think I just leave it to that. And one message maybe, which I guess you all expect from me, is what is the healthy diet? Kya khaye, kya na khaye? Is simply put a rainbow diet. A rainbow diet, try and incorporate at least the 7 colors of the rainbow on a daily basis, if not on a daily basis, for as often as possible. And also try not to eat. That means fasting is a very important tool to beat cancer and to be better and prevent all the problems that we're talking about.
Thank you. Dr. Khanna, last words.
My message to all my colleagues, especially the oncologists, is cure. We are trained to cure. That is our job. That's our objective. When we cannot cure, we have to accept we cannot cure. We'll control it to the maximum possible level. But when we can't even control, please stop drugging the patient unnecessarily. Please stop drugging the patient unnecessarily and involve the palliative care team as early as possible, so that you see the focus shifts from curing to caring. There's a limit to curing. There is no limit to care. There's no limit to care.
Yes. Yes, definitely. Now I would request Mr. Vivekanand Mishra once again to please come and join us, and I would request all our panelists to please come and join us in front of the stage. We would like to give you a token of appreciation. Our next panel, we will be discussing moving from problems to solution, the promise of universal health coverage. The achievement of universal health coverage, a sustainable development goal by 2030, depends on both access and quality. However, the alarming level of out-of-pocket spending on health, with cancer accounting for the largest out-of-pocket expenses and pushing millions into poverty overall, hinders India's progress towards UHC. The session will identify vulnerable groups that are predisposed to financial distress imposed by cancer diagnosis and treatment, and deliberate upon models of healthcare that can protect patients against incurring a financial burden. I would now like to invite Dr. Madan Gopal, Senior Consultant Health at Niti Aayog. Dr. Gopal is a health professional who has been working on issues related to health systems reform in India for more than 28 years and has held many leadership positions and was one of the key team members behind the implementation of the Rashtriya Swasthya Bima Yojana health insurance scheme in India and is now contributing to Ayushman Bharat PMJ. As senior consultant with Niti Aayog, Dr. Goyal contributes to various health sector transformative programs, including Ayushman Bharat. Next, we have Dr. Julka. Has an experience of 40 years in the field of oncology, is a medical educationist and writer known for performing the first peripheral blood stem cell transplant following high-dose chemotherapy in metastatic breast cancer in India. He was honored by the government of India in 2013 by bestowing on him the Padma Shri, the fourth highest civilian award, and for his contributions to the fields of medicine and medical education. Please put your hands together for Dr. P.K. Julka. Next, I would like to invite Dr. K. Govind Babu, consultant medical oncologist at St. John's Medical College and Hospital of HCG Hospitals, Bengaluru. Dr. Govind's key areas of expertise are solid tumors and hemato-oncology. He is also keenly interested in administering targeted therapy and precision medicine and has treated more than 3 lakh cases so far. So I would request Dr. K. Govind Babu also to please come and join us. Sorry, sir? No. We also have Mr. Jose Pizza, co-founder and CEO of Arogya Finance. Mr. Jose has extensive hands-on experience in the retail lending businesses, its systems and processes, legal and regulatory framework management of risks and governance mechanisms. Mr. Jose is also a co-founder of Index Advisory that has incubated multiple entrepreneurial ventures and has led the financial advisory of the firm, helping organizations such as Daimler Financial Services and Medtronic to develop and launch finance offerings in India. The moderator of this panel discussion is Mr. Vaibhav Garg, Director of Health Economics and Government Affairs, India Hub and ASEAN, Boston Scientific. We have Dr. Priya, Senior Public Health Scientist at the Public Health Foundation of India and Director of PHFI Peripheral Universal Health Initiative. She serves on a task force on primary health care constituted by the Ministry of Health and Family Welfare, Government of India, and is a member of the Technical Review Group on Urban Health Planning formed the Ministry of Urban Development in addition. She will be joining us virtually. She's here with us virtually. I would also like to introduce Dr. Parag Bhamre, Associate Director of JPIGO India, JPIGO India. Dr. Parag is a public health professional with over a decade of experience of working in the sector. He has worked extensively in the Mumbai slums as well as the rural tribal pockets of Bihar, Chhattisgarh and Maharashtra. He also works in the areas of immunization, MNCH and non-communicable diseases to create AI-based solutions that apply to the masses. Yeah. All right, over to you. Thank you. Yeah.
Very good afternoon, everyone. I think the panel that we're going to have now is a very complex problem that we have, which we intend to discuss in this panel. And the title itself is Moving from Problems to Solutions. I'm not sure if we'll be able to come to solution by end of 1 hour, but I think we'll be able to discuss the problems threadbare, that we have in hand when we're talking about, the promises of universal health coverage, especially, with regards to the cancer care and cancer diagnostics in the country. I have a fantastic and a very diversified panel with me. I have a practicing physician. I have a policymaker. I have a public health scientist. I have a social organization representative, and of course, I have a person who pays money for the care and the diagnosis, right? So I think it's a fantastic panel to talk about problems to solution, the pathway that we have, and I think we will be focusing on that as we go along. So I welcome all of you to the panel. Thank you, everyone. Is Dr. Julka disconnected? Or relog in? Okay. No worries. Thank you. Okay. So, I'll try and make this panel as interactive as possible with the limited knowledge that I have, in terms of the cancer care and the diagnosis, and of course the economics behind that. And I think that's where the real crux of universal health coverage challenges will come forward, while talking about cancer care and the diagnostics. So let me start with Dr. Gopal. Sir, I think you are sitting at a very central place called Niti Aayog, which has the visibility in all directions of government functioning. I think many of us would be knowing about various initiatives of Government of India towards cancer diagnostics or cancer care, and so on and so forth. But would you mind just sharing sort of major programs that government has in cancer care and cancer diagnostics, so that we exactly know, that what are the various, programs that are running, and then we can sort of have discussion after that. Over to you, sir.
Thank you, Vaibhav. I think I was witness to some of the discussions which was happening during the earlier session, and we have been talking about universal healthcare. The journey of universal healthcare was not that smooth, because we always talked about, because you see how a consensus on the definition of health, on the definition of health, it took around 50 years after formation of World Health Organization. After, from the disease, we have moved to the health. We have a strategy how to reach to that, which we call as primary health care strategy. From health, we have moved to the well-being, and from well-being we are wellness. From well-being, we are moving towards the wellness part. In the course of time, we have changed our strategy, because we are grappling. At that time, we were grappling with the issues of communicable disease. Now, as things are evolving, now we are grappling with the issues of NCDs and the other factors as well. Despite that means triple burden of the disease we are facing. So as a result, the strategy was also made more comprehensive. Now we have a comprehensive primary healthcare strategy, and the institutions surrounding that have been evolving. when the primary care strategy was there in the public sector, you have created a lot of network of institutions right up to a population of 5,000 to 3,000, where we used to have a section headquarter in the form of sub-health center. Above used to be the primary health center. Above used to be the community health center. And above is the district hospital. And every district we are envisaging to have a medical college. That was a chain which has evolved. And after the liberalization in 90s, you have seen a lot of spurt in the private sector. Before 90s, there was no spurt in the private sector. The GDP, that too on the this laboratory investigation. Yes. But as we were progressing, as we were moving from Millennium Development Health for All, then Millennium Development Goals and SDGs, and universal healthcare was added to that. Apart from making the services accessible, affordable, and within the reach of the persons, we have to see that the health even doesn't result into a catastrophe. What is happening, even if a cervical vascular accident happened or the cancer case is detected in a family, you see the catastrophe, the magnitude of pain and suffering the family undergoes, we don't know. We have having an insurance coverage. Everybody talks about the PMJ program, where we are having an assured care for assured coverage for 50 crore population. They are having others that who are the privileged class who work in organized sector. They are having the coverage of CGHS, the other insurance. There's a sizable population which buys his own insurance. But the missing middle which is there, if you talk about the quintiles and other things, the lower two quintiles we are taking care. The upper two quintiles, they can take care of themselves and they are subscribing to this. The missing middle. How this missing middle also, the lower quintile who are in the vicinity of that. In the previous session, somebody was saying that people go into catastrophic expenses. If you look at the out-of-pocket expenses, because universal care is providing accessible, good quality care with prevention of the catastrophe, financial catastrophe. That's the element which is there. As we have identified few of the areas that diagnostics, drugs, and your imaging, they consume a lot of your out-of-pocket. That means if you want to understand out-of-pocket expenses, people are spending around 50%. The latest survey says that 48%. That is 48% people, they are spending from their pocket for buying their healthcare services. What that it implies? That means 1.4 billion people chasing after around 15 lakh doctors for buying their services. So that is resulting in a vicious cycle of you going, buying, and again going back into the cycle of impoverishment. So a threshold of impoverishment has been defined. That means the impoverishment level is less than 25%. Then at least you can say that you have achieved the universal health care. But presently we are at 48%. To reduce that thing, various schemes are there. I will first talk about the universal health care. First, we have the free because the drugs were the prime consumers for that catastrophe expense. So we had that free generic medicine program, and we had the Jan Aushadhi program, and the network of Jan Aushadhi program is increasing. And if you look at the drugs for cancer, they are also available in the Jan Aushadhi Kendra, because that is to reduce the catastrophe because of the drugs. That kind of effort was made. Then the second was that you look up the diagnostics, you see the free diagnostics and other things are also coming up. But the important chunk which comes from the OPD and other things, that is still work in progress, and we have to see that how we handle that thing. For the catastrophe which were occurring because of the inpatient care, so we have launched that program, which is one of the core programs of the government, is Ayushman Bharat PMJ program. The precursor was because people used to say that it doesn't cover OPD, but three aspects are being taken care for this 50 crore population. That means diagnostics, the medicines, and the inpatient care. The OPD care is already available in the government sector. Even you and me can walk in with a subsidized rate. You can have that OPD services there. So this kind of framework is there, and with this efforts, the out-of-pocket expenses used to be around 70. Now it has come down in the recent NHA thing. It has come down to 40. It's not sense that we should be patting ourselves. A lot of work is to be done and we have to see that where we go. Once we talk about the cancer, and cancer, 40% of the expenditure for the cancer patient, as per the standing committee reports, is borne by either mortgage, either by selling the property or by the help of this. Now, one interesting model we have come across that people, they are now lending also they have become lender. Instead of taking loans from the family members, the lenders have come, they are having eye on the property. They usually are in the process of seeing that how you distressfully sell your assets and everything. That kind of this, and unfortunately, it has come up in close network with the institutions and the providers. So that's one thing. So having said this, we do have a lot of programs which are targeting to the cancer, but one of the important program is the National Non-Communicable Disease NCD program. Now, previously used to have a long name, National Cancer Control Prevention. That now it has been shortened to National Non-Communicable Disease Program, in which we are trying to see that the cancer care and the treatment, they are reaching up to the community health center. As I mentioned, community health center, this is the first place where the specialist services are available in the government sector. That's a block level. We are having around 7,000 blocks. And if you talk about the government system, you have a system, though it will be fragmented in a debilitated condition, but some structure is there. The moment it comes to, because the private sector has come up from 90s only, so they are only placed in the tier 1 cities, some part of the tier 2 cities, and now they are expanding to tier 3 cities. But the challenge is that how to reach to them. That's one thing. In the DIT program, screening happens. The second arm of the program, which is at the Ayushman Bharat Health and Wellness Center. The sub-center which I mentioned, they are now been upgraded to, and the strategy which was changed from primary health care to comprehensive primary health care. So now we are providing 12 services, including the mental, dental, the palliative and other care. For increasing that, the centers which used to be sub-health center, now they have been upgraded as health and wellness centers. That means we have moved from health to well-being and then the wellness. So we have moved in that direction. So we are providing that. So in the Ayushman Bharat PMJ program, we are having around 1,500 packages, of which around 130 plus packages are related to oncology. But that is not limiting. That is for the ease of administration, because if the person, because it covers around 50 crore population, the administration is very simple. If the person walks into a hospital, if he is entitled, he can avail the services after pre-authorization by the authorization process like this. Apart from that, for providing financial assistance, you are having a lot of programs. The health minister funds are there. 2 kinds of funds are there. Then the prime minister relief fund is also there. Most of the states, they are having this. But this is only a tip of the iceberg. You won't be helping all the people. The major program lies in prevention of cancer. Even if I sometimes become very sad because everybody is interested in making chain of cancer hospital. I'm investing so much in cancer chains and other things. How many beds you can create? And the way which the cancer prevalence and incidence is going, even if you create 10 lakh beds, that won't be sufficient in the coming 5 years. So you have to focus more on the prevention aspect and see that how the catastrophe happens. You think of a family, suppose something goes wrong. If somebody comes to, you were asking about the palliative, as doctors, if you go to a district hospital, medical college, silently there is an understanding between the doctor and the treating person that you take the person to your home, and it's a silent understanding. Legally and formally they won't say, but that kind of, now that kind of things are also under discussions. People are coming saying that I need not to be put on the this assistive devices or this artificial assistance if I'm at the terminal stage of it. That decision they can upfront now say that thing. So Dr. Saab is there, so he would be elaborating more on that. Let me complete that so that I have to leave by 4 o'clock because I thought that we will be coming on, starting on time. That unfortunately. Next thing is we are talking about if some cancer thing happens in a family. The family is gone back by 10 years or 15 years down the line. The catastrophe and other, even the cerebrovascular accidents also something happens. The cost of care which is there is so exorbitant. You can't say the doctor can just forego his fees But what are the other consumables and other things? Who will take care of that? The medicines and other things. The government is trying to put Jan Aushadhi Kendra and some of the medicines are being available. But apart from that, one more important thing, we see that how the technology which is now evolving, instead of moving from one term is there, that's the surgery, radiation, and your chemotherapy, that is burning, poison, and that kind of thing. Can't we move into the you are expert in that, but I just read it. But can't we move? Because there are a lot of technology that gamma knife surgery,
immunotherapy.
how we can reduce the cost of that so that it becomes more accessible to them. A lot of work is required to be done on the biomarkers and others so that early detection can happen. So we have to create a lot of awareness, though we are having an army of around 1 million health workers working in all the villages. How we empower them so that early screening of the cancer can happen. Current focus is on oral cancer, cervical, and the breast cancers. How we expand the scope of that, because we can't be overloading that person because their prime job is something else. Because we are still grappling with the issue of providing RCH care and the communicable service to that wider chunk of population. With a limited budget, we are trying to see that how maximum benefit can be provided to the people. But the bottom line is how to prevent things. You see, the cancers are increasing. That's the environmental determinants and other things become very important in cancer prevention. We need to do a serious work in this direction. Because prevention is the key for cancer control. Creating facilities, they will have effect. You can at least palliate that patient and can improve the life of that patient. But we have to reach to the masses. We are talking about 1.4 billion patients, and how many cancer beds are there in the country? If you talk about the total beds, we are having around 15-20 lakhs beds. 50% are in the government sector and major in the private sector. And you see that how many beds can be earmarked for the cancer.
Sir, if I can just add a tangent to what you are saying, government has, I think, few years back created this infrastructure for cancer, which is State Cancer Institute, tertiary cancer care centers, right? That's a supply side of it, basically. And now PMJ is providing the demand side of care, basically. We are enabling each one of them with 5 lakhs rupees. Now, do you think that this, catering to both demand side of care and supply side of care is sustainable, particularly for cancer? Or do you think that is important for a country like India where we can't choose one of them actually?
You can frame this question differently. Because from the government side, we want that all the citizens should be having access to healthcare. We are having a network of institutions. We have reached up to a population of 3,000, 5,000 district hospitals. But we want to tap the private sector beds which are available, which can provide cancer treatment. And PMJ comes as a bridge for that. If the private hospital empanels in the government scheme, their beds are also being extended to provide services to them. That's why they are complementing to each other. It's not that it would be, because you see everybody, when the scheme was launched, when I was associated with the RSPY also, people say that ye to kuch hoga nahi 30,000. But if you look at the way that things have consumed, hardly less than 1% they have ever touched the 30,000. That means it is a viable thing for a small, because majority of the population lies in tier 2, tier 3 cities. And when the Ayushman Bharat packages were started, I had the opportunity to be part of that. During that time, everyone was skeptical कि बड़े लोग नहीं आएंगे. हमने बोला छोड़ो हमारे लोग नहीं आएंगे. You have to empower them persons so that they can walk into silver aluminum hospitals. So even आप भी जाएंगे, you also feel sometimes very shy in walking into that silver aluminum hospitals and see that how it happens. So we have to see that we are talking to the masses, and for the masses, these programs are quite handy and they're quite helpful.
Thank you so much, sir. Appreciate that. Let me shift a gear here a little bit, and let me, as a health economist, my viewpoint is for every rupee that I'm spending, what is the best care I'm getting out of it, right? What is the quality of care I'm getting out of it? So I think let me go to Dr. Julka here. Dr. Julka, as a practicing physician.
Yes, yes. Yes.
You can hear me, sir, right?
Yes.
Okay. So as a practicing physician, sir,
Yes, yes.
we have this Ayushman Bharat PMJ, which is said to be the universal health coverage program of India as we go along, as
Yes.
we can see into the future. But, what
Yes.
are your thoughts, sir, that on a UHC program of any country, what are the ideal cancer care initiatives should reflect to be able to take care of the needs of the country like India from a cancer perspective? Your thoughts, sir?
I think Ayushman Bharat is a very good scheme. And today only we had patients in the OPD who had Ayushman Bharat scheme also. And he could get the entire treatment done at in a private hospital at a limited, cashless. And so he could afford that. That means that this is a very useful scheme for all the patients who are having this scheme, because I've been telling in AIMS also. I was Dean of AIMS, New Delhi. And so I've been telling in AIMS also, any relatives who came with the patient, that you must have Ayushman Bharat scheme. You must be under this scheme because this is a very useful scheme for all the patients.
But there seems to be some connection issue at your end. We can't hear you properly.
Yeah, that's right. Get chemotherapy, you can get surgery done, who can get, or elsewhere also. After retirement from AIMS, and what I'm finding here, because, hello.
Yeah, please keep going, sir.
Hello.
Your voice was not very clear in between, maybe because of connection. Please keep going.
Okay. Now, that is what I said regarding the treatment part, that Ayushman Bharat scheme has been proven very useful for the treatment of all the patients, whether in government sector or in private sector. Now, what I want to highlight is that awareness is very important, because I've been doing programs on television, for the last 30 years. And when the TV started in India, I've been doing programs on awareness, cancer awareness. That means on breast cancer, on lung cancer, on various types of solid tumors. Why I've been doing programs? Because I wanted people to be aware of these things, that why cancer, because a simple thing, even doctors are not aware. Let me tell you that a doctor I saw with breast cancer, and she said there was no pain, so I didn't like to come to the doctor. I said, what are you talking? Painless lump in the breast is the major symptom sign of breast cancer. So you must get the biopsy done. So people are afraid. And then another myths about cancer are there. People say if you do the biopsy, cancer will spread. Again, myth is there. So all these myths are still existing. And 1970s, when I did my graduation and post-graduation, that time also myths were there. And today, 2022, after 50 years, myths are still continuing. And we are trying to alleviate these myths of the patients, that it can spread from one person to another. Cancer is a contagious disease. So we have been trying to, dispel the myths of cancer. So what I mean to say is, number one, that awareness about cancer should be there, even in the urban area as well as rural areas. As told earlier by Niti Aayog people, that it was very nice that it should start from the primary health center. Now, primary health center also, people get cases, for example, cervical cancer or breast cancer. If you find a lump in the breast, we must teach them how to examine the breast and how to,
Dr. Chulka, again, we
do
are
the
not
self-examination of the breast. That is
Dr. Chulka, let me come back to you.
applicable to our country, and then they can go to the primary. Can you hear me? Actually, now it's all right. Is it fine now?
Yeah. I think we are back. Yeah, please keep on.
Yeah. Sorry for this. Actually, there was no electricity, so there was some problem. So now, what I meant was awareness about cancer has been a very important step in rural areas as well as urban areas. And once they are aware, we can detect the cancer in early stages and cure them. It is not a question of, we have to go in for palliative care. We have to go in for, of course, palliative care is very important along with cure. But cures are to the tune of, we have reduced the mortality despite the increase in incidence of breast cancer, which is the commonest cancer in India and abroad in the world. So what I mean to say, early detection is the hallmark to cure. So that is done by awareness. People come to the doctor and then they tell them what to do, and each doctor can send to a primary health center and send to regional cancer center. And we have 29 regional cancer centers now in every part of the state, in every state of India. And when I was Dean of AIMS, I was advisor to the Ministry of Health and Family Welfare on the cancer control programs. Now it is NCD, after that cancer control program. So what we used to suggest that right from the primary health center level, we should collect the patients in early stages, and not that, now in AIMS, when we used to get the patients, they used to get dates for say 2 months, 3 months. So we can't make stage 1 to stage 4 just because we don't have dates. We have a lot of patients. So what we used to say that, you try to work extra, we used to tell our residents, so we never wanted to delay the treatment, because stage 1, if we have caught a patient, he or she must be cured. So early detection is very important, and that can be done by more awareness in rural area and urban areas. So this is very important.
Sure, sir. Thank you. Thank you for your thoughts. I'll come back to you with the follow-up question. But let me go to the public health scientist among us, Dr. Priya. Dr. Priya, I was going through your profile, and you have done a lot of work in various universal health coverage programs in various countries with various organizations. So if I may ask you, how do you compare the universal health coverage program of India, which is PMJ, vis-a-vis other UHC programs in other countries, with respect to cancer care, very specifically, right? So if you can throw some light on that, would be very helpful. Thank you. Priya, over to you.
So thank you so much, Vaibhavji, and thanks to the IHCW Council for having me on this really interesting program. UHC has been in the public debate for a long time. It's actually started off as a movement, largely to tackle equity and inequalities in healthcare, both in relation to cost as well as in coverage. And I think where cancer is concerned, it's a moving target. I mean, just a few statistics to start off with from India as well. I mean, if you look at the Indian scenario today, in India, 1 in 9 people are most likely to get cancer in their lifetime. Among the top 2 cancers, you have lung cancer among men and breast cancer among women, which are the leading sites of cancer, if you were actually to look at it by gender. And the third is the incidence of cancer cases. The total number of cases are estimated to increase by roughly around 12.8% in 2025 as compared to 2020. So, this is cancer as a collective is a growing public health challenge. It's a challenge because it has large cost implications. It is a challenge because it has coverage implications. And it's a challenge because it's not adequately addressed at the primary level. So different countries have different UHC models, none of which are really perfect. So in terms of a case study, I think I'll come to the nearest one, which is our neighbor, Thailand. UHC was launched in Thailand in 2002, and when it was first launched, cancer care was really not included. From 2004, there was a rise in the number of cancer cases because there was greater number of surveillance done to see, to priority set for this UHC scheme. And from 2005, cancer treatment was included in the Thai UHC scheme, both due to high demand and also since then the cancer treatment network centers have expanded. So there are currently around 22 networks and 641 centers around the country. But what's really interesting about the Thai model is that the national plan integrated 6 areas of cancer control. And these included cancer informatics. So basically surveillance for cancer, epidemiological surveillance, primary care, essentially, prevention. So prevention at the primary level, early detection of cancer. So incorporating screening programs, then treatment, and then palliative care, and finally cancer control research. So they began to look at this as an ecosystem for this particular disease, largely because it is so diverse and it affects so many areas. And I think this kind of set them apart. Now, in Thailand, essentially, the health insurance system of Thailand pays for all the cancer care, and those with government insurance can go to any hospital, and those covered by what is called UCS and other social security scheme, they go to primary facilities first, and then if they are diagnosed, they are referred to the oncologist and the cancer center for treatment. But what was also interesting about cancer is a very, very expensive disease. So most people, do not do early screening. And by the time you get to the hospital, the disease is already onset. And that's when the financial juggernaut begins. I mean, the average cost of cancer, treating cancer, whether it's breast or even some of the advanced cancer in India, ranges from 5 to 27 lakhs. That's a large margin to really cover. So what they did in Thailand was basically, the provider was paid through diagnosis-related groups in a bundled payment. And standard protocols for priority cancers were developed subsequently in 2008 with the Cancer Association of Thailand. And now there are actually 12 cancer protocols in place. Payment for treatment is fixed, and it's based on diagnosis-related groups, which are inpatients, and fee schedules for protocol, which are essentially the outpatient. The fee schedule payment, interestingly for Thailand, was adopted from Japan. And where the price of high drugs was paid for separately. So the total cost of cancer treatment in the UHC treatment of Thailand is 6% of the total UHC budget. And this is about 2014-15 data, which is less than the total burden of disease in the country. So by integrating cancer care across different levels, to some extent, you're able to bring the cost down. But they also managed to tackle one of the biggest challenges of cancer cost, which is the cost of the drugs. It's one thing which is treatment costs. especially advanced tertiary care treatment. But the one that really hits you below the belt is the cost of the medicines. And that's where, there is a lot of impoverishment that happens across the ASEAN region, because I would compare India to its neighbors. And the UHC system in Thailand does not include all the cancer drugs that are registered. It has a benefit package. And it has more than 2,000 drugs registered in Thailand, where a total of 735 drugs are on the National Essential Drug List. And these are then subdivided into, from A to E, and different types of specialized medicines, including medicines that require pre-approval, are added to these lists that kind of build up. And for the reimbursement of really high priced anti-cancer drug, Thailand has something called a central bargaining system in place, with the central government procurement implemented for multiple lists. And this bargaining system then brings down the cost of many of the higher priced drugs. So that's how the Thai system is beginning to manage these escalating costs of cancer. I think as far as PMJY is concerned, it's a great scheme because it addresses impoverishment at different levels. But one of the things that I think people are noticing across the board in UHC schemes is cancer is usually addressed at the treatment level. And that's where the costs escalate, the drug prices come into play. And Thailand also realized it because its neighbor in Indonesia was also going through the same problem, and then decided to focus a bulk of their efforts on screening. So they identified the top 5 cancers, and there was a tremendous amount of efforts put on screening for breast cancer, cervical cancers, and colorectal cancers, based on WHO data as well as data from the country. So I think a large part of the PMJY's next effort would be to integrate the different components of a cancer treatment ecosystem and focus a bulk of their work on early diagnosis and screening, because that's where you can not only cut costs, but also catch the disease in a very early phase. So I'll stop over here. I hope I've answered your question, but I'd like to leave room for other people to make their comments.
I think you brought very important comparisons between 2 different countries or 3 different countries and how they are tackling this. But I think the sheer number of cancer patients in India, just sort of take away I think the good practices, which is a good practice in another country, but it doesn't really work in India. And I think that's where even PMJ is a very different UHC as compared to other countries.
Yeah.
And I think that's where we in our country have to find different solutions to really tackle this cancer menace in India right now. And at the end, you rightly pointed, I think from diagnostics to curative care to palliative care, I think that seamless integration is very, very important. So thanks for bringing those thoughts. Do we have Dr. Govind Babu?
Yes, I'm here.
Okay, sir, I can't see you on the screen, and hence I was asking. Thanks for being there. Dr. Govind Babu, I think again, you are a practicing physician. You are seeing the kind of cancer diagnostics facilities in the country, the cancer treatment facilities in the country. As a practicing physician, also sort of coming from a medical college and also a specialty hospital, do you feel that the facilities are comprehensive enough, or do you see a gap? And if yes, what are those gaps as per your experience, sir? Over to you.
Right. Thank you for that. And it's been great learning from what other people have been talking so far. And a lot of things are really true. But before I answer your question, one thing I must tell you is, cancer is such a preventable disease, and we've always been talking about head and neck cancers being the topmost in our country, and tobacco as the leading cause for this. Time and again, several committees have made pleas to the government to ban tobacco. I think that is for another day to discuss, but I think that is the simplest way that we can take care of head and neck cancers. So now coming to your specific question, Today genomics is the way forward in trying to treat cancers because this actually personalizes the treatment for all cancers and thereby also decreases the use of unnecessary drugs. We can use a drug that is going to be useful for this particular patient and avoid drug which is not going to be useful but may give side effects only. So genomics is becoming a very important part in the diagnostic armamentarium. And to quote one specific example is lung cancer. Till recently we were treating all lung cancers as one disease, but today we know that lung cancers are at least about 100 different cancers put together, and we've been able to find out through these genomic analysis that there are at least 50 different types of them, and for many of them we do have targetable drugs, and many of them were earlier being treated by just chemotherapy with some benefit but not great benefit. But because of the understanding of the genomics, today even advanced metastatic non-small cell lung cancer, which about 2 to 3 decades ago had a survival of about 8 to 10 months, today we are seeing them living for beyond 5 years, which we thought those days was just a science fiction, but today it's a reality. So this is important that these facilities are available everywhere. Till very recently, I was working at the Kidwai Hospital, which is a government tertiary care center, and I was there for almost 30 years. So I've seen the advances there. And fortunately, these diagnostic setups are being taken up very rapidly by even government hospitals. And Kidwai has actually established a very nice molecular lab, and the private labs are pretty expensive. So this lab in Kidwai is really very, very affordable. So we are able to do these genomic tests for most of our patients. In fact, they're doing it for patients from outside as well. So that becomes very, very affordable. So there is a gap, no doubt, but it is very rapidly picking up. And again, this is important that we bring about this awareness to not just the patients, but to oncologists, because many places oncologists are not aware of this, and more than that, the primary care physicians, because they are the initial people who see these patients, and if they are not aware of such advances that is happening, that will not percolate to the benefit for these patients. So from our Society of Medical and Pediatric Oncology, we've been doing series of awareness programs and CABs for the primary care physicians across the country. We have now covered about 10,000 primary care doctors across the country, and we are making them aware of at least the basic things what they should know, and not look at cancer with a very nihilistic attitude, because gone are the days when it was a death sentence. Today people can survive with all these newer therapies that are there. So we are doing our bit, and I think the gap is slowly getting closer, that these tests are becoming available to most of our patients. Thank you for that.
Thank you, Dr. Govind Babu. I think you have very beautifully summarized the current sort of treatment available in the country. And I think genomics, as you rightly pointed, and being a biotechnologist myself, I think I see, I did my biotechnology almost 20 years back. And I think that time we were talking about genomics being one of the treatment, for cancer. And I think today, as you speak, we see that as a reality. I think that's great to know. Thank you for that, sir. I will now come to Parag and Mr. Peter. I'll keep the best for the last. So, right. So, Dr. Parag, I think a social sector has a very important role to play when it comes to disease like, social organization, a disease like cancer, right? And the budgets are not going to be enough, whenever you talk about it. And Dr. Madan Gopal talked about, you can never have those 1 million beds for every patient in the country, right? So in such a bootstrap setting, in the country, how do you see organization like Japaigo playing role, in say cancer prevention or management? What more can be done? Any thoughts there, please? Thank you.
Yeah, thank you so much for this question, and thank you so much for this opportunity. Thanks to IHW Council. So I'm representing organizations, and my organization's name is little funny. Some people call it as Japaigo, some call it as JPIGO, some get Japaigo. So I'll just like to tell a full form of that. It's a Johns Hopkins Program for International Education in Gynecology and Obstetrics. The acronym of it is JPIGO. We are a Johns Hopkins University affiliate. Hello, is it on? Yeah. So, yeah, no problem. So I am representing JPIGO. It's a Johns Hopkins University affiliate. Thanks for that question, because when we are hearing to all these eminent panelists and many others who spoke before me, I was thinking that the best thing to share here is the story of our JPIGO's cancer programs. So JPIGO has been working in women's health for 40 plus years in 50 plus countries. And in India, we started in 2017 with a specific focus on cancer programs. And for India, the way we work is just align ourselves with the government priorities. And for Government of India, many of us know there are top 3 cancers, right? Breast, cervical, and oral cancer, for obvious reasons. And as per our name, we largely are the women's health advocate. We are the women's health organization. And on cancers, our specific focus is on women's cancers. And largely it comes to, we started our work in 2017 with breast cancer. And if I tell you in short, the evidences that are available around breast cancer in Western world are not at all applicable to Indian setting, because there, if the choice of diagnosis is mammography, in our Indian settings, it's actually the USG sonography, the sonography, the breast sonography, because of the different composition of the tissues. The other thing is that in Indian woman cancer, the breast cancer is coming a decade earlier because of the different genetic predispositions. So the first thing that we took up is the breast cancer. And we called our program as a breast health initiative, because in the screening programs, while you screen women, you actually will find out many other complaints for that woman. It's not only the complaints or the pain or the responses to that cancer positive or screen positive woman. You will also have to tackle others who have come positive during the screening initiatives. So what we started is to basically start identifying and start mainstreaming all of these things together. Now I'll tell you how we approach, right? For any work that we are doing, we essentially have 5 pillars. 4 vertical pillars, 1 horizontal pillar. When I say vertical pillars, the first one is simplifying complexities. Because we believe, we as a public health organization, our role is, we respect all our obstetricians, gynae-oncos, the senior most oncologists and everyone. But when I go to my director public health, when I go to my program manager public health, when I go to medical officer of a PHC, I can't tell too much about too complex things around this already a complex disease. So we largely play a role of simplifying a complexity, demystifying all those things. Now I'll just take a cue here and I'll tell you, and I guarantee you that you will remember these numbers for long. Let's say why cancer में काम करना इतना जरूरी है, ये अगर मुझे किसी को बताना है. The simple thing we tell them, 30, 60, 90. Like today, आज की हमारी maternal mortality जो है, वो है 1 लाख में से 97 महिलाएं आज भी इंडिया में गुजर रही because of maternal causes or causes of mortality. But total अगर हम annual हमारी death की proportion या numbers देखें, that is around 30,000. Now I'll ask you, what about cervical cancer? It is 60,000. देश में हमारे आज भी 60,000 महिलाएं are dying because of cervical cancer related mortality. Now you ask me about breast cancer. That is 90,000, around 90,000. In fact, more than that, as per the latest surveys and results, around 90,000 women are dying because of breast cancer, right? The investments, if you see, these are absolutely disproportionate, right? 70% of our public health infrastructure is utilized for RCH programs. Now, obviously, we have got the results. Our maternal mortality rates have reduced from 400 to now 97, as per the latest numbers. But even the investments right now are on those lines. Even one death is many, but the point I wanted to make here is that the proportionate investment should happen. So when we go to any advocate, any director, any manager, anyone on the field, we just tell them, sir, was 30, 60, 90, yaad rakhiye, and now you tell me how much attention you need to give to cancers. That is first pillar. The second pillar we do, and many of my seniors and other dignitaries spoke about awareness, screening and clinical breast examination and other stuff. Absolutely, yes. Because we have to stick to those basics, because these are the skills that we need to pass on to our practitioners, our ANMs and our frontline workers. But how do we do it? So there comes our role as a JPIGO as an organization. We have introduced humanoid models. Because see, we are talking here about the feel of the thing, right? We are not talking about कि मैंने बस देख लिया और बुखार है या नहीं. It's about how the lump is, whether it is really there, what is the size of the lump, And for that, many beautiful models have been prepared in the Western world. What we did here is we brought those models in Indian public health programs and have already rolled out them in 5 states. And now we have advocated in states like Odisha, states like Uttar Pradesh, where government is procuring these mannequins. The point I want to make is that you simplify things, but you also make it hands-on. Because if you don't make it hands-on, your screening is never going to improve. So I'm proud to share that Jopaigo is playing that sort of a role. The third thing that we do is diagnostic workflows. Because screen positive to aage gaon mein, uske baad kya karenge? It's a big, huge issue. If I am a diabetic positive, I know what is to be given. At least हमारे जो health worker, ANM या MO तो कुछ ना कुछ कर पाएंगे. But lung positive woman in a rural setup, what's next is a big question mark. So what we have done or what we are trying is to simplify these diagnostic workflows. Now here again, I'll go with some jargons and you will say there are too many jargons, but I'm telling you like these simple jargons have worked on the field. Now for breast cancer, if a woman is lung positive, just tell her, you have to remember palm, probe and prick. Now what is this? Palm is basically a confirmatory CB by your specialist gynecologist. कि आपके सामने अगर कोई महिला को लंप आता है, उनको किसी एक्सपर्ट के पास भेजिए और एक confirmatory CBE करवाइए, confirmatory clinical breast examination करवाइए, that is your palm. The next is your probe, that is ultrasound probe. Send that mother to some radiologist. And based on the findings of the probe, you will go to the prick. Prick is like a biopsy. Now that decision will be taken by the specialist, the respective specialist. So that sort of work, so what we have realized that if we simplify, demystify all these complexities, there are great takers there. There are great ANMs, great frontline health workers who can actually use it together. The fourth pillar is collaborations and partnerships. And I'm so happy to be here to talk to all of you, to learn with ISW Council and Rapid Global Alliance, because this is what is required. You cannot beat cancers alone. Not organizations as great as Indian Cancer Society or even the Tata Trust or Tata Memorials. Because cancer is a complex problem and we all have to come together and work as an alliance here. So the fourth thing that we do, and we don't go much into management side of it, but we definitely have tie-ups with institutes like Acharya Harihar in Cuttack.
Would you invest or where would you invest more in cancer prevention, cancer treatment? You are a CEO of your own company, co-founder. Treat yourself as that. And why would you? So the answer is very simple: cancer prevention, because then obviously you are reducing the people who would need care. Obviously from a pool perspective, and obviously more amount of money goes there. But how do we really ensure that while we are preventing the disease, we are also providing the care to the needy people in the country? So your thoughts there, Peter. Thank you.
I'll try to be as quick as possible because I
No,
think
please
we
take
have
your time.
time.
I can manage this organization.
All right. You can hear me? Yeah. How about this one? Yeah.
Take this
Okay.
one. Take this one. Okay, better.
Yeah.
Hello?
Yeah. Okay. So let me just throw a few numbers and then I will get into these questions. So today the PMJ is actually becoming aspirational for the middle class. Because if you really look at it, the poor today has a 5 lakh insurance. How many middle class families have 5 lakh insurance? Okay. So now PMJ is now becoming, Ayushman Bharat is aspirational for the middle class. The point I'm making is middle class has to step up. We can, and we must insure ourselves. Today, 94% of those who are insured, not many are insured, but even 94% of those who are insured are underinsured to the extent of 60%. Yeah. So we sleep happily thinking that we have insurance and that will take care of our needs, but all of us are underinsured. So we need to step up our insurance. So, so coming to that. Now, how does an Ayushman Bharat address the oncology, the cancer patients? The numbers say that about 6,97,000 procedures have been conducted under Ayushman Bharat in the last 1 year. And about 1,600 crores have been disbursed for that. So it is helping. Although it is not helping enough, it has started helping. Now, the middle class, the missing middle, which Niti Aayog was talking about, while government does its bit, I think we can do our bit too. We can step up our own insurance. That is one. Second, there are also many ways in which this terrible disease can be addressed. Another statistics is while around doctor mentioned about 50% of all costs are today out-of-pocket spend. In cancer, it is 75%. So 75% of the costs are borne out of pocket. It is not going from insurance. It's not going from corporate budgets. It is going from people's own pockets. How do you manage this? And that is why there is, terrible outcomes for families. So one of the ways in which it could be addressed is to try and take advantage of various schemes that are out there, even in the private. For example, Dr. Govind Babu talked about genomic tests. Genomic tests obviously are expensive. But how many of us know that these tests are today available on an easy pay option without interest? So you could buy that test without interest over a period of 6-12 months payment. Now, another aspect that I've noticed is when families address that, they say, okay, this is an expense I need to incur. Let me pay it out of my pocket. Okay, I have the money today. Let me spend it. But always remember that cancer is a very tricky disease. There will be other bills to pay. Okay, so wherever you have opportunity to spread your expenses through these easier pay options, etc., please take advantage of them. So that keep your cash so that there will be bills to pay again. And another thing is, while I am no expert on cancer and what should be the right diagnostics, all that I can say is, what I've realized is if you do the right diagnostics, the future costs will also come down because then you are targeting your therapy. The therapy really works
and then you have good outcomes. And even those what you call immunotherapies are today available on easy pay options and without interest, at much lower cost than what is the normal cost that the market bears. To give an example, I don't want to talk about organization, etc., but there are therapies that are available if you get into the right program. It's available at 1/3 the cost, of what others pay. It's available to you at 1/3 the cost, and that too without interest and over a period of time payable. So look at all these options so that you can treat your loved ones through their process. While it is a bad disease, there are plenty who goes into remissions. There are a lot of people who are living decades without disease. So it is not so terrible anymore. If we all put our mind to it, we can solve it. Then coming to where should we be spending the money, whether it's on diagnostics, etc. I think Dr. Priya, I think she made it so very clear that diagnostics obviously is important, but at the same time, spending the money in the right way after diagnostics will not only bring down costs overall, it will also cure and get the patient, completely cured of the disease. So I hope that. Thank you, Mr. Peter. I think what you mentioned about, we all know it is painful process, but I think keeping the cash intact is very, very important because you never know what next, right? Nobody knows actually for that matter, right? Nobody can be sure, but I think very, very, very useful pointers from you. But organizers are staring at me to close the panel now. So I'm sorry I wasn't able to come back with a follow-up question, but I'll definitely pick your brains through emails. So with that, I thank all my wonderful panelists, starting with Dr. Julka, Dr. Govind Babu, Dr. Priya, Dr. Madan Gopal, Dr. Parag, and of course, Mr. Peter. Thank you so much for your presence today and wonderful, I think, words of wisdom that you have provided to all of us. Thank you so much. Thank you, IW Council. Appreciate this. Thank you.
Thank you very much.
Panelists to please come and join us in front of the stage, and I would request Mr. Kamal Narayan, CEO of IHW Council, to please give our panelists a token of appreciation. We will be taking this discussion forward by discussing role of civil societies in responding to changing cancer landscape, improving access to high quality health workers and cancer health commodities, while also advocating for good governance and equitable health financing requires a vibrant and influential civil society and a network of health stewards to initiate discussion and reform. This session will center on methods for fostering productive collaborations among stakeholders involved in cancer control, such as the government, academia, industry, and global networks. It will also seek to explore crucial approaches and measures needed to create viable business plans and explore viable new sources of funding aside from the traditional ones in order to boost the functioning of the international cancer community. The moderator for this panel discussion is Ms. Urvashi Prasad, the Director of Development, Monitoring and Evaluation Office at Niti Aayog. Please put your hands, yes, please come and join us, ma'am. And our panelists, or I would, okay, so from Access Health International, we have Mr. Tushar Mokhashi. I would request you to please join us. Ms. Belinda Chan, CEO of Fiji Cancer Society. Fiji Cancer Society's prime role is on advocacy, awareness, and patient support. Please put your hands together for Ms. Belinda Chan. Next, I would like to invite Ms. Vandana Gupta, founder of We Care Foundation and Cancer Survivor. She has played key role in bringing global exposure and expertise for the organization through affiliations with American Cancer Society, International Kidney Cancer Coalition, Lymphoma Coalition, UICC. She will be joining us virtually. Next, I invite Ms. Poonam Bagai, founder and chairman of Can Kids, Kids Can, and ex-bureaucrat. Ms. Poonam Bagai is a cancer survivor. She is also a joint secretary of the Indian Cancer Society. In 2011, the American Cancer Society chose her to be a global cancer ambassador. And next, we have Mr. Ravindra Mohan, Director, Palliative Care Physician and NDPS Compliance at Canosport. He is an MBBS with post-graduation in palliative care from Flinders University, Australia. Very warm welcome to all of you. Over to you.
So it's really a pleasure to be moderating this panel on a very, very important topic, which is really the role of civil society organizations in cancer care. And I think, we've spoken through the day about so many challenges when it comes to cancer care, right from awareness, prevention, screening, then diagnosis, treatment. So there's really so many stages. And of course, you need medical support. You need financial support, you need psychosocial support. So, the dimensions of cancer care are so many that all stakeholders have to play a very, very important role. And in that context, CSOs, as we know, they do play a very
working closely with the hospital or the institution so that you're filling the gap. Working closely, let's say, also with the government, so you're filling a gap, right? Then comes the patient engagement piece, which a lot of people don't do, which is, am I actually patient-centered care? IHW talks more and more about that now. But are we actually keeping the patient at the center of care? And are we actually listening to the patient? So now, more and more hospitals are providing patient navigators. But in the absence of a patient navigator, you take poor people landing up in a hospital or hearing the word cancer. तो कमरा नंबर 13 में रेडिएशन होता है और कमरा नंबर फलाना में कीमोथेरेपी होता है. You don't know what we're talking about. How do you make sure that you engage the family, make them feel comfortable in a hospital setting? Do you have in our case, do you have a child life specialist? All that becomes important, right? We talk about patient-led advocacy, right? Now, again, in the West, you would see most CSOs, many of them would do a lot of advocacy work. In a manner of speaking, I would say IHW does advocacy work because you create forums whereby stakeholders can engage and talk together and actually say, okay, what can we do to drive policy change? So some civil societies will focus more on that, and some civil societies would focus on service delivery. We say awareness and health information. Dr. Govind Babu spoke about it. Dr. Julka spoke about it. And yet I can tell you that is truly a place where we are completely in a gap. People on the street only know cancer means mar jayenge. I have run this for 20 years, Urvashi, almost. And my house manager who sees me working at it says, पर अगर मैडम इलाज होगा तो वो तो विलायत में होता है ना, फिल्म में यही था कि वो अमेरिका में प्लेन में चले गए तो ठीक होके आ गए. So we're still in that space. And equally, we did a study recently in which we found that it was taking only 3 days median time for a child to reach, for a family to reach a healthcare provider. But it was taking 36 days median time for the child to get diagnosed. What is that telling you? It's telling you that forget about the masses, even the healthcare providers at the primary PHC level, CHC level don't know cancer के symptoms, कहाँ भेजना है, what is the referral pathway, where are the resources available. Again, I know the government is doing some great work now in terms of trying to build up the portals. And again, I think civil society organizations are sitting on so much information that we can share and that we can pull together so that this information is rapidly available. So what we do is every state, we are giving out resource directories. What are the services? What are the government schemes? Which are the hospitals? Who can you call up? And every 6 months, we put this out. Is it authenticated? Did the government of India give it? Maybe not, but it is still information that is important to put out there. So I have 4 more, if you have patience to listen to it. You asked me to set the stage. So stakeholder engagement. I think civil society organizations are very well placed. I can tell you from working in state governments, right? The state government thinks for private hospital wala is up to no good. The private hospital wala thinks the state government hospital wala is up to no good. Everybody thinks pharma is up to no good, right? But nobody is thinking ill of that NGO that shows up. So we have found that being in the middle of all of this is a very good way to bring everybody together in a non-threatening way to actually say, beech mein to patient hai. So we are patient advocates and we are speaking on behalf of the patients. So if you build up your patient voice and then you speak in behalf of the patient, nobody can turn you away. When my survivor is sitting at the table, all the stakeholders are listening. Because the survivor is right there. Who's going to tell the survivor you're talking nonsense? Nobody can. So building up patient voice is a very important piece that civil society organizations can do, and providing forums like this for discussion, not just of experts, but also of people living with NCDs. Very important. And again, something you will find not only the WHO, but at all levels we should be doing. You're calling me here is not just because I am leading an NGO. You're calling me here because I'm a people living with NCDs. I'm a cancer survivor. Vandana Gupta is a cancer survivor. Now, it puts us in our own position of strength. But as NGO leaders, we are working to build up this voice so that more and more people who are actually at the center of care can ask the questions of, can push and drive the change. Capacity building in the community, important. Patient-led research, also important. We mentioned earlier fundraising, right? If you're filling gaps, then NGOs are great for the fundraising space. The CSR, the Corporate Social Responsibility Act, has actually enabled NGOs to be able to raise funds. And again, we're filling gaps, right? So when I work with a state government, I'll tell them we are giving money for maybe some initial diagnostic. When I spend 15,000 rupees, you are spending 5 lakh rupees on that child. But if I don't give that initial 15,000 rupees for the diagnostic or the emergency medical assistance, then the child can't access your 5 lakhs. So we're actually working together, and we're not only fundraising through CSR, etc., to provide the support, but then we're working with the other stakeholders to make sure that we have access to the scales. So I want to end by saying that I think today, with Ayushman Bharat and what Niti Aayog is saying, and I'm not saying this because you're from Niti Aayog, but where we are in the cancer space, if civil society organizations work closely with all that is there on the table already, I think we can really, really make a difference.
Thank you. Thank you so much. And I think you've done more than, just set the stage. You've given us so many very, very important points. So, we'll just try to go a little deeper into some of these different aspects. And maybe next I'll request Ms. Vandana Gupta. If we can go a little bit more into the patient's perspective, which Poonamji also touched upon, and which is, as she said, at the heart and at the center of all of this. From the patient's perspective, what is the kind of benefit you've seen in terms of engagement of CSOs and indeed, even other stakeholders? What is it really that the patient needs or would like from the different stakeholders, which might be beyond, the obvious of financing and access to healthcare and so on. So if you can touch upon this a little bit and, give us more insights into the patient perspective, that would be very helpful. I think you're on mute.
Thank you and good evening for having us over for this important discussion. And I really feel that the fact that all of us are here together and that you are giving us a chance to talk and you're willing to listen, it's a step forward, which means that everybody is involved in patient care to a large extent, and patient has really become the focus. Unlike in the previous years when patient was not really, it was like, it's okay, the patient is there, but the schemes were what the government wanted or the hospitals wanted or something like that. So, if you start from the beginning, like Poonam mentioned, that most of our people who are working in the villages, and we know about 80% of the country resides in the villages, have doctors who are really not capable or not really understanding the cancer diagnosis. With the result, cancer diagnosis is given very, very late. And by the time the patient really comes to know that he has got cancer, he has already moved to stage 3 or probably stage 4. So I think one thing that all the patients really need to get are really, really talented and doctors who understand the disease, and for which there can be different courses conducted by the organizations, by the hospitals, by the doctors themselves, for the junior doctors who are coming up, and to say that, you want to nurture the future, that you want to improve the quality of care that is going to be given to the patients. So there it should start. And then, of course, we know that travel and accommodation and finances are a huge burden, but we never talk about insurance for the patients. none of the patients, I mean, we talk about the government schemes, we talk about Ayushman Bharat and the benefits it has given. But have we gone into the details of Ayushman Bharat? How difficult it can be at times for the patients, because whatever is approved, and please pardon me if there is something which is politically incorrect, but I'm just bringing out what should be said, because there are many medicines which are approved by Ayushman Bharat, but there are hospitals who have the Ayushman Bharat scheme in the hospital are not agreeing to you have that medicine in the hospital. So the patient goes thinking it's an Ayushman counter and that the medicine would be available to him. But the hospital says that we don't have it in our hospital. Now, what is the poor patient supposed to do? Again, there's a problem, and he is emotionally, unstable because of all this, because now he understands that the cost of the treatment would go up because he doesn't have the finances, and he had been told that from Ayushman Bharat he would get anything and everything. There are government, the insurance agencies which say that we are going to insure or give or provide insurance to the patients. But then when you go into the depth of the whole thing, they say that, there's one agency which has just come up which says that we will give the insurance to the cancer patients, but they will give it even if you're a cancer patient, but it is going to be valid only after 3 years of your treatment, of your being a cancer patient. Which is, like if I'm a patient today, then I'm going through my treatment today. I don't have to wait for 3 years to get my the insurance valid. Why is that so? Why can't we be given something? And for young children, I'm sure Poonam has faced this problem a lot, that they are not given insurance policies at all. So when the children are younger, they have a huge life to live. Here we are all working towards getting them to get a longer life. And then they don't even have an insurance to take care of their problems. Maybe you can charge a higher premium, maybe something can be done, but then that should be given. That should be the major thing. And I think all of us as NGOs or civil societies or people working as patient advocates have to work towards making patients very, very powerful. They have to understand that, we have to make them understand that it is your right to ask for things. Whether you are going to be involved in a clinical trial, whether you are going to be given some treatment, our patients are really scared to ask any questions from the doctors. And I think it becomes our role to make them very strong, to empower them with all this so that they can, or we can talk on their behalf with the doctors, which can be done in some centers, but may not be done in some centers. But I think it's very important that the patients know that all of us as patient advocates or as survivors are there to understand what they are going through. It's easy for us as survivors to understand what the patients are going through and to stand up for them. And the treatment aspects, the cost of the medicines are so high that I shudder to think that if I was to have cancer, where these molecules are going to be needed, how would I pay for it? So it's the same problem with the others, and they sell their jewelry and property and everything, and then they are able to maybe afford 2 months or 3 months of treatment. And if we can all work together for something like that, to work on the access of medicines, all the initiatives are a collaboration of the government, the doctors, the hospitals, and the civil societies. We all have to understand each other's needs and work towards that. So I would like to stop here and maybe carry on later.
Thank you so much. And thank you especially for highlighting some of the challenges, and actually that is a very important role that, people who are working on the ground, as well as CSOs, that's a very important function they perform. Sometimes you have programs and schemes, they are launched with the best of intentions, but we always need to make those constant improvements and course corrections. And also India, is not one country, it's so many countries in one. So we really need to make sure that any scheme that we're implementing, any program that we're implementing, we're able to make it effective across all the different states and districts that we have. So I'll take my next question to Ms. Belinda. Given your own experience of running a CSO, What do you feel have been some of the major challenges for you? And especially from the government's perspective, where do you think, there could be better engagement, there could be more support? What has been your experience in this regard?
Thank you. Firstly, thank you for the opportunity to be part of this summit. It's a real humbling pleasure of mine to be part of this. Talking to you from Fiji, where it's almost midnight Saturday. And listening to what's being shared, I see that despite the vast spread of India and the number of countries within India, our problems are very, very similar. The challenges we face are very, very similar from a patient perspective, from a clinician perspective, from a carer perspective, from just the family. And so for us here in Fiji, so what I'm going to talk about is what we experience here in Fiji. With government, right now, government is not, we've just had a change in government, and so the new government is now laying their feelers out and getting a feel of what's happening around the country. Prior to that, the last 16 years, we have seen the deterioration of our main hospital, which is based in Suva, which is on the main island of Viti Levu. In that, we don't have proper oncology services. Basically, everything has come to a standstill, and so the society has come in to help fill that gap in terms of procurement of medication, procurement of diagnostic equipment, providing patient support in terms of social support, transportation, ensuring patients turn up to their clinics. That we don't lose them. They're not lost in the system. They are able to make it to their clinics. So government has a big role moving forward now to play. They need to touch base with NGOs and CSOs and see how we could work together. There are 3 other NGOs that work in the health space, and although their objectives are not similar to what the society is doing, but they're still in that health space. And so the CSOs and NGOs here in Fiji have an important role. It's because of the relationship we have with our communities. We understand what the community are experiencing. We understand the challenges they face. And in particular, accessing health system. We understand their health literacy. It very basic, and that needs to be expanded on. We also understand the hardships that they face, which prevents them from seeking medical intervention whenever they're sick. Over the years, we have noticed that the Itoke, which is the indigenous Fijian people here, their health-seeking behavior is very poor as compared to our Indo-Fijians, which is the Indian community here in Fiji. They have very good health-seeking behaviors. That is very sad. We want everyone to improve their health-seeking behaviors, to access the services that are currently being provided free at no cost. Again, cancer treatment, very basic chemotherapy protocols, but it's available. There's surgery, there's chemotherapy, and that's it. But the thing is, people are coming in late. So education, government needs to ensure that messaging, standardizing of cancer messages out into the communities are simplified, are very similar, irregardless to which ethnicity that we take it out to. But they need to work together with the NGOs, because it is the NGOs that know what the needs, what the challenges are within a community. And so a very wide range of challenges out here. And I guess it's very similar to what you experience as well in India. We're fortunate that we don't get any funding from the government to provide these services, let alone procure chemotherapy drugs, diagnostic equipment for the hospital. But we have very good corporate support. So, we can see corporate as well playing an important role in lobbying to government with NGOs for policy change within within the cancer space. So it's not only us, we all can't do this work alone. We got to work with other partners, other stakeholders to actually get government to move along and then start changing the face of cancer here in Fiji.
Thank you. And you know, yes, while a lot of the experiences you've shared obviously is from your context, but it does apply in many ways, certainly to, you know, different parts of the country. Although, of course, in India, we have the added massive challenge of scale and diversity. But nonetheless, you know, a lot of these are challenges that are common. So I think it helps to, you know, learn from another context. I'll shift gears a little bit, and my next question is to Mr. Ravinder Mohan. And so my question to you, you know, given your rich experience in palliative care, and I think, you know, palliative care is something which, you know, there's still a perception for a lot of people that this is something you do, you know, at the end of life, right? This is something you do when you have no other option. And so I think, you know, it is really a field which I feel in India is not developed at all, you know, to the extent that it should be. And also the perception is very negative, you know, amongst a lot of people that, you know, it's something when you do when you don't have hope for anything else, when it's actually, you know, quite the contrary, and it's so much more related to quality of life and, you know, so many other dimensions. So what in your experience, you know, do we really need to do, and you know, how CSOs obviously can contribute, but even more broadly, to really strengthen this whole palliative care, you know, initiative in the country, and also take away this very sort of negative perception about it, that, you know, it's something that you only do as a last resort.
Hello, friends. I'm Dr. Mohan from Cancer Support, and we are a 26 years old organization. It's an initiative of a cancer survivor, Madam Harmala Gupta. We provide free home-based palliative care to cancer patients at their doorsteps. And we do this in Delhi NCR, Amritsar, Bathinda, Rohtak, Sonipat, Meerut, and Jamshedpur. And we don't charge any money from them. 2017, we got WHO award for our work, and the WHO recommends our model of home-based palliative care worldwide. To explain how it works, please permit me share a small story. I was caring for a patient in West Delhi. When the team went, the lady was tossing because of pain. I want to die. We gave her a small dose of oral morphine, and we are the biggest producer of oral morphine in the world. When her pain subsided, she took decisions. कि मैं जो खून मुझे हर दौड़ते चढ़ता है मैंने नहीं चढ़वाना है, because my uncle told my cancer is not treatable. Number 2, मेरा एक बेटा मेरे से 12 साल से नाराज है, मैं उससे मिलना चाहती हूँ. 2 बच्चे अमेरिका कनाडा में, उनसे मिलना चाहती हूँ. और मैं अपनी प्रॉपर्टी अपनी बेटों के बराबर हिस्सा देना चाहती हूँ. For a North Indian is unusual to hear. You'll be surprised when the family meeting took place. वो माँ और बेटा गले मिलके रोए, and we had to decrease the dose of morphine because pain was not only because of cancer. The lady was pain-free. She settled her economic issues. उनकी बेटी एक लड़के से मिलती थी, उसको घर बुलाया उन्होंने, शादी भी तय हो गई. And then she says, मेरे सारे now I'm pain-free. My all pending was settled. Now I'm ready to go to my guru. She died after 3 months, pain-free, with all pending issues settled. Her death was celebrated. So this is the magic of palliative care, which works only for those patients who join palliative care early at the diagnosis. If you send us, refer us your dying patients, probably it won't work. It works. And my message to the group is, please never get cancer treated without palliative care cover. Palliative care is a human right issue and it must reach everyone. We are working with Niti Aayog. We will be doing a small pilot project in Rohtak. इसी टिल सिर्फ शहरों में तो दर्द नहीं, दर्द तो हर जगह है. जब तक ये चीज ANMs और विलेजेस में नहीं पहुंचती, तो it's okay lecturing like this, but it must reach everybody. We are the biggest producer of morphine in the world, and if you carry a doctor prescription for morphine, 100 रुपए की दवाई के लिए 500 का पेट्रोल खर्च करेंगे, फिर भी morphine मिलने वाली नहीं है. We need to educate our doctors. Palliative care is here to stay. Of course, is important in cancer. In coming times, tsunami of old people is knocking at our door and we are deaf. Answer will be palliative care. So palliative care is here to stay, not only for cancer, for old age people, end stage of all diseases. Whichever specialty you work in, palliative care is there. So what cannot be cured can be cared for. And care has no end. We work for patients so that they live well and they live well. So palliative care has to be part of all treatments, whether it be COPD, end stage heart, psychiatric illnesses, or even accident victims. So scope of palliative care is tremendous. We are phone call away in the places I mentioned, and we visit our patient within 72 hours. And we use around 6 lakh tablets of morphine every year, free of cost to patient. We don't charge. Of course, richer patients we prescribe, poor patient services are free. We'll be reaching to more states gradually. Anyone who wants to start palliative care in his state, we are ready to help. Our dream is palliative care should reach everyone who needs it. It is a human right issue. It makes sense.
Thank you. I just wanted to add on palliative care, Urvashi, very importantly, that in India, it is the civil society organizations that push palliative care. And that I think is a big role that we have played. You know, I'm the vice chairman of Pallium India, and Dr. Rajagopal is the father of palliative care. Pallium India, the Indian Association of Palliative Care, many other NGOs that really pushed on this. The morphine regulations that eased out were completely hinged on advocacy. We also learned how to do good advocacy. I still remember we had this company that helped us in terms of how do you go and talk to members of parliament? How do you actually try to work to get the law passed? And I still remember that winter, there were only 4 things that got passed in the parliament, and our morphine was one of them. So, you know, the session is on the role of civil society, and a lot of the time in India, we're struggling so much with service delivery that most of us do a lot of work on helping families, helping poor families. But the role of civil society organization and advocacy is very important. The role that organizations like Pallium India play, which is on a pan-India basis, actually therefore making the voice of palliative care worldwide, right? Dr. Raj is recognized worldwide, participates in research worldwide, but that led to change in India. And on the same front today, when the government has finally brought in palliative care at all levels, at the PHC level, through the PMJ schemes, I think the challenge to civil society organizations working in the field of palliative care is now to work with the government to integrate palliative care at the PHC, CHC level. We all tend to talk only about the hospitals. But when the government has now enacted schemes that actually say that we can have palliative care at the PHC level, then this is the time for NGOs and civil society organizations to work with the government to make that possible. So when we say home care, sir, then home care should no longer be about, I went home in Delhi and were we able to reach that. Home care has to be, my child went home to his village somewhere in Bihar, and at the PHC level, was I able to integrate palliative care for him? Was I able to make sure that he got good palliative care, because the schemes are now there. And I think NGOs need to respond to that challenge well. Thank you. This is correct. So what we've also addressed is that while palliative care in India started within the realm of cancer, now more and more palliative care is also looking at non-malignant conditions, etc. Right? Thanks. Thank you. Thank you. Thank you for sharing that very important perspective. Dr. Mohan wanted to add.
Mr. She asked a question that a difference between palliative care and end-of-life care. Friends, is very different. Palliative care is not only end-of-life care. Palliative care is a bigger umbrella, and end-of-life is a part of it, but it's very important. When the cancer patient has lost all treatment options, end-of-life care should start, not that when he or she is gasping. बहुत कुछ लोग करना चाहते हैं, विशेष हैं वो पूरी की जा सकती हैं. Give that time. People want to say thank you, sorry, give them time. They want to plan their funerals, give them time. Let the people die at home their natural death. Death on ventilators and ICU is a torture. This torture must stop. End-of-life cancer patients should never be put in ICUs on ventilators. They would help other people. So this torture is not only emotional torture, this is also economic torture. And often our doctor colleagues are responsible for the torture. But hospitals are responsible for the torture. So when the patients cannot be cured, they should never be put in ICUs on ventilators. It's futile intervention at end of life. Yeah. But ma'am, very few people would know it. Yeah. People should know that when we withdraw a futile treatment, it's not euthanasia. Very true. There's nothing like active or passive. When a treatment is not working, it should be withdrawn, and there's nothing illegal about it. Don't put very old people who could love to die in hands of their near and dear ones with the tubes in. And a small story to share with you on end of life. I was caring for mother of IT professional. शाम को उनकी चाची आती हुई उसे गायनेकोलॉजिस्ट एट गुड़गांव अपनी माँ के दूध का ये सिला दे रहे हो माँ मर रही है और घर में रखा हुआ है she was CA pancreas who was pain free going down चाची है डॉक्टर है बड़ी डॉक्टर है रेडी ICU on a ventilator 2 days 4 lakhs and mental torture. When the family then finally decided, they Googled all around about palliative care and asked wherever they could ask, they asked about what cancer was doing, was it ethical? They even talked to the people in the US. They said which is the best place for palliative care. I told them UK and Australia, and US comes up, and we are the lowest, but some organizations do very well. Finally, they decided to take the lady out of the ICU against pressure from the family. And lady died at home, pain-free. And those economic tortures not only affect one generation, could even affect 3 generations. So we need to learn those lessons, putting very old people in ICUs. And people have a status symbol कि 20,000 के रोज के कमरे में रहते हैं उसको that money could be utilized by noting like organization who could probably better utilize it. Thank you very much. Yes.
Yeah. Sir, can we just take this offline? We're almost out of time. So we'll just finish with our panel. Mr. Tushar, sorry for keeping you waiting this long. But perhaps, you can just, obviously give your perspective, but also sum it up for us in terms of, where do you think we really need to go with respect to, these partnerships, CSO engagement? We've understood why they are critical, what areas they can contribute. But what do we need to do, if we need to take this next step in India's context? What are some of those things we should do to make this engagement more meaningful and to really make sure that CSO engagement, or I would say broader partnerships, between government, civil society, corporates, private, whoever that might be, how do we make those more effective and sustainable in our context? If you can shed some light on that.
Actually, Vandana is saying she can't hear at all. Can anyone speak? Everyone speak loud.
Okay. Yeah.
Yeah.
Please go ahead.
Okay. Yeah. So I'll touch upon 2 points. One is, of course, the partnerships that we're talking about, and the other point, since I come from a financing background, so I would like to touch upon the fundraising point as well, and a little bit about the financing of cancer care. So and partnerships, of course, are linked to these things as well. So I'll first, ma'am, if you permit, I'll speak about the financing part. Very quickly, I mean, during the entire day, and especially the previous session, and ma'am as well spoke about different which cancer care or healthcare is financed in our country. But the point that I want to make here is, see, we've heard that the government is spending through different schemes. Dr. Madan Gopal spoke about them. And then there is, of course, household out-of-pocket expenditures that are happening. Very inefficient way of spending. And of course, there are so many problems like catastrophic expenditures and impoverishment due to health expenditures. What I want to make here as a point, an important point I feel, is that the financing is very fragmented. And if we look at the basic principles or the functions of financing, I think pooling is one of the most important aspect of healthcare financing. Now, what is happening is, since there are so many different fragmented ways of financing healthcare, I think it gets diluted. The main idea of pooling is not just pooling the money, but pooling the risks as well, right? So when we pool the risks, what is happening right now is a lot of people who are suffering from common cancers or rare cancers. Rare cancers, of course, are not covered anywhere. And people end up spending a lot of money on rare, rare in the sense of numbers, just sheer statistics. They may not be rare cancers per se, but in terms of statistics. So what is happening is a lot of people are spending a lot of pockets, and there's no way that you can actually save them from financial hardships other than pooling the risks. Because the sick have to be the risk transfer has to happen from the young, from the rich, from the healthier people to the sick and poor, unhealthy people, right? So if that is not happening, then there's a problem. Now, there's another problem that we are seeing. There are a lot of cancer-specific health insurance and things like that coming up. Now, that's another fragmentation that we are adding up to, right? Then what good thing that the government is doing, I would say, is the government has started, and I don't know if there was a detailed discussion about it, but I think at the health and wellness centers, a lot of screening is happening. Though it is only for some common cancers, but still, I mean, they are common cancers, so the sheer numbers come from there. And I think in the future, there might be some expansion in terms of the coverage. What happens is, of course, you all know that early detection, and we have heard from almost everybody in this in the previous panels and on this panel also, is that the detection of cancers is very late in India. So, and maybe otherwise, I'm not a cancer expert, but if it is very obvious that if it gets detected early, not only the physical condition of the individual improves or can be made better, but also the financial or economical condition we can see a lot of financial hardship as well. So we at a lot of times we think we think about getting more money, but we also need to think, and I think this was said before as well, how do we reduce the costs? And there are different aspects of it. The important point that I want to also discuss is we have heard a lot about how do we raise more money. I want to step back a little bit and ask, do we really need more money? Of course we do, but do we have the capacity to spend it? That efficient spenders. We have data to see, at least from the government side, we can see, and in the private side, we don't know what's happening, right? How much does a small hospital charge for cancer care, and how much does a bigger hospital charge? There is no estimate available. There are very few studies that talk about how much does private sector charge for it, and there's a long discussion around it. So I would say this both. You need, of course, we need more investments in health, especially cancer care. But cancer again is a very, very in a way unknown territory. Very little is known about it. So if you don't know the details, and cancer is such a huge term, right? So and it was dealt with during the day. So the partnership point where I want to bring is all these sources of funding and the people who are working on the ground. This again is another type of fragmentation. Like the funding is fragmented, the service delivery also is fragmented, and everyone is working in different ways, in their own ways, and the need for partnerships is extremely important. That's why we are discussing now. I think Ayushman Bharat, we spoke about Ayushman Bharat in general, but I generally like breaking it up into the 2 or 3 aspects of it. We spoke about the health and wellness centers, but the PMJY, the way PMJY is engaging private hospitals in different states, I think it's a beautiful initiative, and we know that there will be problems, but those problems are on an ongoing basis being dealt with. So this itself is a large partnership which is happening on ground at the state level, at the ground level, where hospitals, small hospitals, big hospitals, they are all joining hands with the government. So that's one set of partnership. I think ma'am has mentioned about the civil society's role in all the different ways. So I think there is scope for partnership everywhere, and I think there are many partnerships that are happening. But again, I would say that central government and the state government should play that steward role and drive the partnerships, because I think another problem that we have seen in the PMJY is the trust issue. The private sector, and ma'am very beautifully put it, I think the most trusted partner is the civil society because of obvious reasons and the way they have.
And this was a point that I wanted to make, that though the civil society is and should be the trusted partner, because we don't have any particular affiliation to anything but the patient, right? But I think, and this is something that I wanted to actually say, that while the civil society organizations in India are playing a big role, the government needs to start taking the civil society organizations more seriously, making sure that they are also part of stakeholder dialogue. And often they don't. They'll call the doctors, they'll call the hospital, call the scientists, they'll call the researchers, and the civil society organizations that are actually plugging huge gaps are often not invited to the stakeholder. So thanks for raising that point. So we can tell Urvashi and others that whether it is Niti Aayog, whether it's the Ministry of Health, there is a real role for formal engagement with civil society organizations, because we do play a very big role, whether it is in providing the funds. You said, why do we need the funds? Yes, we do. I mean, there is a gap. And as I said, it's a multiplier. I can spend 20 rupees, but without my 20,000 rupees, sometimes the patient can't get access to the 5 lakh rupees, right? So I think that's very, very important. That, there is a role that a civil society organization plays in stakeholder engagement, and that role needs to be recognized by the government. Yeah.
Another point that I think it was 2014, 15 or before that, when actually this exercise was done. That was the time when government always used to be a little apprehensive in partnering with the for-profit private sector. There's a report that was actually being done by the Ministry of Health and Family Welfare, which has a detailed guideline on engaging the not-for-profit. I think I would say that, ma'am, I worked for 8 years, around 8 years earlier in my career. I've seen and spoken with the policymakers who have always shown and loudly spoken that the NGOs or the civil society is a more trusted partner. But I would, my personal opinion is that both for-profit and not-for-profit sectors should be seen as partners, because the government alone cannot do everything. It's very clear, and we have understood that. So, couple of more points on reducing. I think it's important that cancer care, and this point was also made before, but I would still want to reiterate here. Reducing the costs of cancer care is not just by, it's not going to just happen by regulation. Here also partnership is important. We have to bring industry players on table how to reduce the cost. I'm sure that it's a very ambitious statement, but I think there is scope, and the private sector would definitely like to come down a bit when they see the volumes, and I think that's tried in other places. I think cancer care also, it can be tried, and that's another scope of partnership.
National Cancer Grid is paying quite
Right, ma'am. And yeah, and my last point is about the newer initiatives. I think there are in cancer care, and I mean, especially in cancer care, newer technologies, newer drugs, they come up and they are very exorbitantly priced. Now, I think that's where again partnerships would play a role, and that is where maybe the whole, I think the main part has to be played by the government, but the other players also have to reach out more, publish more, write more about it, so that it is evident to the entire research community, practitioner community, that the civil society is working a lot on certain aspects. Because what we have seen is many civil society organizations do a lot of work, but there's hardly any awareness about it in general public and the people who work in public health. And so that again has to be told. We only know very few examples which have have a larger, bigger name, but so many others who do a lot of work, and publishing or writing about their work is important and should come across. Thank you.
Thank you so much. And we're well over time, so unfortunately we'll have to end this panel. But I think everyone would agree it's been a really insightful discussion. Thank you to all our panelists, those who are here with us, those who joined virtually. Thank you very much.
Thank you so much once again to all our panelists. I would now request Dr. Nalini Kaushik to please come and give a token of appreciation to all our panelists. And I would request you to please step down, but be right in front of the stage with us. Thank you. Thank you so much. And now I would request Mr. Kamal Narayan, CEO, IHW Council, to give an introduction of Rapid Global Cancer Alliance.
Hello. In addressing this challenge which we are talking about today, the menace of cancer. You all have been seeing, and I'm sure would be curious about that, what this Rapid Global Cancer Alliance is and what it stands for and what we are trying to do with this initiative. So let me take you through what Rapid stands for. And I will be little, kind of quick because I can be, cognizant of the fact that we are already running late. So as we have already kind of mentioned to all of you that IHW Council stands for core philosophy of that health is the fundamental right of health. As our speakers also discussed and talked about, palliative care is a human right issue. Similarly, health is the human right issue. It's a fundamental human right. And to address anything and everything that hampers human health, it is important for us to join hands in a concerted manner to address that challenge. I'm here, we have been hearing a lot of numbers since morning, but just to kind of review and revisit those numbers, I'm, kind of putting these numbers in front of you. 10 million deaths globally. This was a number 2020 number for cancer deaths. 10 million. In India, we have been hearing these numbers, 1.39 million. So almost 14 lakh people are diagnosed of cancer, out of which 0.57 million, is the expected number by 2023. The number of deaths which we see is almost 7.70, means almost 8 lakh. That's the number I was also quoting at the beginning of this session. When it comes to India, we are seeing almost every second person is dying of cancer after diagnosis. Certain period of time, whether they get treatment, whether they don't get treatment, but the end is this. We look at the West, they have much bigger burden of cancer, much more number of people are diagnosed of cancer, but the death rate is much more lesser. Why we have such a massive burden of death or disease, and as we go forward, it is going to only increase. We have a system which is, in a way, not working in tandem. There are many links, there are many parts of this whole structure, the whole cancer care system, from screening of a prevention to palliative, but all of that somehow not working in tandem, and that is what I think we have been discussing all through the day. There are so many great efforts being put by many institutions, by many individuals, by even governments. We heard about states having provisioned cancer care to the district hospital level. Many of them, we heard about those states as well. So somehow we need to kind of bring together all those efforts and make this process go more efficiently. If you these numbers sometime become a very as we also heard some of the speakers saying that we have gone deaf in terms of about these numbers. They don't register in mind anymore. So if I break these numbers down and can give an image, imagery of, all of you know that when a plane crashes, it becomes a massive global story. Every media, everyone gets shocked when a plane crashes. And with a average 180-200 passenger traveling in a plane, in a Boeing, actually almost 11 Boeings are crashing every day. And that's the number. And that is happening in India. 11 Boeing full of passengers crashing. And when they crash, they are not crashing alone. The whole family crashes. They leave behind them massive burden of, emotional, social, and so many other consequences. So rapid is a thought which is emerging from the two sides of this whole system. And we have looked from the two sides of cancer care. One is the people side of cancer, care or cancer prevention, how people should look at cancer as a disease. We have gone through, we have came out of a pandemic, and we have behaved in a certain manner. We have looked at the pandemic at a certain manner. We have seen very closely how everyone can be afraid of something. And that's what pandemic has told us. So similarly, for people, these are the 4 points. The first of all, everyone has to realize that cancer can happen to anyone and everyone. The problem is that many times we do not believe on the fact that we too can, or I too can develop cancer. If we look at the pandemic, experience, everyone was afraid of the fact that they can get COVID infection. And that is why we were behaving in a certain manner for prevention, for treatments, or even for, other aspects of it. So realize, R stands for realize, act now. Once you realize it, and the action will only happen when you have realized that something can happen. Once you realize that cancer can happen to anyone, then act for prevention, screening, examinations, testings, whatever. You have to work for, act for the prevention. Then comes the third more important and very important aspect, practicing healthy habits. We talked about, tobacco cessation. We talked about, reducing alcohol consumption and many other factors, eating well, sleeping well, exercising. All that is important when it comes to preventing cancer. So practice healthy habit. P stands for that. I stands for inform others. Once you have realized, you have acted, and you are practicing, also educate others. That is every person should start doing that. And when we are doing these four things, we are able to defeat cancer. That's what RAPID is for the people point of view. Then comes who are the providers point of view, the people, those who are provisioning for cancer care, those who are provisioning for cancer prevention. The most important part, and which has been one of the highlight of many of the sessions, is that, recognize for, participation of the patients. So we have to recognize the role of the patient. We have to put the patient at the center of everything. We have to plan the cancer prevention to care to palliative, everything in a manner where it is meant for that patient. Many times when we provision healthcare, we forget the challenges, the pains, and then the problems being faced by patients and their family. The second important thing for those provisioning care is awareness. They have to invest in awareness. Awareness is something which is consistently and continuously need to be strengthened. The third is the partnership. Many of us, many of the institutions, many of the civil society organizations, many of the corporates, government, they're all working in different silos. So we need to come together and foster partnerships for that. And the third, improvising and decentralizing cancer care. We have seen, though recently we have also seen the cancer care getting a little bit more decentralized, but still a lot of that is still concentrated in large cities and certain centers rather than being accessible and available to the people across the length and width of this country. And when we do these four things again, recognize, on awareness, partnerships, improvise, then we are able to defeat cancer from the provider side of it. So if we put these 2 coins together, this is how it looks like. So RAPID for people. Without people participation, we cannot address this problem. We cannot provision, we cannot make, every center, every PSC, every CSC equipped for, all kinds of cancer care, because ultimately you also have to look at the cost of doing all that. And more than that, cost of, the cost which you incur on your own health, on your body. So people have to realize, and that's why the people side of it is very, very important part. And then only efficient provision for healthcare can be done. So what RAPID, when it comes together, RAPID is for the people, for the providers together, and with a sense of urgency. Why RAPID? Because we have to be rapid against cancer. Otherwise, it is getting rapidly and catching up with us. 8 lakh today, maybe 9 lakh next year, or 10 lakh year after, and it is going to come to all of us. So we have to be rapid against cancer for the providers, for the policymakers, for the people, everyone. And that's why it's RAPID. And what RAPID tries to, do is 3 major things first. Rapid access. We, through this institution, are going to endeavor for rapid access for screening, rapid access for treatment, rapid access for care, and also rapid access for even a lot of therapies, devices, drugs, which are there, can get a rapid access to the patient, and patient can get a rapid access to that. You all know that in general, a new drug or a cancer drug 6 to 13 years to reach to the market, including its development time to regulatory to all that. The second important thing is rapid uptake. We do see that there is a lot of new therapies, new mechanisms are available, but they are not being kind of taken up, or there is very less uptake of that, mainly because of lack of policy, lack of drives, lack of intent for that matter. So, kind of facilitating rapid uptake of that, and also rapid adaptation of the system, the modifications that are needed in the policy, in the system, in the care infrastructure, that also need to be done in a rapid manner. And that's what the three major pillars we are going to focus on. Going only forward. Okay. So how do we, wish to achieve this is another rapid aspect of it. R stands for reaching out as many stakeholders, people, institutions, policymakers as possible. Building a very strong advocacy around that under the umbrella of this rapid thought. Fostering partnership so that different stakeholders, different institutions, different organizations are interacting with each other and also trying to tackle this problem together. And institutionalize. One of the gap which we saw is that in India we don't have a very focused institution which works with all stakeholders when it comes to tackling a major menace like cancer. You see UICC being a global institution, and we will be observing World Cancer Day tomorrow, which was an initiative by UICC. It's based out of Geneva, the Americas and then European countries, and also a lot of focus in Africa. But when it comes to in countries like India, we don't see much of that happening here. So there is a strong need of an institution which works consistently in this space. So one of the focus of RAPID is to institutionalize advocacy with all stakeholders in the space of cancer. And then the fifth and most important thing is to deliver. So not only build awareness and advocacy, but also try to achieve some kind of measurable outcomes out of it. As an institution, we intend to bring together all these stakeholders, both from the demand side and both from the supply side, and the users in between, patients and their families, very important, and that's why they are the first stakeholders for us. And as we go forward, we saw some of the survivors who are working very strongly in the area of cancer prevention and cancer, management, bringing them together, clinicians and diagnostics, fraternity, policymakers at all levels, pharmaceuticals and other, companies, from the devices to other peripherals, scientists, experts, alternative funding entities. So we heard some of the institutions talking about how a genome test can be achieved or can be done on a zero payment, interest EMIs also. There are institutions that are working on that, and also organizations, doctors, medical institutions, elected representatives, media, to give edge to our advocacy, academic institutions which are involved in research and other part of this, and patient support groups. So all of them together to build a strong advocacy business. I'll be quickly running through. We have given a brochure and the booklet of RAPID. You can all read it in more detail. So building a global network, collaborate for a global alliance, connecting with all stakeholders together. Programs like this are meant for that, and create a lot of digital footprints so that we are also able to fill that gap of accessibility to right information. That is one another gap for the patients when after you have been diagnosed of something called cancer. There is, always you find that there are multiple gaps in terms of navigating that sometime overload of information which, is thrown by the Google, or, the sheer panic which sets in after, you get into this aspect. So create and then sustain. One of the focus we will be putting on that how we sustain and help this whole advocacy. Along with that, also help many of these patients group or institutions or even individuals in navigating and accessing the care through multiple other initiatives like fundraisings and all. So the work so far we have already done. It's been the Rapid Global Cancer Alliance was conceptualized and initiated almost a year back now. We are about to complete a year. ISW Council as umbrella organization has been strongly taking forward the advocacy aspects of so awareness. In the last 9 to 10 months of Rapid, we have focused a lot on awareness, done a lot of work on advocacy, and also on the policy level. One of the example you see is that the recent report by the Parliament of India done by the Rajya Sabha, the cancer care management report, which was initiated by the Parliament, which also asked government to work towards making cancer care more affordable. They reached out to Rapid Global Cancer Alliance and also ISW Council for the inputs so that this can be achieved. We, our advisory board, who are the expert in this space, have given our inputs, which have been published in the report. The report, you can access that report on internet also. Apart from this, many other initiatives which were taken. We have built a very strong initiative on the breast cancer space, even making 20th of October as the Breast Cancer Action Day. We believe in certain spaces, and especially in the area of breast cancer, we have to go beyond awareness. We have to now get into action. Some of those glimpses of what has been happening in Rapid in the space of both building awareness and advocacy. This is an organizational structure, starting from advisory group to having a sub-country chapters, a team of global experts, country advisors. A lot of that is still in a formation mode. Some of the people involved right now as an Apex Advisory Committee, Dr. G.K. Rath, Dr. Hars Mahajan, Dr. A.K. Vaid, Dr. Sirohi, Dr. Ravi Mehrotra, representing the various aspects of it, is still, in a building phase. We also have several honorary advisors who are important stakeholders in this space. So with this, I would like to conclude this with a message that we all need to come together rapidly for Rapid Against Cancer movement. And with this, we have distributed this, one of the, also a feedback, what you heard, do you feel, because what we believe, we cannot build this institution without not only participation, but also without the inputs and knowledge sharing of our important stakeholders. So this form will help us a lot in terms of understanding your opinion on that, how we can make it more effective. So please do take out time and fill it. We will collect from all of you this form. And please do spend some time going through this document, which has detailed the elaborate strategy about how we wish to take this movement of being rapid against cancer. Thank you so much for all of you for being with us for the whole day. Now, as we have also initiated, we believe that recognition and appreciation works a lot in terms of making something go faster, making something go better. And for that, and with that, we have also initiated awards. Many of the institutions sent their entries. It was an open entry process. Our board of advisors and jury members, they have diligently gone through all of that. And with that, they have also reached to the conclusion of awarding some and may not be awarding to some, but all of you who participated in the process have really done something, and we need to keep increasing what efforts we are putting. And for those who will be getting recognized today, congratulations to them, and we wish them all the luck for even better efforts for the next year. Thank you so much.
Like Sir said, we have now come to the most anticipated part of the evening, the Cancer Care Award ceremony. It is a pleasure to introduce these awards as part of our Cancer Summit this year. The aim of the awards is to commemorate path-breaking and innovative breakthroughs in cancer care and research. We sincerely hope that these awards and honors will go a long way in motivating all the awardees to continue with the excellent work that they are doing, while also inspiring others to make a difference in the lives of others through their unique and pioneering efforts. So let's get the first category. To give away the first 6 awards, I would request Mr. Kamal Narayan, and I would request Dr. Suvarsha Khanna. But in the meantime, I would like to say a heartfelt thank you to all of you for taking out your time and joining us here today. It was a very eye-opening, informative, and a lot of great conversations also happened on stage and off stage, which we will definitely carry forward post the awards. But just wanted to say a quick thank you. And we will be continuing with the awards in just about a minute. As you can see, I'm also leading with the flow. I would actually request Mr. Vivekanand Mishra and Dr. Nalini Kaushik to please come and join me to give the first few awards, as Dr. Khanna is not in the room with us. When she will be here, I think she will join us. Yes, please. Okay, now we can all show a little bit of excitement since we will be giving away the awards now. Let's break this mundane. We'll start by giving you a round of applause, waking the muscles up. Yeah? All right. Okay, ladies and gentlemen. So the first award, Clinical Research Award. The Clinical Research Award recognizes individuals whose research in cancer care has significantly and positively impacted the oncology patient, family, and the wider community. The Silver Award in this category goes to
The Silver Award for the category Clinical Research Award goes to Dr. Wasim Abbas for his project Hyperprogression After Immunotherapy.
Congratulations, Dr. Wasim Abbas. The project Hyperprogression After Immunotherapy showed hyperprogression in real-world data settings and in Indian patients. Congratulations to you.
The Silver Award for the category Clinical Research Award goes to Dr. Wasim Abbas.
Yes. Okay. Our next award, Catalyst for Innovation in Early Detection and Diagnosis. This award recognizes individuals who have acted as a key catalyst for promoting innovation in early detection and diagnosis of cancer. And this award goes to
The Silver Award for the category Catalyst for Innovation in Early Detection and Diagnosis goes to City X-ray and Scan Clinic for the project Complete and Multimodality Confirmation and Early Detection of Cancer.
Congratulations to City X-ray, Scan and Clinic. We have their team here with us. Congratulations. Our next category is Catalyst for Innovation in Cancer Treatment. This award recognizes innovation in cancer treatment that have helped benefit cancer patients all across India. The Bronze Award, this award goes to
The Bronze Award for the category Exceptional Contribution to Cancer Health Services During Crisis goes to Pattern C2 Biotechnologies for the project Cancer Diagnostic Transformation using Digital Technology and Tumor Biomarkers.
Congratulations.
Bronze Award for the category Exceptional Contribution to Cancer Health Services During Crisis.
Yeah. The next category, as you heard, Exceptional Contribution to Cancer Health Services During Crisis. This award honors those who have worked hard to close populations of India. And this award goes to
The Gold Award for the category Exceptional Contributions to Women's Cancer Care and Management goes to Dr. Rama Joshi for her project Outcome Analysis of Uterus-Confined Endometrial Cancer Patients Undergoing Robot-Assisted Surgery.
Exceptional Contribution to Cancer Health Services During Crisis. This award honors those who standing gaps in access to preventive and high-quality health care among the marginalized populations of India. And the Bronze Award goes to
Pattern C2 Biotechnologies for the project Cancer Diagnostic Transformation using Digital Technology and Tumor Biomarkers.
Thank you. I would now request Mr. Kamal to please come and join us on stage. Yeah, no, like, all of you will stay, it doesn't matter. Moving forward, exceptional contributions to women's cancer care and management. And the gold award goes to
women's cancer care and management goes to Metropolis Healthcare Limited for their project OncoMed.
We have Dr. Khanna back with us in the room. I would request please come and join us on stage to give away the next set of awards.
The Gold Award for the category Exceptional Contributions to Women's Cancer Care and Management goes to Metropolis Healthcare Limited for their project OncoMed.
Thank you, Mr. Vishwa, and thank you, Dr. Nalini. Next award, the most impactful cancer awareness campaign. This award recognizes those that have created the maximum impact in cancer care. This category of awards appreciate the efforts made.
The Bronze Award for the category of Most Impactful Cancer Awareness Campaign goes to Brand Care Medical Advertising and Consultancy for the project #Men4Pink.
Their project #Men4Pink aimed to drive proactive, preemptive action against India's breast cancer burden by getting the women screened during Breast Cancer Awareness Month in 2021. Congratulations to your team. And the silver award in this category goes to
The Silver Award for the category of Most Impactful Cancer Awareness Campaign goes to OnQuest Laboratories Limited for their World Cancer Day 2022 campaign, Ignorance is Not Bliss.
their project World Cancer Day 2022 campaign, Ignorance is Not Bliss, was aimed to emphasize how important the screening is and how to overcome the same if they get timely screening done. Congrats to the OnQuest team. And the gold award in this category goes to
The Gold Award for the category of Most Impactful Cancer Awareness Campaign goes to Cipla Limited for the campaign Care to Cure.
The campaign Care to Cure has reached a 12 million audience with an awareness message about the importance of early detection of breast cancer through TV, social media, and print media. Congratulations to the team Cipla. Moving on to the next category, the most promising cancer centers and hospitals. This award honors those who have worked hard to close long-standing gaps in access to preventive and high-quality healthcare among the marginalized populations of India. And the award, the silver award in this category goes to
The Silver Award for the category of Most Promising Cancer Centers and Hospitals goes to Yashoda Super Speciality Hospital and Cancer Institute for providing accessible and affordable cancer treatment.
Congratulations. Our last category for this evening is excellence in promoting integrative health in oncology. This award honors those individuals and organizations that have made a significant contribution to cancer care and management, either in the field of naturopathic medicine, chiropractic medicine, holistic nursing, mind-body research, acupuncture, consciousness and spirit, public health, and policy related to integrative health medicine. And the silver award in this category goes to
Silver Award for the category of Excellence in Promoting Integrative Health in Oncology goes to Kiera for being India's first integrative oncology solution that provides evidence-based complementary therapies alongside means for treatment.
HERA is India's first integrative oncology solution that provides evidence-based complementary therapies alongside mainstream cancer treatment. Congratulations to your team. And with this, we have reached the end of the award ceremony. Many, many congratulations to everyone. Would you like to sum it up?
Thank you, everyone, for your being, here and patiently going through all the sessions. And congratulations to all those who have been awarded for the first edition of Cancer Care, awards. With this, we look forward to meet you again on various other occasions and also work together with all of you for Rapid Global Alliance. Please join us for tea. Wish you a great evening ahead. Thank you.
Thank you so much, ladies and gentlemen. It was truly an honor for me to be here amongst all of you. I also learned a lot. Please, like Sir said, join us for high tea outside and have a very lovely evening ahead. Thank you.